Morning everyone. I declare open this hearing of the Senate Community Affairs References Committee inquiry into the Supported Home Program. I begin by acknowledging the traditional custodians of the land on which we meet and pay my respects to their elders past and present, and I extend that respect to Aboriginal and Torres Strait Islander people who are joining us today. The committee will be conducting today's hearing via video conference and in person. I'm Senator Penny Orman-Payne, Chair of the committee, and I have with me Senator Askew and Senator Ananda Raja, and Senators Antic, Whittaker and Ruston will be joining us via video conference. These are public proceedings being video streamed live via the Parliament's website, and a Hansard transcript is being made. I remind all witnesses that in giving evidence to the committee, they are protected by parliamentary privilege. It is unlawful for anyone to threaten or disadvantage a witness on account of evidence given to a committee, and such action may be treated by the Senate as a contempt. It is also a contempt to give false or misleading evidence. Witnesses also have a right to request to be heard in camera. If a witness objects to answering a question, they should state the ground upon which the objection is made, and the committee will determine whether it will insist on an answer having regard to the ground which is claimed. If the committee determines to insist on an answer, a witness may request that the answer be given in camera. I remind senators of their obligations under the Behaviour Code for Australian parliamentarians to treat witnesses with dignity, courtesy, fairness and respect. And I remind committee members and witnesses who are appearing via teleconference and who are not speaking, if you could please mute your microphone. I now welcome representatives from Limbs for Life and the Australian Orthotic Prosthetic Association. Thank you very much for appearing before the committee today. I understand that information on parliamentary privilege and the protection and obligations of witnesses giving evidence to Senate committees has already been provided to you. For the Hansard record, I'm going to ask each of you to please state your full name and the capacity in which you're appearing today, and I'll start on my left.
Thank you. Melissa Noonan, CEO of Limbs for Life, as a person with lived experience and also representing the Australian community of amputees. Thank you.
Louise Pulai, Policy Advocacy and Research Manager from the Australian Orthotic Prosthetic Association.
Jessica Landers, Chief Executive Officer of the Australian Orthotic Prosthetic Association.
And Paul Sprague, Member of the Australian Orthotic Prosthetic Association.
Great, thanks very much everyone. I'm now going to invite someone from each of your organisations to make a short opening statement, and then we'll go to Senators' questions, and I'm going to start with Ms Noonan.
Thank you. Limbs for Life was established more than 20 years ago to provide support for people both pre and post amputation in Australia. We know that due to chronic illness, peripheral vascular disease, diabetes, etc., along with infections, that the incidence of amputations are increasing across this country. Accessing funding and supports for people over 65 is often onerous, time-consuming, and causes a lot of grief and barriers, in the sense that delays for accessing my aged care takes a long time, sometimes up to 12 to 14 months. But in addition to the time constraints and barriers, there's a range of different funding streams which impact our community. For example, prosthetic limbs are funded by states, but only 2 out of those 8 states and territories provide individuals with the opportunity to see a provider of their choice. Many of them cannot access the supports and services through that scheme that they need. For example, technology has increased significantly over the past 15 years. However, funding under the state schemes has not. We know that in a recent survey that we undertook, a national consultation with Monash University, that 19% of amputees over 65 reported requiring hospitalisation due to falls, primarily because the prostheses that they were using did not have the technology available to prevent some of those from happening. There's a lack of consistency across the country, and that I think that for many people, even understanding and accessing services and supports is confusing, especially at a time of trauma. We know that the aged care system requires people to, or wants people to live independently in their home for longer, but accessing those services, and in order to do so, is quite onerous. In addition, the length of time that it takes impacts people's mental health. For example, I spoke to a gentleman last week who was an above-knee amputee resulting from cancer. He's 68 years old. He wants to get back to work. He feels like he was messed around and confused by my aged care for over a month, only to find out that accessing the supports and services he needs to return to work are going to be lengthy and onerous. He needs a left foot accelerator on his vehicle so he can safely drive. He also needs a fit to drive assessment from an occupational therapist, along with additional driving lessons. So the longer he's out of the workforce, the longer it takes for him to regain that independence. Impacts his mental health, but he can't contribute to the economy either. So there's a myriad of things that I suppose affect our community, but I think any services and supports which can be expedited, it helps people to recover a hell of a lot quicker than they otherwise would.
Thanks, Ms.
Thank you.
I'm now going to go to the Orthotic Prosthetic Association.
Thank you for the opportunity to appear today. I would also like to acknowledge the traditional custodians of the land on which we meet and pay my respect to elders past and present, both here in the room or watching online. So as the peak body for certified prosthetist orthotists, we represent a small, unique profession. So our 620 certified practitioners provide orthoses, prostheses and clinical care that enable people to stand, walk, transfer, shower and remain safely at home. They also allow people to remain employed, engaged and embedded in their communities. So AOPA supports the objectives of support at home. Unfortunately, through this scheme, older Australians do not currently have a reliable pathway to orthotic and prosthetic care. This is because certified orthotist prosthetists are not explicitly included in the service list, and most lower limb orthoses and all prostheses are excluded from the ATHM list. So despite the guarantee that people would be no worse off transitioning to support at home from their home care packages, people are now being redirected to state-based equipment programs, which, as Mel has mentioned, only provide partial subsidy. They involve lengthy waits, sometimes of over 2 years. They can exclude required services, and they're often not locally accessible with a provider that a person chooses themselves. So for older Australians with mobility needs, they may need to navigate 3 different schemes for the AT that they need. An artificial limb program for a prosthesis, a state equipment scheme for an orthosis and footwear, and the support at home program for a walker, wheelchair or bathroom modifications. 3 schemes, each with different eligibility rules, funding limits, assessments and varied wraparound services available. If we contrast this to a person who is 63 under the NDIS, their mobility supports are considered through just the one scheme. At this time, AOPA recommends 3 practical changes that would dramatically improve access to orthotic and prosthetic services under the scheme. The first is to explicitly include certified orthotist prosthetists in the service list. The second is to include clinically required orthoses and prostheses, including the complete clinical service pathway required to safely provide those devices, and replace the blanket funded elsewhere exclusion with a test of whether the person can actually obtain timely, affordable, clinically equivalent and locally available support. We are happy to expand on those points and we look forward to your questions. Thank you again.
I'm going to go to Senator Ananda Raja to kick us off.
Yeah, thank you, Chair, and thank you for your testimony. I'm just interested in probing a little bit deeper into the navigation. It sounds like it's a challenging system for patients to navigate. What can the committee, or what should the committee consider with respect to improving care navigation? Do you have any thoughts? Should there be a helpline? Should there be a website? Should there be a national directory? If you could elaborate, that would be helpful.
Look, I just think because of for our community, there's obviously 3 different schemes that they can tap into. It doesn't immediately tell you which one's there, which one is going to meet your needs, if at all, and what the wait times are. I think, even with the forms to access My Aged Care, they can be really onerous for older folk. And not everyone is online. Not everyone, there's a large assumption that everyone sits in front of a computer and can answer a lot of questions. It's confusing at a time of especially trauma, and then thinking about how they're going to navigate, their home, their space, and then, their world with limb loss. It's really confusing. So I don't even know that because there's not one scheme, not one blanket overarching umbrella approach. I think it's really onerous for people to know where to go to get what. And even then, there's more barriers because if it's the wrong phone number, if it's the wrong service, then where to from there?
So some sort of care navigation service would be helpful. I mean, we have these for cancer. If you get diagnosed with cancer,
Sure.
there are care navigators now. Should there be something equivalent for limb loss?
I think the schemes should know about each other. If they are to coexist, all three of them, then at least if you're not eligible for one, that one who is shutting you out should be able to tell you where to go and how. And in aged care, I think that the no wrong door principle should apply. There should be accessible, accurate and helpful information in multiple formats for older Australians, because we already know Support at Home from testimony before us and the other submissions that it's already an administrative burden. And as Mel said, at a tricky time, one scheme's enough, and if you have to navigate three, what you'll find is people will just choose not to, and they will miss out on the care they
You're
need.
saying that these three schemes don't talk to each other at the moment?
Not at all.
And they're not even sure what's provided in the other schemes. So if they say, can I go here instead? They say, I don't know, maybe call them.
Right, so some
Very tricky.
coordination of these schemes would be a good starting place.
From an organisational perspective, we spend probably 75% of our time assisting people around Australia to determine what box they fit into. And even then, it's just not a black and white, straightforward approach. Unfortunately, it's really convoluted. We need to find out if they're plus or minus 65, because obviously that makes a big difference. And I think it's so much easier for those under 65 to be able to know where to go. I think, while the rehabilitation centres are supportive and helpful, at the end of the day, they're all very busy people. So there's only so much that they can do. I think the other thing is, people are discharged from rehabilitation, post-amputation and acute care, and they're sent home, but with what? Do you know what I mean? Like the delays to get a wheelchair, who provides them with that if that's what they need? Yes, prostheses might take time if they're going to be a user for healing and things like that, but you're going home with almost, nothing or a piece of hire equipment, which the hospital might allocate to you for 30 days, and after that you're pretty much on your own. Your property may not be accessible if there's stairs. No one's going to just have ramps in their house. They just don't build houses like that. So there's a lot of different, barriers that impact people, even just getting back to living at home.
You mentioned in your opening statement that the funding has not kept up with the technology. Can you perhaps elaborate?
Absolutely.
Yeah, certainly. So we know, if I can give the example of here in Victoria, their state-based equipment scheme for orthoses hasn't had a review and increase in prices for over 20 years.
Since 2002, I think.
How long? 22?
20 years.
20 years, right.
Yeah.
Okay, so things have moved on quite a bit since
As you
then.
can imagine, there's been increases in cost of provision of services, but also large advances in the technology that's available. So now, as Mel mentioned, there is technology that can make older people safer in their walking to reduce their falls, but it's not available under these
Can you
schemes.
elaborate? What is that technology?
So it's microprocessor knees, similar to what I wear, which enables me to walk, ambulate. I went from using a mechanical knee and falling when I was really tired up to 7 times per week, which is the prescription that these people are being provided pretty much nationally, to a microprocessor knee. So that has a sensor built in. It knows if I'm going to fall, and primarily I had 4 falls in 7.5 years compared to up to 7 a week.
And when it knows does it send out an alert?
It actually locks the knee. So the knee doesn't collapse from underneath you. But it's not just that. The mechanical knee units they're exhausting to use. They're heavy, they're clunky, and they've got no safety built-in mechanism in them. Whereas, the basic microprocessor for someone who wants to safely ambulate in the community isn't necessarily, onerous cost-wise. They can be $40,000. It's potentially going to last someone 7 years, 7.5 years. And if you look at that, break that down cost per year, the artificial limb schemes nationally really haven't increased in funding, even in line with the CPI. In fact, Victoria has almost gone backwards. And, you've seen in the evidence that I provided in our paper, it's just completely unmet, and that's a national issue.
So if you have private health insurance,
No.
are you likely to get access to this
No.
technology, or is it just across the board difficult?
Private health cover does not cover prostheses for people over 65.
I see. Okay, right. So this has to be publicly funded.
Correct.
Yeah.
And there's no access to, even if you're paying or whatever your gold standard of private health cover to, the most that you can get, there is no access to funding under that scheme for anyone for prosthetics.
And all the evidence shows microprocessors, and they're not actually that new, are they? They've been around for decades and decades.
Yeah.
They were new then, and now they're improving. They're lighter. You can walk fast and slow. You can lock it if you want to for extra safety. You can walk on ramps and stairs. I mean, they're completely different in terms of the function.
Do we have research data from Australia of amputees using this new technology?
No.
Demonstrating that it's superior?
No, there is, I think, studies from Sweden and also the States. I'd have to have a look. I can take that on notice for you and provide you with that
So maybe
information.
there's an opportunity here also to do a bit of research. If we could, on notice, get a list of those states that have not undertaken a review in a while, that would be helpful.
Absolutely.
Yeah, just to capture some of that variability.
Yeah, we can certainly do that. I mean, keeping up with the differences between the state schemes is very difficult, and it's really a core equity issue for these state-based funding schemes. What somebody can access in Victoria might be completely different to what they can access in Queensland. So I think, and at times, finding that information about how they're administered is also can be difficult.
And just with the prostheses versus orthoses, is it conceivable that an amputee would need both?
Yes.
They would. So on one foot and then the other
So
leg.
it's definitely conceivable somebody would have a prosthesis on one side
Yeah.
and orthosis on the other. They would also need perhaps a wheelchair, other walking aids, shoe modifications, home modifications. So yes, it's very possible that they could be accessing all of these different schemes at once.
And at the moment you're saying that the schemes are all disjointed.
Yeah, if you look at amputation in Australia, the average age of amputation is in the 70s, about 73 years old, and the leading cause is diabetes. So the main risk of amputation is already having an amputation. So those people who already need a prosthesis, who've had one leg amputated, are very high risk of losing the other leg, and that's why we use orthosis to try and protect that remaining leg and try and keep them mobile.
My last question before I hand back to the Chair. With regards to your submission, you did say that we have the second highest rate of preventable diabetic-related amputations in the developed world, which is quite shocking.
Yeah.
I'm guessing a lot of that is also being driven by First Nations diabetes prevalence. So
yeah.
what is the state of service for First Nations communities? I'm guessing if it's bad in Victoria metropolitan centres, it's got to be a whole lot worse in those
Workforce-wise,
other
density
communities.
in the Northern Territory, for example, is the lowest in the country, or
Right.
equal lowest. 0.8 practitioners per 100,000 people, which is extremely, extremely low. And we know in Alice Springs there's very few, maybe one or two providers that are not consistently there. Then it's not a reliable access service, and outreach is very difficult, particularly in schemes like this where the travel is not funded. It's very difficult for providers to be able to provide that outreach service, but we know, as you said, Aboriginal and Torres Strait Islander Australians are overrepresented in the amputation population, 3 times as likely to be an amputee over the age of 50, and certainly AOPA is working closely with Indigenous Allied Health Australia to try and increase workforce numbers in those areas.
So maybe on notice, if you could just provide us with some comparisons across the states of waiting times and any other metrics that you think the committee should consider, particularly with respect to this equity of access issue. That would be helpful. Thank you. Thanks, Chair.
Senator Askew.
Thank you, and thanks very much for your time and for being here today, and for your evidence and for your submissions. I've sort of read through them, and very interesting. I've got a couple of questions relating to that, but first of all, one of the comments that you made earlier, I think it was Ms. Landers, the no worse off, under the no worse off statement. what was it before? Are they worse off now than they were before? That's my first question.
Yeah, so what I would say is we are definitely receiving case examples of people who are worse off than they were previously. And I'd defer to Paul here. He can provide a case study of somebody he provides service to.
Yeah, and I'll declare up front, I'm a Managing Director of Neuromuscular Orthotics. We're a private company headquartered in Melbourne, but also with a clinic in Sydney and one on the Gold Coast. And so, yeah, just for the record. But also with us today as an observer is John Van Delft, who is one of our patients who accesses our service here in Melbourne. So John is 84, although he'd prefer to say he's 16 as he subtracts his chronological age from 100, turning 15 next month, he says. John is a long-term client of ours and, due to his age, obviously not eligible for NDIS. 2 years ago, through his home care package, he was able to, over the course of a few years, save up and put aside some funding to fund his orthoses. So John wears 2 orthoses, one on each leg, and previously had worn one which was full length, like a locked caliper that you sort of associate with people that had polio and needed that for mobility over the years. And he was deteriorating on the other side because we know that polio, the trajectory of that is impacted by ageing. So John needed an upgrade on the side that he wore a below-knee device, and he put aside this funding. He was able to get approval for that through his home care package manager and fund it, and that was in July 2024. And there had been some changes made to the guidelines to ensure that that could continue under that system. For example, where there was confusion about whether the funding was for disability or ageing, it was clarified that for conditions which were impacted, the trajectory was impacted by ageing, like polio had been given as an example, that could be accessed. Under the draft rules for the support at home system, unfortunately, because of some misunderstanding about the funding for these orthoses, for example, in Victoria, these sorts of things can be subsidised by SWEP, the Statewide Equipment Program, and that's the one that hasn't had the change in the subsidy level for over 20 years. It was assumed that because they were funded by others, they didn't need to be included. In the initial draft lists, under the exclusions list, currently funded by others, things like the knee ankle foot orthosis, or KFO, and the ankle foot orthosis were on that exclusions list. Through discussions, including, I think, with one of the advisors for Senator Ruston, we pointed out some of the difficulties that the people accessing that scheme were going to face, and thankfully they were removed from the exclusions list before the final version came out in November last year. At the same time, they weren't put on the inclusions list. So we've found since November now there's a lot of confusion between the providers. I don't know how many there are, but for example, differences between Bolt and Clark versus Let's Get Care or Trilogy Care or all of those sorts of providers about whether these things can be provided or not. And in any case, even if the technology can be, or even if a decision was made that, okay, we can include the technology, like Jess said, because as professionals we're not included on the service list, then the assessment component of that, the fitting component, the reviews, and then for potentially years afterwards, the repairs and maintenance of that device are not included as well. So that's why one of the, I think, relatively, hopefully straightforward considerations we're hoping the panel would consider would be the inclusion of that technology on the inclusions list rather than having the grey area, as well as inclusion on the service list. Because, I guess John is an example of somebody who was able to access that service 2 years ago, whereas now, that's not the case. And we do have, examples. There's one currently at the moment of a patient of ours who's at Knox Private Hospital, and the nurses and OTs are wanting to have her discharged to a rehab facility. And I have an email from last week where, unfortunately, they're saying they can't discharge this person to rehab without an improvement to her knee ankle foot orthosis. And this is somebody whose funding has been denied by her provider at the moment. But we think with clarity of inclusion of those sorts of devices on that list and the services to access them, that would improve it.
Okay. Yeah, go for it.
This came up in a hearing the other day when we were talking to podiatrists who were talking about the Byzantine way in which services are provided. And I guess it raises the question for me again around the idea that an aged care service provider is the one making the decisions when we have doctors and other health professionals assessing someone as needing someone or something, or a service or a prosthesis or whatever. And I guess what it's raised for me is this idea that why do we have providers being the gatekeepers to the health things that people need? Like if you or I went to the hospital and they said you need X and you get a referral, whereas for older people there's this layer of gatekeeping. And I wonder if you have any comments around that.
I think it really raises the example of, so when we've met to discuss this with Minister Ray's office, the advice was that prosthetists and orthotists are listed as a profession in the Aged Care Act, which is wonderful, but the people who are making the decisions, the funders, for example, they're not looking at the Aged Care Act. They're looking at the services list, because you're right, they don't have that really in-depth knowledge of the clinical need of a person. So they are deferring to a printed list on their desk. So when a request comes through from a prosthetist or orthotist, they look at the services list and they say, well, you're not on the services list. They're not delving down into the Aged Care Act. So I think because we have many, many different levels of people administering the scheme, it has to be very clear, very explicit in the guidelines.
I guess, and the reason I raised this is I came across a Facebook group the other day, which is literally just thousands of Australians who are engaging or trying to engage with the aged care system. And one person put in that chat and they said, I don't understand why I can't just get approved for a level of funding, have a card like a Medicare card, and if my doctor says I need X, go to health provider Y and swipe my card like I would if I was going to see it. And I guess that has really tweaked my interest, I guess, as to why do we have this layer of people who are gatekeeping between older people and health professionals?
It's an extra administration burden. And for those people as well, if you've been granted a level, regardless of what it is, you should be able to access the services that you've been approved to receive.
Yeah.
And I think the other thing for those people, often there's some going without services so that they can, save money in their plans to be able to spend that on a wheelchair if there's not enough money. So they might go without a cleaner or someone helping with meals, but then at the end of that quarter, the government's retaining a percentage of those funds. And I just find that bizarre.
And I guess what my sense of it all is that older people have very little agency around their healthcare.
To add to the point about that administrative burden with the providers, to contrast to NDIS, where our company registers with NDIS and we go through the audit process and everything with one organisation, under the supported home system at the moment, each of those providers contacts us separately to provide all of these different documents, our insurance documents and our police checks and everything individually across dozens of them, which is a huge administrative burden. This is not about providers though. It's about, for example, one of those providers that we weren't, so when I say this is not about us as a clinical provider, when a recent client who lives in the western suburbs wanted to access our services and their provider was one that we hadn't previously registered with, their response was, oh, well, they need to go to another provider that we already have on our books. But in such a thin market, this person wasn't going to be able to access anyone within 30 kilometres, which is a burden to the user, and that's what's important here, is giving them the best access and choice, like Mel said, to a service provider. And Mel has, more exaggerated examples than just 30 kilometres as well.
And that's a national issue outside of Queensland and New South Wales. And I think I put one of the examples of, a below-knee amputee who is 78 years old, lives in Shepparton. There is a clinic literally 10 minutes from her home, but to access state government prosthetic funding, she's got to drive to Bendigo So she's got a 3-hour round trip journey without the length of time that she's going to be in the clinic for, depending what she needs. And so your out-of-pocket fuel costs, she's got to be able to get transport there. But why can't she see the provider who is an accredited professional who is 5 minutes, 10 minutes from her home? It just doesn't make sense.
Can you just outline what the barrier is?
So in each state and territory outside of Queensland and New South Wales, the states, I guess, accredit certain or allocate funding to certain providers based on a state-based decision. For example, in Victoria, there are 12 providers that are deemed experts, and the funding goes to the healthcare system. So it's retained by the hospitals. Anyone outside of that who's a private provider, like Paul, for example, cannot provide a service to people who are over 65. It's a tender process in some other states, but it just seems like in this day and age in this country, not to be able to see the person of your choice, just it's almost wrong. You know, it is wrong. I'm sorry.
I'm conscious that I took Senator Askey's time.
Sorry.
I'm going to hand back to
In the
Senator
course of that
Askey.
conversation, you've just answered my next question, but I just want you to elaborate on it a little bit. It was about the quarterly funding. Is that part of the new changes that have been put in? That
Were put in November last year,
so
I
if
believe.
they don't spend it in the quarter on what it's meant to be, it can't be held over.
That's
so it's
correct.
Not an annual figure now; it's a quarterly
I believe it's quarterly, that's right.
So
And I only have personal experience caring for my mother, who was 100 years old, where her funds were retained. And as you say about providers, had I not been there to manage her providers, even though there's an overarching organisation that is managing her funding, basically I'm coordinating all of her appointments because no one else is doing it, which obviously I'm fine to do, but it just seems, you know, it made me question why the companies that are managing that funding are not coordinating everything else.
So is it it's not just for orthotics or for
It's outside of orthotics and prosthetics, so it's under the My Aged Care scheme.
in all their services?
It's a national,
on a
yeah.
quarterly basis. That is
Not
great.
not prosthetics and orthotics, because
No.
that's completely separate.
Yep.
So it's funding under My Aged Care.
Wow. Okay. Wasn't aware of that. We might look at that a bit more. The other thing you had on there was published state and territory financials and data relating to artificial limb schemes. So, is there any clarity or vision of what goes on at the moment?
We've had to FOI data for each state and territory. I can give you the data that's out of Victoria and WA, but I know, for example, currently across Western Australia, the feet that are being funded are the most basic feet on the market. It's technology that probably comes from the 50s and 60s, and they're $800 per foot. So that kind of foot, you know, that I learnt to walk on, it's like walking on a brick. It gives you no energy return. You are expending 65% more energy just to walk from here to there, whereas another person would be doing it 6.5 times. It is exhausting. Yet there's similar feet that are energy restoring, energy returning, that are really bouncy, more suitable for someone to wear. That foot is something that, you know, you would learn to walk again to regain your balance and your confidence, but not for the long term. They're dreadful. And the fact that, you know, that's the cap, the $800 cap or that kind of foot, you know, even in one state is just, you know, it's just really wrong.
I think it highlights an issue inherently with the use of lists. So we're not saying that lists are not helpful for people administrating the scheme, but one of our recommendations is if there are going to be lists, they need to be reviewed regularly. And they need to be reviewed in consultation with people who are actually using the services to ensure that those lists keep up with technology and cost of service provision.
And with assistive technology, the lists are fraught with problems by making it seem like it's a product-only service, which it's not. So quite often when you have a list of products, they don't include the clinical wraparound services necessary to keep that product safe and functioning into the long term. So you'll see it's like a false economy. They refuse to fund a repair, so someone will apply for a new one, even though the repair would be far more cost-effective and keep that device functional for longer. So I think, yeah, making sure that the full wraparound service is considered, not just a product cost by itself. And I think recognising the return on investment for assistive technology is important. We know from the World Health Organization that there's a 9-to-1 conservative return on any spend on assistive technology. So it makes sense and it's the right thing.
Chair, just with...
Nandiraja?
Just on that point, how do these new technologies end up on these lists? Who nominates? Is it who sponsors, for example?
It's the administrators of the program. In a lot of cases, Victoria, there's not so much lists in place. However, having said that, there's funding caps. So, prosthetics and orthotics as well are built, they're individualised, custom-made devices. So what's going to work for me may not work for another person who is 10 years older than me, also living with an above-knee amputation. And having a selection of, say, 3 or 4 different feet to choose from, it's not totally custom-made. I've always questioned why people who are qualified professionals can't make the decision based on that individual. Like a doctor makes a decision on a script for antibiotics for their patient. So I don't understand why qualified professionals can't choose the device that's going to best meet their needs of their client or their patient based on funding constraints or, a list.
Just going back to this list, the administrator determines what goes on the list. How does the administrator know what is actually current or
That's
best
a very
practice?
good question.
There's no standardised practice that I'm aware of that those administrators have used. And because, some of them are quite outdated, like the SWEP list that was put together in, I think, 2002. For example, the full leg device that John wears was allocated a subsidy of $2,200 at the time. And now, 24 years later, the approximate cost might be between $15,000 and $20,000. So that we're talking, an out-of-pocket expense that can't.
So there's no standardised way. It's all left up to the states. It's a bit ad hoc.
Correct.
There's highly variable competency of some of these administrators, I'm guessing, and there's no systemised way of them ensuring that patients are getting access to the best available technology. Is that right?
Yes.
Is that a good summary?
Yep.
Yeah,
I'd agree.
We're not aware of any process that they undertake to make sure that the things that they're providing are the best available. No.
And in some states, to get for a company to have a new product on a list, and often it's a very basic product, but it often means that they need to remove another. So there's from what I can understand, and some of the information is very difficult to access, if there's 15 feet and I want to put a new foot on there, then I've got to take one of mine off, as a very rough example.
And just my last question. And so this is peculiar to people who are particularly over the age of 65, right?
It's specific to people over 65.
Everyone else gets captured by the NDIS.
Correct.
Got it.
Or a motor vehicle or a workplace transport accident scheme.
So TAC type
Yes.
scheme would also be captured by this scenario?
No.
Oh, but would fall into the other one. Okay.
It is similar in a sense to the NDIS.
Okay. So we have a very, very much a tiered system.
Yes.
Yeah. Okay. Got it. Thank you.
That brings us to time for this panel. Can I just say thank you so much for your submissions and your evidence. It's been very enlightening, and there's certainly a pattern occurring across particularly the allied health sector, so your evidence is really helpful and useful, notwithstanding that it's actually quite shocking. The committee will report to the Senate on the 24th of November 2026, and we've agreed that responses to questions on notice should be provided by close of business on Friday the 21st of August 2026, and thank you very much again for your evidence. And we're just going to suspend briefly broadcasting. And while we're suspending, if the reps from Occupational Therapy Australia would like to come to the table, I'm just going to get that started. I now welcome representatives from Occupational Therapy Australia. Thank you very much for joining us today. I understand that information on parliamentary privilege and the protection and obligations of witnesses has already been provided to you. For the Hansard record, if you could each state your full name and the capacity in which you're appearing today, and I'll start on my left.
Thank you. Jonathan Ali, Senior Advocacy and Policy Officer, Occupational Therapy Australia.
Thank you. Jessica Schwarzbord, Head of Policy and Advocacy at Occupational Therapy Australia.
Thank you. I'm now going to invite you to make some opening remarks and then we'll go to questions.
Thank you. Good morning, Chair and committee members. I acknowledge the Wurundjeri people before we begin of the Kulin Nation as the traditional custodians of the lands on which we meet today, and I pay my respects to elders past and present and extend those respects to the traditional custodians of the lands all across Australia. So I am Jessica Schwarzbord, Head of Policy and Advocacy at Occupational Therapy Australia, and I'm here today with my colleague Jonathan Ali. Occupational Therapy Australia is the national peak body representing 36,000 occupational therapists. Occupational therapists work in partnerships with individuals and communities to enable meaningful participation in activities of daily life. And I want to thank you for the opportunity to appear here today to represent the profession and our members. Support at Home is designed to help older people remain healthy, active and socially connected to their community and to live at home for longer. Occupational therapists are uniquely placed to contribute to this goal. In the aged care context, OT services enable independence, prevent functional decline, increase quality of life and reduce care needs. OTA believes in the promise of support at home and wants to see it succeed. And we are here today because support at home is currently falling short of its potential in several important respects. We are concerned that as a consequence of the way that this program has been implemented, we are seeing a reduced access to essential OT services. OTA members tell us that assessments are taking too long and older people are waiting for weeks or months for funds to arrive. These service gaps are causing older people, their families and their carers considerable stress and confusion. Over half of surveyed members, we did a survey recently of our members, reported that at least 26% of their clients had declined recommended supports because of the co-contributions required being financially prohibitive. In this survey, we also found 84% negative sentiment towards the program. And all respondents who were surveyed all reported working with older people who lacked adequate assistive technology or home modification funding to meet their assessed needs. 90% of respondents said that the current settings would affect their ability to viably deliver occupational therapy services. And over half of survey respondents indicated that they were contemplating withdrawing from the aged care sector. At the same time, there are over 100,000 people waiting for support at home placements. We urge the government to respond swiftly to these implementation challenges and to ensure that support at home can deliver on its promise to older Australians so that older Australians can age in place with dignity. Thank you.
Thanks very much. Could I ask a question to kick us off? And this is probably a question on notice, but those statistics that you noted from that survey, is it possible for you to provide on notice the overall results of your survey to the committee? Because I know that we don't have a submission from you, but that would be really useful information for us to take into consideration.
Absolutely, we can provide that.
Great, thank you. Do you want to kick us off or I can?
You go ahead.
Okay. In terms of, you gave a fairly damning statistic there. I think you said 85% have negative views of support at home, and around half, did you say, were looking at potentially exiting the aged care part of their practice. Could you maybe speak to the things particularly that are contributing to OTs wanting to not be part of support at home and aged care?
Yeah, absolutely. So Jonathan was the one that designed the survey. So I might pass to you, Jonathan, if you'd like to start.
Sure. So the survey asked broad questions around the implementation of support at home and how it impacted on occupational therapists who are our members. It took a particular focus on the transition from the home care package scenario to support at home. Most of the feedback that we got from members tended to indicate long delays in assessment, definite dislocation and misallocation of funding levels when assessments were completed. And really the key issue is that once we're seeing assessments completed and confirmed, there are more gaps for funding to actually arrive. Now, in those gap times, things can change. People's lives can change, their conditions can change, they can deteriorate, they can change in other ways. But the scenario that they are aligned with in terms of the funding they receive and the package they're approved for can then be outdated, 2, 3, 4 months down the track. From a clinical point of view and from a practitioner point of view, that presents obvious difficulties, I think. The other thing too, really that's come out of the survey relates to business viability. Just in terms of overheads and people trying to run their businesses viably. Cost of living challenges obviously come into play, unexpected economic global factors come into play, all those things. But I think really one of the key things that the sector is really crying out for, and has really come through in the data and evidence and in the answers that people gave, is a simple question, and that is, what does good look like? Where are the benchmarks? Where are the quality indicators that people all through occupational therapy, allied health, the care economy ecosystem, working within the support at home context, what are we looking to tell them to indicate that they're on the right pathway to deliver services properly, doing a good job and doing the best thing for older people? There are a lot of different players in the ecosystem. There are equipment providers for assistive tech and home mods. There are sole traders, registered providers, and of course there are older people. Now, in terms of the broad context, parameters and just a pathway for them to actually refer to, they're in the dark. I would say they would be key issues that we could begin to talk about.
Okay, I'll go to Senator Nandaraja.
Just on that, this kind of every step introducing red tape and delay, do you have any data from your members as to how many or what percentage of clients are needing a revisit or a reassessment because of these inbuilt delays?
So support review plans. Well, whilst, there are delays in assessment related to review of support at home allocation by the IAT, but that may well be a separate issue.
So
in
I'm
terms of
sort
an actual...
you know what I'm getting at, like they've been seen by an OT and then because of all sorts of delays, they're having to then come back and reassess them because that is obviously increased cost, more time, red tape, etc.
Duplication, absolutely.
Yeah, duplication.
Okay, in terms of an actual statistics of where those processes are causing issues, we will take the stat on notice. But in terms of broad feedback, to give you an anecdotal quote from the survey, assessments to get on the program are still taking too long. There's another long wait for funding for services to get in place. This is supposed to not be the case under support at home. In one instance, we had a long wait for assistive tech and home mods with a client presenting with urgent need waiting over 3 months. The stress on the family caused them to put the client into care.
Yep.
Clients are cutting services due to being over budget. Previously, under home care packages, they were in budget, providers charging percentages on all invoices, services and delivered meals. So that's from a sole trader in a regional setting. That's as much as I can tell you about them.
Maybe if we, go.
Just
Go
a
ahead.
supplementary question. You mentioned financial viability, which I think is related to some of what you're saying now. So what is it about support at home that is threatening the viability of your members that wasn't the case, for example, under HCA?
Well, travel, certainly. Now, I know pricing caps have been deferred, so we're cognizant of that, and we'll wait for that, decision. But, when we're looking at, I would hope when we're looking at the application of pricing caps, and particularly in thin markets, and acknowledging that thin markets aren't necessarily rural, regional and remote, they often are, but a thin market can be in the inner city if the services aren't there, that can still be a thin market. But certainly where OTs are required to travel long distances and are getting paid the same amount to travel 30 kilometres as they are for 300 kilometres, in this day and age, that's a biting business expense, particularly with what's happening globally. The other thing too is that when the war started and all the petrol prices went up for everybody, there were OTs trying to access emergency funding to cover those costs and being told no, fuel alone as an overhead isn't enough. You need to have a broader suite of problems than simply that. So, that is certainly one issue in terms of business viability.
Yeah. So just going back to, I guess, metrics. If you could perhaps on notice supply us with some metrics regarding reviews that your members have done, and if they have any data on people who've had to enter care or escalate or end up hospitalised because they have been waiting for assistive tech or home mods, I think that would be helpful.
Some of that data will be in the survey data that we supply you on Senator Orman Payne's
If we could have a
request,
little bit more detail on the survey, like who the respondents were, the number, how the study was done, that kind of thing, that would also be helpful. I'm just turning to the anecdote in here, the case study 1 on page 10. And, there's a registered provider. So this patient was assessed and advised that he'd need some assistive tech, home mods, but in getting that assistive tech, the registered provider then put up a barrier, despite the funding being approved. Can you explain how something like that would happen?
Well, if the ongoing budget isn't approved, sometimes the registered provider will have reservations about carrying the cost. So, essentially if the person is coming to the provider saying, okay, I'm approved, but I don't have any money yet, business realities might be that...
I see, okay.
Is that also part of, is the 60% the interim package is also what's contributing to that? Because we know that there are people who are being approved at a particular level but then getting 60% of their package because they're getting an interim package. Is that part of that?
Well, that is going to create a gap in some cases, yes.
Shall I go to Senator Wendy? Just before I go to Senator Askew, I just want to correct something for the Hansard. I said that there was no submission, but I note that you have given us a submission today, so I just wanted to make that clear. Senator Askew.
Thank you. It's also being supplied digitally in 2 different instances on Friday.
Thank you, and thank you for providing that. We've got it, and unfortunately haven't had time to read it in full, but I have looked through it. In regard to your recommendations, there's a few in there that we've it's reinforcing messages that we've heard already along the journey, I must admit. But specifically, I just wanted to look at the consumer co-contributions, which we've touched on already, just about the home modifications and so on. We've heard evidence before that if money's not used in someone's package, it may be no longer available if it's after a quarter or a year or whatever. Have you come across situations where that's been examples that you could give us of that, where people have sort of been approved for funding for something but then the money's been removed because it hasn't been expended in a certain time frame?
I will take that on notice, if that's okay. So, knowing the survey as I do, I don't recall that instance being part of our data, but I want to be careful, so I'll confirm that on notice.
Okay, and one of your recommendations was also about the $15,000 lifetime cap. Obviously, that is something that I would have thought you would have come across. Have you got any examples of that? Of how you would see that would not...
well, I mean, if you look at a home modification for wet areas, I haven't had my bathroom done lately, but I imagine that if I wanted to completely redo the wet areas for safety within my bathroom, depending on obviously the architectural unique elements of one's house that will always come into play. But there are always hidden and unforeseen costs in any major renovation. I think we all know that. Where you are looking at a $15,000 cap, a modification of a wet area, first off, $15,000 may not cover that. Secondly, your $15,000 cap doesn't just apply to OTs. Okay, it's your AT and HM cap. So if you are looking at accessing other services from other allied health providers, that's eating into your $15,000. Your OT assessment is eating into your $15,000. Your costs to build the thing are, eating into your $15,000. So at the end of the day, really, I think our view on the cap is that it came from a really well-intended place to allow people to do major works that they required in their homes to stay ageing with dignity in place in their home environment. But at the end of the day, goalposts have changed and it's not enough money for people to really actually use it effectively. And I think in terms of keeping people at home and out of resi care and out of hospitals, it's becoming a major issue, particularly also when we're looking at probably earlier in their ageing stages when we're looking at these major modifications. So you might use that $15,000 cap for a certain amount, and you might actually make the changes that you need to make to your wet area in your bathroom or other changes in your house, and that might be fine for a couple of years. And then you might have a stroke, or you might have a fall and damage your hip. Any number of things may change to health conditions in older people because of circumstances that then require more modifications, and the money's not there to do it. And where do those people go then? Exactly. They get assessed for resi and it takes forever, or they end up in a hospital bed waiting to go into aged care. So that's the ramification of the cap not working.
And I might add that conversely, one of the consequences can be that older people choose not to modify their homes early because they're worried about that cap and they can't afford the co-contributions and financial pressure that causes. So the consequence of that is an increased risk of things like fall and then early entry into residential care because they haven't had done that home modification when they needed to. So it's playing out in both ways, unfortunately. And we're hearing from our members that they're saying around 30 to 40K is what they're seeing for home modification costs.
That's a figure in the submission, that's right.
Yeah. It really is a far more realistic price. My brother's going through it under the NDIS at the moment, exactly the same thing, and that's why I thought the 15,000 just doesn't make sense. But okay, that's fine. The only other question I had, and you've obviously gone into it, which I haven't thoroughly read the full extent, but is the integrated assessment tool. So your thoughts on that?
Well, we just want something that works.
Yeah.
It's really what we're after, something that works.
You made a comment before about somebody getting, I think it was misallocation or disallocation of funding that I wrote down. Is that because of the integrated assessment tool? Is that what your implication is from that?
So they comment on the algorithm. I mean, basically, look, with the IAT, and I realise Senator Rushton has had the bill in the Senate, which has been co-sponsored.
Yeah, with the Greens.
And with Senator Pocock as well. And I know it's passed the Senate and that we will wait to see what happens with the bill. We are not saying you cannot have algorithmic decision-making in the care economy. And we are not saying get rid of the IAT. We're saying fix the IAT and take a closer look and give closer scrutiny to the algorithmic processes underpinning the IAT. Because just as we have a set of checks and balances and hierarchies in human-centred care in the medical system in a hospital staff, all those positions are there for a reason and they're scrutinised. Human beings make mistakes, of course they do. But in those care hierarchies, human beings can mitigate those mistakes. And that's the crucial difference with the algorithm. So if we look at the evidence We know that 167 reviews for support for the IAT are to do with misallocated funding. And we know that 133 of them are about priority categories. So, and I will get to our member feedback momentarily, but what it appears to be doing is that, for example, let's say I can get up in the morning and I can dress myself. I can put my clothes on. The IAT may assess me as low-level needs. It doesn't know that my brain doesn't tell me to dress myself. I am high needs. I can't get dressed. My body can dress myself, but I can't get dressed. So in terms of member feedback, we've had someone, like I said, there's a major city, an OTA in New South Wales, major city, and a support home survey talking about a number of cases, not just one, where the algorithm has over or underrepresented the needs of a client. So the example that's cited is there's a client that needs 24/7 support from multiple family members, all of whom work or care for children or don't live with the client, but the client is determined to require no extra funding. And, you know, from a transitioned L3 home care package. There's a major misalignment there, and that person is worse off, even if they had a previous home care package. And the no worse off principle talked about grandfathering people on previous packages in after September 2024, that they would not pay more for their care. Well, that person's paying more for their care. Where's the no worse off principle? You know, and I realise the no worse off principle has been vaunted widely, it's become a catchphrase, and it wasn't widely understood. But in terms of a specific example of someone on a home care package who's supposed to receive the same funding and care under support at home, that person is not. Now, and I'll bet you dinner right now that that's not the only example that provider has. He talks about many examples.
I might add as well that one of the things that we're really concerned about is the exclusion of clinical judgment from these processes, and that is something that absolutely the tool does. It excludes clinical judgment. Allied health professionals, OTs in particular, are experts at assessing functional capacity, and then they've coming up against this blunt tool that doesn't enable them to do their jobs and what they're trained to do. So that leads to risk for the older person. It leads to increased strain down the line on our other systems, stress for families and friends and communities. And I think as well, it does go to that stat that we talked about earlier with viability, in that our members are frustrated. They can't do their jobs in this system, so why would they want to remain in the system?
And I'll just speak to another point that you've just prompted me on, thank you, is that we as policy people and yourselves as people invested in the health, in the care economy, will understand the nuances of these processes. Clients and patients and people in the street do not. And because they don't, understandably, our members get the blowback, they get the frustration and they get the stress. And that comes through very, very broadly in our survey, and that's another reason to come back to your original point. Why do people want to leave the sector? Well, because the day-to-day stress they're getting from this is not worth them turning up.
Thanks very much.
One last question, and then we'll need to finish this panel.
Could you give us an indication as to what the variability in pricing is amongst your members? Make a recommendation for home modifications, for example, and I get what then happens. Does the client then go to the market to get quotes, or how does it work? Because I'm just trying to get a sense of what the variability is in terms of that pricing.
What do you mean under the various tiers?
No, for say home modifications. Say a person needs a shower rail or they need some sort of mod. Is there a lot of variability being seen in the market in terms of the pricing of those modifications?
Of those items, do you mean? Yeah, there can be. Anecdotally, I would say that sometimes we have seen items that are cheaper at retail than through sort of sector-aligned provision pathways. I'd be happy to give you some specific examples on notice. But yes, I've heard that anecdotally and feedback, yes.
Right, okay. So if you have any data, yeah, I think on
Definitely.
notice, that would be helpful, because
No, we can
obviously
definitely give you that.
that will just eat into the 15,000 budget if there is so much variability, right?
Yeah, but there also are, I mean, there's the low funding tier of $500 and the medium tier of $2,000. You can go back and reactivate those. The 15K is for life.
Yeah.
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 We would also tend to advocate, I mean, you mentioned red tape before. Absolutely. Instead of having to apply for the low tier, I think if you're going to have assistive tech and home mods, there should be an automatic allocation for older people who want to access those things in place. It would save a lot of time, a lot of labour time, a lot of red tape, and probably some money as well. And we appreciate you can't just clamp that on across all levels of it, or that you can't do that without some interrogation of the idea. But it's, I think, worthy of investigation and would certainly, smooth a lot of the pathways. They're complex enough as it is. That's one small thing that can be done to help older people.
Thank you. We'll have to leave it there for this panel, but thank you very much for your comprehensive submission and also for your time in coming to give evidence to the committee today. The committee will report to the Senate on the 24th of November 2026, and we've agreed that responses to questions on notice should be provided by close of business on Friday, the 21st of August 2026. Thank you very much again for your time.
Thank you.
And I will now welcome representatives from Victorian Sector Support Development Partnership. Good morning. Thank you very much for appearing before the committee today. I understand that information on parliamentary privilege and the protection and obligations of witnesses giving evidence to Senate committees has been provided to you. For the Hansard record, could you each please state your name and the capacity in which you're appearing today?
Hi, I'm Anna Makedonska and I represent Victorian Sector Support and Development Partnership.
Thank you.
And Meg Henderson, also representing the Sector Support and Development Partnership.
Thank you. I'm now going to invite you to make some short opening remarks and then we'll go to questions.
Anyone?
Either of you can make those remarks.
Stop.
Thank you, Chair, and thank you, Senators. It's an honour to be here today. We work across the community aged care sector to build capacity and identify emerging issues and provide the department and advocacy bodies with practical examples from providers who support older Australians every day. Through sector support and development, our local connections with providers across regions allow us to hear directly from organizations about the practical realities they face. These relationships are important because they help identify emerging issues early, share trusted information, and strengthen implementation on the ground. The Victorian Sector Support and Development Partnership submitted 2 papers to this inquiry. The first reflects the experiences of mainstream aged care providers across Victoria. The second was developed through a separate engagement process with 14 First Nations providers and organizations. Having reviewed many of the submissions to this inquiry, it is clear that the issues identified by Victorian mainstream providers are very consistent with concerns being raised by providers across Australia. However, the First Nations submission identifies distinct challenges and perspectives that deserve a separate consideration. Our mainstream submission is based on 178 survey responses statewide and input from at least 58 Victorian organizations across metropolitan, regional, rural, and remote communities. The message from Victorian providers is clear. They support the intent of the reform, and they want the support at home to succeed. Their concerns relate to implementation. The message is not stop the reform, it's help us make it work. 8 months after implementation, providers continue to report a significant gap between policy intent and operational reality. They describe a model that is increasingly complex to operate, with multiple funding streams, business rules, and administrative processes consuming valuable time and resources instead of focusing on direct care. Providers are spending increasing amounts of time on interpreting guidance, reconciling claims, explaining budgets, and managing manual workarounds. The impact extends beyond providers. Older Australians are confused by contributions, by statements and funding arrangements. Some are delaying, reducing, or declining services because they're uncertain about the costs and affordability. Providers also report ongoing delays in assessments, reassessments, and funding decisions, as well as concerns about assessments quality and outcome that do not always reflect the level of need. This is creating a growing disconnect between being approved for support at home and actually receiving the support at home, and receiving the level of care people have been assessed as needing. This submission is not simply a list of problems, it presents practical recommendations to strengthen implementation by improving government engagement, reducing operational complexity, improving timely access to care, ensuring care management funding better reflects the realities of delivering contemporary home care. The Victorian providers believe that these practical improvements will help realise the objectives of the reform while delivering better outcomes for all the Australians. And if I can, I will now hand over to Meg Henderson to outline the key themes from the Victorian First Nations submission.
Thank you. Good morning, and thank you for the opportunity to speak. I just want to start by acknowledging the Wurundjeri Woi-wurrung people and the Bunurong people of the East Kulin Nations as the traditional custodians on the lands on which we meet today. Pay respects to Elders past, present and emerging. The submission we put in around the First Nations community-controlled organisations represents the voices of those in Victoria. It was, they participated in surveys and roundtable discussions. While these organisations strongly support the intent of the aged care reform, their message is clear. The current implementation of support at home is not working as intended for many Aboriginal elders, communities and providers. The central concern is that the model remains largely mainstream in its design and does not adequately reflect Aboriginal ways of caring, community-controlled service delivery, or the commitments contained within the Aboriginal and Torres Strait Islander aged care framework. There was 3 really strong key messages in there, and despite significant consultation throughout the reform process, the Aboriginal organisations say that their recommendations are not reflected well in the final decision of the Support at Home program in particular. That they also state very clearly that elders face significant barriers to care. Some of that is around confusing communications, navigating complex systems, experiencing delays in assessment and struggling to access services even after approval. Many rely heavily on the trusted Aboriginal organisations to help them understand processes and remain connected to care. And another major concern is the client contributions. Some of them are having to choose between food and the contributions that are expected of them. The submission, I think, warns that these barriers increase risk in inequity rather than improving access. And the third key theme that came through was that Aboriginal organisations are carrying the system, that their staff are coordinating services, chasing assessments, following up providers, advocating for families, filling service gaps and helping elders navigate increasingly complex systems. And this work's often invisible within the funding model, but it's critical to ensure that the elders receive support. So importantly, our submission's not calling for a completely new direction. The recommendations reinforce commitment that government have already made through the Aboriginal and Torres Strait Islander Aged Care Framework, the Royal Commission and Closing the Gap. The 6 key recommendations are: hold support at home accountable to the Aboriginal and Torres Strait Islander Aged Care Framework, establish formal Aboriginal shared decision making, accelerate Aboriginal-led access, navigation and assessment pathways, implement flexible community-controlled funding models, remove financial barriers such as client contributions, and support the growth and sustainability of Aboriginal community-controlled aged care providers. The message from the Victorian Aboriginal providers is that they support the reform. They support better outcomes for elders, but they are concerned that without targeted changes, support at home risks increasing barriers, weakening cultural safe care and widening existing inequities. So the opportunity now is to ensure implementation aligns with existing commitments and delivers what Aboriginal elders want and deserve: accessible, culturally safe, community-controlled care that enables them to remain connected to family, culture, community and country. Thank you.
Thanks very much. I might kick us off, and I'm going to ask sort of a big picture question. One of the themes that comes up quite regularly, or has come up both through our CHSP inquiry and this one, is older people themselves saying, in many respects, they don't like this at all. It's complex, it's hard to navigate, they don't get the care that they need, there's misalignment with their assessed need. And then we hear from providers and provider orgs who say, we support the intent, but we don't like the implementation. Could you outline for me what you understand is the intent that is being supported?
I think the intent is essentially about having a coordinated system that supports older people to remain within their own homes. That there's a range of services and options there, that people have choice, they have the right to choose, that they that those rights are respected within the system. And I think that, I don't think anyone questions that in the sector, is that it should be about people's choice. And it should be about supporting them to make the decisions that are right for them, because what works for one person doesn't necessarily work for another. But I think what we're finding is all this red tape and all of this administration is really very much getting in the way of that. And being able to, I was just listening before too around what Occupational Therapy Australia said. I'm an OT as a background, and I was sitting there thinking, I don't want to work in the sector because I can't do what I need to be able to do in a way that actually works with people. The system's cutting that through.
And I guess the reason I asked that question is because there were two parts to the reforms. There was the part that you're talking about, the part that said we need to make it a rights-based system, we need to put people at the centre of care.
Yeah.
But then there was the other aspect of the reform was a complete rewriting of the financials, the way the rules are written. And I would put it to you that the intent around the rights was fine, but actually what we've got on the other side of things is not actually delivering what the rights-based side of the Act says. So I guess from that perspective, it would seem to me that actually the reform has failed in that regard, because it's actually not delivering, and in fact it's making things worse.
I would support that. I think it actually contradicts it in a way. And I know, like in Victoria, we spent a lot of years working in what we call the active service model and that wellness and reablement approach. And it's something that I think foundationally is fantastic, because it's really about supporting people to be able to make choice and be the best that they can be within the circumstances they live in. And it's very difficult to implement that in a system that's transactional, and that's very limiting in how and what you can do within that. And I think it's very difficult for providers to be able to deliver on that in the way that they're funded.
I think it's interesting that you're talking about it, that it's transactional rather than relational, which I think also reflects a comment that was made to us by someone around the integrated assessment tool, which said it's not actually a tool that's assessing functional capacity, it's a financial eligibility tool. So this is all about finances and eligibility rather than actual support and care needs.
Yeah, and I think you'll find too that listening to the Aboriginal community-controlled organisations, and particularly when you hear them passionately talk about the elders that they support, that their culture, that the way that they work is very much not a transactional model. It's very much about trust and being able to respond when, and be able to, it's very much a respectful model, and it's very difficult to do that in this transactional process.
Yet I think what we're also hearing from other older people actually is if we rolled out what First Nations people want to see, that would actually work for everybody else as well. We're hearing from culturally and linguistically diverse communities that they want a relational approach. When we hear from, I'm not sure what mainstream is anymore, but from other people older people, they want a relational model. Like at the moment, they just feel like their numbers in a system, punch the tag and maybe you'll get something at some point, but no one's really looking at you as a person.
Yeah. And I think the way too, if you look at something like support at home, I think about what happens up in, say, Mildura, up around in that sort of Robinvale area where there are, I don't think there are any specific support at home providers on the ground. They might come in and visit, but they don't actually sort of live within that community. And so it's the relationship is actually with those providers. So, for instance, in with the Aboriginal elders, the relationships with the Aboriginal provider that lives on the ground there, that works in that community, that understands it. It's not with the support at home provider. And so they're not having that relationship with them. It's very hard to do that when you come in and maybe you're there once a month on the ground. So it doesn't actually exist in a lot of the communities, that connection and that understanding about what exists within that community.
I'm conscious of time, so Senator Nandaraj, do you have questions?
Just with regards to the First Nations Aged Care Commissioner, there's an interim person who's been appointed now. What kind of engagement have you had with the Commissioner, and what are you hoping to get out of this appointment?
Oh, it's interesting. I just had an email come through yesterday to support a group of providers that operate within the Loddon Mallee-Hume area. So they've been in existence as a consortia for quite a long time. And I know that the interim commissioner has just been approached about coming along to one of those meetings, probably in, I think, the November meeting. So we're very much sort of trying to engage and get, interaction.
And what do you think should be the first order of business for the new commissioner, based on your own expertise?
I think what providers, when we've been talking to them, very much are sort of saying, I think one of the priorities is about making the decision, I suppose government making that sort of decision on providing sustainable, flexible funding models so that the Aboriginal community care organisations can actually deliver culturally safe care on the ground. This sort of thing where they're locked in and you can only do X and Y, where in fact Z's what's required on the ground, is really limiting the way that they can support. So a lot of the work is, in reality, they're doing it, they're not getting funded for it.
Could you give some examples?
I had a really lovely one. It's just trying to think of some.
Even on notice is fine.
Yeah, I definitely know that some of the one of the providers up in Robinvale talked a lot about on the weekends going out and supporting elders. So it's not funded within. So the support at home program is not on the ground. They're not delivering that out of hours care. But for some reason something's happened, and it might be as simple as they've run out of firewood, and the fire is their only heating source. So being able to get somebody to sort of rally around and deliver and make sure that there's enough firewood that's accessible within the home. Would be sort of,
I just want to turn to workforce. If you could give us an indication of your workforce, the characteristics of your workforce, and whether you've seen increased stability, because obviously, we've put a lot of money into aged care wages for aged care workers, and supporting the students who are going into this area with paid pracs and so on and so forth. Has it made any difference on the ground yet in terms of stability of that workforce? Obviously, that's important towards building that kind of relationship or relational aspect to the care by having a stable workforce.
Thank you. We haven't seen it in practice yet. What we see that, especially in the office situations, care managers are extremely distressed they overworked and stretched because of administrative burden, and we can see a lot of turnover in offices. The same happens with clinical assessors. I spoke to a few clinical assessors who were saying that they believe that their clinical skills are not valued. They're becoming de-skilled because they're using just the tool and not their clinical judgment, and they're leaving the industry. And that's a big concern. In terms of staff on the ground, support workers, it is still difficult to attract qualified support workers, but it was always difficult, and it's becoming more difficult because more people stepping into care.
And I think the thing, just to adding that, you know, with the, for example, local government stepping away from delivering aged care, I think they had always been probably the leaders in offering really fair work conditions for support workers, that they would pay for, you know, mobile phone usage, for mileage, for travel between appointments and things like that. And a lot of that is sort of being removed, which makes it more difficult, I think, for support workers to be viable in that sort of situation.
And have you got support workers who are First Nations themselves? Do you intentionally draw from the community, or can it be anyone?
The First Nations providers very much target First Nations
Workers.
community members, to be part of their workforce. I think they would make up the majority of the workforce. There are sometimes gaps in there where they certainly have workers who are not Indigenous but are very connected to the community in there, but the majority of it, and they certainly look at ways of bringing through the workforce, whether it's internships or ways of actually building the skills within the community.
And just my last question, what has been the quality of your engagement with the department in this implementation phase?
Very, very regular. We have very strong connections with our stewardship teams that operate in Victoria. We also are connected directly through some meetings with Canberra. So pretty much we operate and deliver a lot of forums and workshops and things like that. So department reps are always invited and probably are highly represented at any of those sort of engagements. And particularly with things like the work in supporting the Loddon Mallee Hume Aboriginal Network, always have department reps at those meetings. They're highly engaged in that.
And has that helped troubleshoot problems early, or has it made any difference? I mean, they may be turning up and engaged, but has it helped?
It's hard for them. I think they get stuck in the middle. They're sort of the messengers in lots of ways, because it's sort of the decision makers are here and they're that sort of pipeline. So they absolutely advocate and pass the messages up the line. With their influence, I'm not sure how.
Maybe having the Aged Care Commissioner First Nations might help with that advocacy. But thank you. Thanks, Chair.
Senator Askew.
Thank you, and thanks for your evidence, and thank you for your submissions, because they were really informative and comprehensive. And it's actually something in there that I wanted just to elaborate a little bit further. So you've summarised the key issues. I think that's really basically what you've summarised through there is exactly what we've heard in every one of the hearings that we've done around the country so far. But in it, you've talked about when you've summarised it back to the 4 strategic reform priorities, and you've just talked about, in response to Senator Ananda Raja's question then, improving government engagement and reform stabilisation. By reform stabilisation, what are you looking for?
What we're saying, we see the department is engaging through their stewardship teams. The department is engaging through advocacy bodies quite heavily, and it's really valued. However, not every provider is part of their advocacy body, like Aging Australia, for example. They would value more engagement with the department through webinars, because not everybody can visit physically, obviously, the forum or the network meeting. They are reporting that there is not enough engagement for them. It's a lot of questions. It's still a lot of questions about reforms, about business rules, about a lot of things that were not anticipated, which we had a lot of changes. It's like hundreds of changes on the 1st of November. And to do a change well, you need to have time, you need to have testing, you need to identify issues that are not working, and reform can be made, can be done well. We've seen a very good example of change management, for example, with the personal care, the removal of the contribution for personal care. There is 6 months leadway. The department is engaged every fortnight online, and we're able to ask questions. We're not on the 1st of October yet. However, you can see the change management done well. However, on the 1st of November, we had hundreds of examples like that. And we need, providers need time to implement IT solutions, which are still not there, because the design of the system is heavily software focused. Not every provider is where it's needed to be, and not every software provider is able to deliver. Even very mature, very experienced software providers, they are not able to sustain the pressure, and they're crashing. Therefore, we know even about organizations who are unable to produce statements still 8 months past the reform. They can't see the budgets because their software provider crashed.
Okay, so that's, I haven't heard that one before, so that's interesting. And so with regard to the engagement initially, so the lead up to the implementation on the 1st of November, is that where you see that the failure happened, that there wasn't that consultation in the prior to it? So now they're playing catch up?
Yes.
Okay, so looking at that, you've got the next point on your 4 key strategic reforms are to reducing operational complexity and administrative burden. So obviously they almost overlap to some degree. So how would you see that being implemented, and what sort of recommendations should we be looking at it in that regard?
Talking about administrative burden, and you've probably seen many examples over this period. Let's even start from the onboarding of clients. I don't know if anybody talked about the agreements, the service agreements. When you go to a doctor, you fill in 1 page. When you go to a surgery, you fill in 2-page document. When we sign up clients, it's 40-page document. It's legal document. It's not easy to understand, and your obligation as a provider to explain the document and for the client to understand the document. That's the most important bit. Then you have to go through all the documents, through the whistleblower protections and aged care rights and code of conduct and privacy, and then you have to talk to them about contributions, which you don't know yet what it will be, but it may be approximately something. Then you have to go through your own organizational procedures to explain how it will all work. By the end of the process, it's a lot of paperwork, and you have to leave the client the agreement, or you do it on the phone. Clients overwhelmed. It's a lot of pressure on clients, but it's a lot of pressure on provider as well. The investment of time is very intense, and they're not paid for this through care management, because if clients are entering through the quota, you're not receiving money for care management. You will receive it within the next quarter. But clients who are leaving the system, their care management money are staying with the provider. And there was an assumption that it will even out. It's not evening out. And then, for example, the client was assessed a year ago because the assessment, and allocation the allocation of care doesn't mean that the care has started. A year later, the care started, the client is receiving some of the services like domestic assistance, for example, and the client needs to go, the client had a fall and needs an assessment with an allied health team. There was in the original assessment, there was an approval for occupational therapist. The client is making an appointment with the clinic, and the triage is saying, oh, you really need to see the physiotherapist because the physiotherapist will help you with the problem. However, you're not approved. Now we have to write a request for service review, And few months later, they will receive an approval to the physiotherapist. They're going to the physiotherapist does what they need to do and saying you will really benefit from the exercise program. And we need to send you for service review. You know where we're going. And then the podiatrist and then the dietitian, and here we go. Yeah. What happens, every service type in the service list has an approval, which means you have to be approved for personal care. And the personal care, for example, you have 3 services. Personal care is a service type, and there are 3 services. It may be assistance with self-administering medications, the hygiene, where is assistance with showering happening, and non-clinical continence support. When you're assessed and approved for personal care, you're approved for all these subsidiary services. When you're approved for allied health, you need a specific approval for a specific service. And people, assessors who are assessing, they may not know 12 months in advance what will happen. Some assessors routinely tick all the boxes, just in case, because the clinical assessors and they think anything may happen, timeliness is an issue. Good for the client, probably skews the statistics completely off because you can see the demand is everywhere. Many assessors wouldn't do that. They think it may be occupational therapist, when in reality maybe it needs to be exercise physiologist. It's a lot of back and forth. To request a service, a support plan review takes time. Yeah. To receive it takes more time.
It sounds very complicated. So, and that 40-page form, does that have to be done for every provider?
Yes.
So
it has to be done for every client, by every provider, to every client. Client needs to have a service agreement. Yep, with everyone. Client's concerned signing it. It's a legal document written in legal terms because it has to comply with HK Act, prescribed terms, with consumer law, with contract law. It's quite heavy and quite intimidating. Another thing is managing, if we're talking about administrative burden, just stop me because it's a lot.
We're running out of time, that's
yes.
Conscious of the time. But, sorry, what was the other one?
For example, associated providers.
All right.
Management of associated providers is a nightmare. Providers will have a lot of associated providers. They may have on their books hundreds. Each associated provider needs to be registered with GPMS, Government Management Provider System. It's a 6-page form which you need to fill in and send and then wait till they appear on the system. Some registered providers, they are associated providers as well. They provide care to other providers. They have to comply with regulations, which means they have to demonstrate their compliance. They're already registered, but they still have to go through this process of complying, which means the provider will send them a learning pack, and they have to go through the learning pack, and they have to do all the modules, and they do it 40 times. Why can't we have a register where provider registers once? But it's a lot of administrative burden and managing the providers to make sure that they're compliant.
Okay. And I think this is one of those things that is a barrier to Aboriginal organisations, the culturally specific organisations actually being providers in support at home, of actually having the systems and the capacity to do all of this extra compliance stuff that they haven't had to do under CHSP. And it's a significant barrier for them to be able to step into that space.
It's totally understandable. It seems like absolute craziness by the sound of it, administrative nightmare. But thank you very much. I'm sorry I've gone over time. So thanks, Chair.
That's all right. Thank you very much for both your very comprehensive submissions and your time in front of the committee today. It's been very helpful. The committee will report to the Senate on the 24th of November 2026, and we've agreed that responses to questions on notice should be provided by close of business on Friday the 21st of August 2026. So thank you very much again. The committee will now suspend and we're going to come back at 11 a.m. I now welcome representatives from City of Greater Geelong and Mount Alexander Shire Council. Thank you very much for coming before the committee today. I understand that information on parliamentary privilege and the protection and obligations of witnesses giving evidence to Senate committees has already been provided to you. For the Hansard record, if you could each state your full name and the capacity in which you're appearing today, and I'll start on my left.
Anthony Bassford, I'm the Executive Director of City Life at the City of Greater Geelong.
Pamela Newton, I'm the Manager of Community Care at the City of Greater Geelong.
Rosalie Rogers, Manager Community Wellbeing, Mount Alexander Shire Council.
Thank you. I'm now going to ask each of your organisations to make some opening remarks and then we'll go to questions. So I'll start with City of Greater Geelong.
Thank you, Chair and Senators. In May 2025, the City of Greater Geelong Council made a commitment to its older residents, a decision to remain in the delivery of in-home care services at a time when many local governments were exiting or had exited or were considering their future in aged care services. Council did this despite the policy uncertainty, workforce capacity and capability issues, IT system challenges and financial risk. Over the last 12 months, my team and I have worked on rebuilding the city's capacity to enact the decisions and implement the Aged Care Act reforms, and Senators, it has been a journey. It has required ongoing service review, adaptation and investment in sustainable delivery models. The City of Greater Geelong is both a regional city and a growth council covering more than 12,000 square kilometres. Greater Geelong is growing quickly with a current population of 306,000 and increasing to 442,000 by 2046. We currently have 62,000 residents aged 65 years and over, increasing to 73,000 by 2031, just in 5 years' time. For our city, the largest outside of Melbourne, the reforms need to support older people in communities such as Corio, Nor Lane, Whittington, which are some of our most disadvantaged communities in Victoria, as well as our growth suburbs, the Bellarine Peninsula and our rural townships. We are already seeing strong demand for domestic assistance, transport, delivered meals, home maintenance, social support and personal care. These are often described as low-level supports, but for Greater Geelong, like many rural and regional councils and communities, these are the supports that stop small problems becoming hospitalisation presentations, carer breakdown or premature entry into residential aged care. The city currently supports approximately 300 supported home clients, 3,600 Commonwealth Home Support Program clients and 300 young people with disability funded through the Victorian Government. There are approximately 4,300 referrals sitting in the My Aged Care, and we estimate 1,400 of these people are expected to ultimately require and commence services. On average, the city receives around 150 referrals a week. The city's submission to the inquiry focuses on three key themes that we believe are pivotal to the success of the reforms. Access must improve. Older people must be able to access assessments, care funding and services in a timely manner. Affordability must be protected. Co-contributions and pricing arrangements should not create barriers to accessing essential support, and preventative CHSP strengths must be preserved ahead of future transition to supported home. The city is seeking a clear implementation roadmap of the transition of CHSP into supported home with adequate, staged and proportionate transition funding. The transition roadmap must provide clear guidance for providers, consumers and carers. Limited transition-related funding has been made available to date and does not meet the full cost of transition for local government and probably no providers. The city is seeking retention of the CHSP block funding or an equivalent flexible funding mechanism. Block funding enables councils to sustain practical support such as delivered meals, transport, social support, domestic assistance, personal care. Even when the demand is variable, and this is the important part, travel costs are high or services are not financially viable on a strict unit cost basis. Senators, I'd like to draw your attention to two case studies we have included in our submission. These are real people, real situations and real issues facing older people in our community today. Gwen, which isn't her real name, has done everything possible to remain living independently in her own home. Yet under the new arrangements, she has been assessed at a lower level of lower level funding despite requiring increasing support. The result being an 89-year-old woman with no family support, complex care needs and limited resources is being asked to pay the gap between what she needs and what the system will fund. In another case, Kathy, also not her real name, aged 79, lives alone in public housing and currently receives a home care package level 4. Kathy has limited financial means and no capacity to purchase additional services privately should her package funding become exhausted. As a level 4 home care package recipient, Kathy has growing support needs and is progressively utilising her available funding allocation. A reassessment request is being lodged early as we know she will exhaust her funding and the current reassessment wait times are extremely long, somewhere in the vicinity of 12 months. If we delay a reassessment request until funding becomes inadequate, this could leave Kathy without support. These cases raise important questions about assessment consistency, transparency and timeliness. Most concerningly, lengthy reassessment delays are changing provider behaviour and encouraging organisations to manage around the system rather than rely on the system. As a local government provider, Council has a strong duty of care to vulnerable people in its community, is guided by the principles of public value, equity and community wellbeing. Council may face the real and very difficult decision of service continuity for clients based on available funding and capacity to pay, given what we are seeing play out in our community. The city's service delivery experience shows that inequity can also arise in regional and peri-urban areas that fall outside the current thin market eligibility settings, but still face significant unfunded delivery costs. The reforms are transferring financial risk and difficult ethical decisions to providers and raise questions about the sustainability and viability of providers to absorb the consequences of system change. Senators, the City will continue to work with the Commonwealth Government to support implementation reforms that improve outcomes for older people in our community, sustain trusted local service providers, support provider transition and reduce avoidable pressure across health and aged care systems. We appreciate the committee giving us the opportunity to highlight areas of concern in the supported home transition. Thank you.
Thank you. Ms Rogers.
Thank you, Senator. I've provided 3 documents here. One's a little more comprehensive than what I'm about to say, and a document that I provided to the Commonwealth on funding equity business case. Now that document is 2 years old, but the principles have not changed apart from the subtle, minute increase in the unit pricing. Mount Alexander Shire Council at an in-camera meeting in October 23 voted unanimously to remain in the business of aged care based on the financial modelling, including the introduction of home care packages. Mount Alexander Shire is currently funded for Commonwealth Home Support. We're an associate provider for multiple not-for-profit entities, Veterans Home Care, which we also do in Central Goldfields, Home and Community Care Program for younger people, and we're also a care finder. Mount Alexander Shire is also a member of the CHSP Alliance, led by Kathy Eager AM and Paul Sadler. The concept of supported home program is to deliver services by individual packages. Commonwealth Home Support is still to transition across to supported home, not before 1 July 27. Mount Alexander Shire Council is currently not directly providing supported home packages, but are being brokered, as I mentioned above, as an associate provider, and there's a reason for that. Mount Alexander Shire Council made application to the government in early 24 to register to be a home care package provider. This was granted around July 24. Once this was approved, the recruitment process for a home care package coordinator and a finance officer was undertaken. A second recruitment process occurred because of the need to secure the right person. So obviously time was moving on. The finance officer was secured and was tasked with gaining full understanding of the financial complexities. Once the coordinator was in place, then designing systems and policies were being developed with a view to go live. Whilst all this was occurring, we were reviewing our software with a view to upgrade to meet Commonwealth expectations for data and financial reporting. Tendering processes were in place. Information from the Commonwealth was still in the development phase about transitioning for the digital requirements. Whilst attending the digital transformations meeting, it was becoming abundantly obvious that the timing of implementing the home care packages, then transitioning to supported home packages, and the timing of implementation of the new software, and for the implementation for the software vendors, the deeming was not aligned for the Commonwealth, as well as for providers including Mount Alexander Shire Council. Categories and digital mapping were occurring, as well as the Commonwealth undertaking a deeming process to determine which category each service provider would be allocated. Early on, I reminded the Commonwealth bureaucrats that we were a registered home care package provider, and I was not seeing Mount Alexander Shire getting that status as part of the deeming process. This was raised in meetings and phone calls. I was advised in a phone call that yes, they could see the two registration numbers and not to worry, it would be merged under one registration number. Another phone call on this topic told me that the provided numbers were being replaced by ABNs. This was inaccurate. I was being reassured that all will be well and it will be sorted. The long and the short of it all, we are no longer registered for home care packages, in particular Category 5 for clinical and above, as required for delivery of packages under the new supported home program. When this was further followed up, I was advised that I'd been told, due to the fact that we hadn't commenced the packages, because I was waiting to get staff, etc., we would have to register again. To my knowledge, I received no such advice. We now must register for Category 5 if we wish to be a package provider under supported home program at a further additional cost for registration. Whilst we are not currently providing packages due to the deeming issue and registration, Mount Alexander Shire continues to be brokered for services as an associate provider. The Commonwealth has changed the reporting requirements for CHSP in preparation for transition to supported home not before 1 July 27. This has led to numerous problems. The CEO, in conjunction with my Director of Healthy Communities and myself, made the decision to not take up supported home packages for at least 26-27 financial year due to the ongoing dynamic environment. Multiple issues have occurred since the Commonwealth, since the commencement of the new can't even speak properly, sorry, that are burdensome and not in the spirit of client-first, person-centred care. Extensive waiting lists for assessments and or reviews is not person-centred care as far as I'm concerned. Majority of assessments, despite what was written in the contract, are being undertaken by phone. Incorrect information from the assessment around the client needs is being recorded. Lack of awareness of geographical locations of clients' home and referral codes to agencies 2.5 hours away from the client's home in Mount Alexander Shire, like e.g. Swan Hill, Kyabram, Echuca. Upon receipt of referral codes and categories for packages, many service providers' books are closed. We keep ours open, and we do what we can. Transition of CHSP to supported packages, again, not before 1 July 27, is of concern, though it is acknowledged that recommendations have been referred to the Senate to review this decision. Financial viability and sustainability for small providers, especially in rural and remote locations, is of considerable concern and anxiety for myself. Clients being asked to sign an agreement with no definitive financial co-contribution listed as they are waiting on Services Australia to means test. In this other document, I question the legality of that. It's the only time I've ever seen you can have this service, but we'll tell you one day what that's going to cost. Documentation is bureaucratic and burdensome for clients. The Commonwealth departments continue to change requirements, resulting in adding significant burden to the providers and further confusion. Ongoing changes to policies and guidelines within the Commission, whilst necessary, are incredibly burdensome. Many providers do not have software. Many systems are not functioning as they were intended. So that's my quick summary.
Thank you very much to both of you for your opening remarks. And can I just start off by saying thank you very much for remaining in the business of providing care. We know that care provided by local government authorities is often care that people are very happy with and would like to see more of. So the fact that your councils are staying in that space is really welcome. I might go to a couple of the points from the City of Greater Geelong submission first, and I'm happy, Ms Rogers, if you want to add on anything to those. You note that co-contributions, the co-payments, may discourage people from using services. I'm interested to know what you are seeing on the ground in relation to that.
Yeah. So we have 300 packages. We're constantly working to sign people up. We have people sitting on the CHISP services. So people are now starting, because they're moving into this is not the grandfathered group, yes, who are making decisions on the dollars and are saying we'll stay with CHISP. So that's defeating we're going to start to block up CHISP. I need Anthony's identified the number of people who are waiting. CHISP is finite resourcing. I need the throughput. So that's a problem where people are, they just can't afford to make their contributions. And when they look, well, if I stay with CHISP, I pay maybe $10 for my home care, $13 for a meal. That changes significantly when you move across to the package. So that's what we are seeing, people making their individual decisions, and that is their choice.
Yeah. You've also said that financial hardship protections need strengthening. What are you seeing in relation to the number of people who, first of all, need access to those financial hardship provisions, I guess the ease of application, and are you seeing people actually getting approved?
Okay, so I spoke to my care partners and they said that there's a reluctance from their client group of wanting to go through that process. So I can't give you examples. My clients are saying they're not wanting to go through that. It's quite a tedious process for clients, and to go through to become supported home clients. So that's what we're experiencing, is that it's short. It's either short term, so there's a opportunity for people to even do a little bit of, it's not just the financial hardship, but go back and use some CHISP funding, so for 12 weeks to give them some type of reprieve, but that requires yet another assessment. It is, as a manager, and I'm having this explained, it's very counterintuitive. I've got CHISP. We could quite easily flip to say, okay, you can access CHISP, but it's got to go through the single assessment service, which there's just delays everywhere. So it's kind of not worth people's while of going through these processes.
Yeah. What else did I want to ask? You've also noted issues with the assessment system and the fact that it's not consistently recognising need. Can you give us some examples of what's going on there?
Yeah, so there's certainly the scenario, we gave 3 case studies, and like Anthony said, we've only just changed the people's names, and there were many more that my team put up for me to present to you. So we've had a client with increasing needs. So we asked for a reassessment and they're downgraded, which is perplexed our care partners. We then had a woman who, yes, needed a reassessment, who has a registered carer, a grandson, who then moved up to the top end of packages. And I think I put in, she needed a bit of allied health, some transport, and I think it was domestic assistance. That's perplexing. So one of those, we also had, I think Gwen was a casualty of the algorithm, so that didn't work for her, but this other lady has made this colossal step up, and she, so we're confused. My staff are confused. There's reluctance. Should they put clients up for a reassessment if this is what's going to be the result?
Okay. I might go to Senator Nandaraja.
Thanks, Chair. You are one of a handful of councils that are left in this space. I just am interested in better understanding the kinds of services you actually provide and the staff that you've got. So have you got, for example, clinical assessors, support workers? Have you got maintenance crews who can go out and put in home mods, IT, allied health support? Can you just unpack for us the types of staff capability that you have in-house?
Okay. So we have a large home maintenance team. We have community care workers, and they are all qualified and they deliver domestic assistance. They can take people shopping, deliver personal care. We have care partners, and we have service coordinators who establish services for our CHISP clients. And then we have a team of team leaders and our customer assistants as well.
And allied health support?
We don't
So that's
have
outsourced.
allied health on staff. We have in excess of 200 associate providers. So we've got a large number of providers with a lot of variability in pricing and availability.
Are they the care partners that you refer to?
No, the associate providers are the people who will deliver, like they might be delivering allied health for us.
Okay, right. And so what's a care partner?
A care partner is what they used to be called case managers. The new legislation now has them called care partners. So a big change for care partners is they must bill 10% of the client's package. So it means they've got to be connecting with their clients every month in order to cover their costs. It's also probably ensuring that they're having more contact with their clients. So that is, it's not all doom and gloom. This reform like that I think is good, that we're requiring our care partners to have contact with the clients.
I was going to say, I think as a large organisation as well, we're able to lean on and lean into some of our other parts of the organisation, so communications, IT support, finance, risk management. So there's a whole range of those, that expertise that sits in other parts of the organisation that we can support as a large rural city. That might not be the same for all local governments, particularly some of our rural and regional friends.
Yeah, so on the topic of your partners, like we were talking earlier and you said there might be 28, 29 councils that are still providing this kind of care. Do you communicate with each other? Do you pool resources? Do you learn? And how do you do that?
Today's the first day that we've met in person, but we are on Zoom frequently, and there's an email exchange if we want to with our counterparts. So local government has a very tight connection with our counterparts and work closely together, sort of thing. And sometimes collaborate. We might share policies, guidelines if somebody's struggling with something, or we invariably may counsel each other when the going is getting tough.
That's correct.
Yeah, that's
Benchmarking, quality improvement. Yeah.
And you know, switching from the old Act to the new Act, obviously there was a lot of resourcing required to upgrade. Do you want to just talk us through transitional arrangements that happened at that time, including funding, and what would be important going forward?
Yeah, thank you, Senator. It would be our observation that there's been very limited transitional funds, and I can give you an example. There was $10,000 offered towards ICT upgrades, which is just significantly underdone. Our particular program that we use, which is Civica Care Connect, CareLink, we've had to do a significant amount of work. We had probably $150,000 worth of internal ICT support to get the system working, which was a significant hold your breath moment. For about 5 months we weren't able to actually claim any money, so it's a very significant financial risk. On top of that, of the annual licence fee, and then the work that is done just to keep the system going in terms of the work that the team do, there's hundreds of thousands of dollars. We didn't apply for the $10,000 because it wasn't worth it.
Yeah,
for the
right.
amount, for the scale of what we actually need.
So you had to
spend.
apply for that money. It wasn't just
correct.
Interesting. Okay.
Yeah. There was also an opportunity for the Commonwealth to reallocate some funds, some underspend from the Commonwealth Home Support Program, which we had requested to invest in transition. That request ultimately was denied, and that was about, we'd signed an agreement, and part of that agreement was you needed to pay it back if you didn't spend it. So that's certainly what we're doing. But there was a missed opportunity there for funds that had already been allocated to the City of Greater Geelong that could have been invested in transition and a whole range of activities to support not just transition, but actually bringing us up to where we needed to be in terms of the delivery of the reforms.
Yeah, okay. Yeah. So you've committed to continuing to provide aged care to your community. How has this been received in the community? And I also note that unlike some other providers, you've got limited taxation levers here, for example. You can't tax deduct, depreciation is not on the cards. So viability is going to be, I guess, the big issue going forward. What should the committee consider in terms of ensuring we maintain council in this space, but also maybe crowd additional councils into aged care?
I think there's a great opportunity to see local government as a really trusted provider, and that will take some nurturing. And so, if there are opportunities other than simply referral to a consultant, if there are opportunities to fund some innovation. As I said to you in my opening remarks, we've had to look at service reviews over the last 12 months, constantly adapting. So sometimes we would go down a pathway and that wouldn't work, and we'd have to come back and try something else. So I think there's opportunity, and that costs money.
Yeah.
So it's not about wasting money, but it's about making sure that we can, really deliver the best for our community. So I think there's an opportunity there for some innovation funding. The block funding certainly will give us that opportunity to be able to just balance out expenditure on clients and making sure that we can meet all those client needs that are emerging. In terms of how it's been received, and Pam may be able to give some specific examples, it's been very well received. In fact, so much so to the point that there were times where there were, potentially other providers that were concerned about how well we were being received as from a competition point of view. So it's been very well received by community, and as the numbers suggest that we've talked about, you can see that growth in the numbers, and that's only going to continue, particularly from a population point of view as well. But Pam, I don't know if you want to add anything.
I think that's right. I think that because of our size, we also attract like a large workforce. So there's probably some areas that are more difficult to service because of their distance from the city. We can ensure that we pay our staff travel, like Meg raised a number of things that we just offer our staff: training, travel, phones, uniforms. We pay above award. That's attractive. Our staff still will make decisions about that distance, the travelling, where we have an enterprise agreement with a set amount that we pay our staff for their petrol expenses. I think today that's going to be raised as an issue because it's going to hit them. They've had a nice break, but that's going to be an issue for our staff as well. So I think we can service people who live further away from the city. In that is more difficult for some of the other providers who also look to us as like you're delivering an associate provider, so they'll broker from us. So some of our supported home kind of competitors will purchase our services.
I might draw you in, Ms. Rogers, but while you're talking, just have a think about what we can consider with regards to fleet vehicles. There's obviously a big push, but we'll go to Ms. Rogers first.
Being a smaller municipality, financial viability is of significant concern to me. And as I say, the model that we put up under the home care packages was financially sound. That's gone out the window. I have councillors asking me, we report to the council every quarter, asking me, have we made the right decision? My advice to them at the moment is, can you just give us another 12 months before we do another review? The current councillors are committed to providing this service. However, it's only another election away, and that could change. The community are incredibly grateful that we are in it. They often tell me that. We do routine surveys of the community. Now, I've been in this business a long time, and I know when I was with the City of Greater Bendigo, we rarely got a compliment. We get plenty of complaints. We get more compliments now than complaints, and that's independent of when we do the survey. And to the point, I think that the compliments, they're too scared to say something negative for fear of losing the service. Now, that's a sad indictment, I think. I mean, some of them certainly come back and tell us they're not happy, and that's fine. But I think it's a sad indictment because they're watching their friends in neighbouring municipalities. And Mount Alexander Shire is the last remaining local government in the Loddon Mallee region. So I've no longer got any regional counterparts. I did have a neighbouring municipality ring me up and say, been asked to ask, how much would it cost if we got back in? And I said, don't.
So we've got sort of 311 million for this thin market grants. How has this been? Have you accessed it, or
I've attempted to apply, and we were deemed not eligible. And part of that, I believe, is the way the postcodes are allocated around the M&Ms, because I'm thinking this particular place that they've got marked as part of Castlemaine is so remote, I would never find it without my GPS.
Right. Okay. So peculiar. I was interested. My last question, Chair, just on this issue of transport, right? This is obviously a community-based service. Workers have to travel. How does a large council, like City of Greater Geelong, think about, fleet upgrades? How do you plan for something like that? And, obviously electric vehicles are there are hybrids, so on and so forth. Just more fuel-efficient cars.
So we don't have a fleet specifically for community care. There are fleet vehicles that can be accessed. That's probably challenging during the week in terms of their use. Unusually, there are only business use vehicles in the whole council from the CEO down. So we don't actually have vehicle allocations. We have one of the challenges we have is that mileage can provide a fairly reasonable boost to care workers' salary or pay. It's probably a little counterintuitive in terms of the wear and tear on the vehicles, but it does actually show up as a cash contribution in your salary. So there is this tension as well around how that works, and and then as fuel prices go up, obviously there's also tension now around our workers wanting additional mileage, which is outside of the enterprise agreement. So that's going to be probably the next issue that we will be discussing with staff and
so
and
that's
the unions.
interesting, isn't it?
Yeah.
It sounds like it could be a perverse, incentive.
So if there was a pool of electric vehicles, and we do have all the charging stations, and that would actually reduce the salary, the pay packets of the workers, which would be. So that would be a sort of an unintended consequence, and probably a negative one in terms of some of the people that work for us.
Just last question on notice. If you could provide some information to the committee on the proportion of these assessments that are happening by phone versus in person, that would be helpful.
Sure.
The vast majority, but I don't have the stats. You would actually have to go to the assessment agencies. We do all of our intake and assessments in person, unless it's a follow-up a couple of months later to say how did it go. But we do.
So the initial one is always in person, is it?
No.
So
The assessment agencies that do the IAT, they're meant to do it in face-to-face, but we know when a client rings up and says, somebody from Mildura or Geelong has rung me to do an assessment, and then when our intake and assessment people, which are onboarding and developing the care plans and going through agreements, go through that, they're finding that the information's not there, so they're actually doing their job.
Oh, interesting.
there's variability between the councils. So we, like you were saying, Rosalie, the single assessment service will be able to tell you the percentage of face-to-face. I think following the algorithm discussion, there's been more face-to-face assessments. For the CHISP services that we're organising people's service starts or care plans, we do ours on the phone. So, so there is variability there. But,
And one of the things that I would say on that, since prior to the single assessment being implemented, my KPIs of what we had completed for personal care was just marginally over 100%. The first 12 months after the introduction of the single assessment, that plummeted to 78%. We're just not seeing them in the portal. And now that's the end of this financial, that's gone down to 55%. Now, you can't tell me that people out there, as they're becoming more frail, are not needing personal care. Where are they? I don't know. I have raised that with an assessor, and they indicated they've got 800 reviews to happen. But all of the new ones, we grab them if we see them. Given that we're the only CHSP provider, we're not seeing them.
and I can echo that. It's odd we're not meeting our CHISP personal care targets. As soon as they land, we pull them off the portal. So I think that's...
And for me, at a small municipality, that's $330,000. If I don't meet my KPIs, they're going to take that off me. Now, if I lose another $300,000 out of my budget, that will be the nail in the coffin.
Got it. Yep, so it's interacting. Yep. Okay, thank you, Chair.
Senator Askew.
Thanks. Thank you very much for your evidence. It's been really interesting, and I think most of my questions have been covered, but I've got one for Ms Rogers. Just in your submission, you mentioned in there about reinstating the traineeships. So obviously workforce is an issue in all regional areas. That's something we've heard nationally. But this was something I wasn't aware of, is reinstate traineeship funding for apprenticeships and traineeships to facilitate additional staff. It's got in there no longer available from the 1st of January 27. So that's something that doesn't...
From organisations that have 250 employees and above are no longer eligible. Now, local government have about 100 different types of services that we provide. Aged care is but one, and I have been using them for the last 5 years to ensure that I have staff. And 97% of my staff now, in the field staff, have gone through the earn and learn model that we set up to ensure that they could have, as a minimum, a Certificate 3 in individual support.
So that situation will cease at the end of this year,
Yes,
and you won't. So your staff going forward, you will either have to meet the cost out of your existing budget,
which we have been doing. But when it first was there, $10,000, that was great. That was covering wages and sending them off to class and things like that. Now, even $1,500 isn't really doing anything. And I think it's short-sighted when we know we have a chronic shortage of staff, not just in aged care, everywhere. And the baby boomers, the baby boomers are yesterday's workforce, and they're entering aged care, and there isn't that huge volume of us coming across. Generation X isn't quite as large a cohort. Where are we going to get these people from? And we haven't got to the pointy end. That's 10 to 15 years' time when we've got all of the baby boomers in there, an element of Gen X, and we'll still have a slither of the silent Gen in there. So we're not getting it right now. If we don't get it right ready for 10 to 15 years' time, if we think we're in pain now, we're in a world of pain in 15 years' time.
So did you have anything to add on that in regard to workforce?
So we are seeing a lot of people coming to us who are on visas, and what I'm noticing, so it's very much a part-time job. There's a range of people who will we offer permanent jobs, the permanent jobs with us, then realise the amount of work that we're offering is not enough for them, and they will then jump back into residential aged care.
Okay.
Yeah. So it is a terrific part-time job, which is predominantly for people who are balancing their own caring responsibilities. It's not as attractive for people who are wanting to have a full-time work role with us. We have a lot of occupational health and safety requirements, so it's really important to us that our staff don't get injured. So we're very strict with the amount of domestic assistance people can do, which typically limits the amount of work that is available for our staff.
All right, thank you. I'm conscious of time. Thank you. Thanks for that.
Thank you very much for taking the time both to submit to the committee and to come before us with evidence today. It has been really helpful. The committee will report to the Senate on the 24th of November 2026, and we've agreed that responses to questions on notice should be provided by close of business on Friday the 21st of August 2026. And thank you very much again.
Thank you.
Thanks. Okay, next piece of paper. Yeah, she's giving questions to you. No, I'm just talking about the lived experience witnesses. I can see Peter in the room. And then we've got Lynn.
Well, he'd be late 30s and Tim's 39. I know, it really does. That's horrible. And Amanda says, and I've said to her, you just don't know what's going on in someone's mind, and that's what she said.
Thank you.
And it doesn't change the fact that it's too late.
I love that sign. That's the easiest. That's the easiest to read sign I've seen since we've been.
Hi, Michelle. Good day.
Morning, everyone, and morning to those who are joining us online. This session is an opportunity for the committee to hear from members of the community about their lived experiences, and I remind the members of the committee that this is a listening exercise for us. I would also like to remind everyone that it's a public hearing, these are formal proceedings, and the Senate and the hearing needs to be conducted in an orderly and respectful way, which I have no concerns about at all. I'd also like to remind witnesses not to disclose any personal or private information, such as your full name or your date of birth or your address during the statement, because we are broadcasting live, and once it's out there, we can't get it back. I'm now going to welcome Peter, Lynn, Linda, Deb and Jen, and I want to thank you all very much for appearing before the committee today. We're now going to do something that feels very weird when we're only using first names, but I'm going to call on each of you to state your name for the Hansard, which you need to do even though I've already said it. So I might start in the room and we'll just go left to right, so you could just state your name.
Hi, I'm Deborah.
Peter.
And Lynn.
And I'm now going to go online and I'm going to have to call on you so that you know it's your turn, which is where this starts to feel weird. So Linda, if you can just say, hi, I'm Linda, that would be great. I think you're on mute, Linda.
Very sorry. Hi, I'm Linda.
Thank you. And Jen.
Hello, I'm Jen.
Thanks very much, everyone. I'm now going to give each of you an opportunity to make a short statement of about 10 to 15 minutes in length, and it'll be over to you, and we will all be listening really intently. So I'm just going to start and work my way across the room. So I'm going to go to you, Deb.
May I just grab my booklets? Can we give... Thanks, sweetie. Just in front of you. No. Sorry, guys. That's for you to look at. So I'd like to begin... First of all, I'm very grateful for the opportunity to be here. I feel very privileged, and I'd like to acknowledge how fortunate we are to live in a country that cares so deeply about our elderly and vulnerable Australians. To introduce myself, I'm a retired educator with a background in disability, learning support and wellbeing, and I'm now studying dementia at the University of Tasmania. I was introduced to dementia a few years ago through the lenses of 4 people I care for, and since then I've experienced Australia's aged care system through those 4 lenses. A stepfather who needed emergency respite but couldn't access the home care he was funded for. A failure that set off a chain of events ending in his preventable death only 3 weeks later. A father whose assessment was fast and effective, but again whose approved services simply didn't exist. A mother whose care works well, but that was because we found the right provider very early as a result of her being in hospital. And an older gentleman with dementia, alone in a hospital ward who had no one until we stepped in. These 4 experiences taught me a single confronting lesson, that the system doesn't fail in a uniform way. It fails differently for every person who needs it. And when it fails, the cost can be measured in lives. So these experiences have led me to 3 points I would like to share. Firstly, that older people enter aged care at a moment of crisis, which you're all aware. Next, that the information provided is not easily understood. And finally, that the system depends too heavily on families to bridge those gaps. So firstly, my first observation is that families rarely enter aged care from a position of calm. They enter after a diagnosis, a fall, a hospital admission, the death of a spouse, or a sudden realisation that someone is no longer safe at home without support. They are frightened, grieving and exhausted while trying to understand this complex system and to make those decisions. With my own father, I spent 2 days calling around 20 providers, and every conversation began the same way. I explained his circumstances, answered the same questions and heard the same response. There is no capacity. Every call meant that my father still had no care, and every call felt like a personal rejection for me. Like a punch in the gut, very upsetting. So as a consequence of that, I wouldn't make any more calls. So we ended up paying for our own care via a different pathway. We would never expect a person whose car has broken down on the side of the road to phone 20 mechanics, repeat the story and so hope that someone has capacity. We send roadside assistance, and aged care should work the same way. Choice has limited meaning when there is only one provider or none. At present, there are 2 valuable roles in the system. A care finder who helps only the vulnerable people navigate the system before they connect with a provider, and a care partner who coordinates care after a provider has been chosen. Both roles are important, but there remains a significant unsupported gap between the moment an older person first needs help and the moment it is delivered. And that gap affects all of us, because at the point of need, every older person and every family is vulnerable. I believe that every older Australian should be offered an independent, what I'm calling a care anchor, from the very first contact with the system, or even earlier. For example, at a defined age, once you reach the age of 65, you're educated as to what could come next. Maybe it's the GP, the pharmacist, I'm not sure. And introducing this kind of support before crisis so that we all understand the boomers that are coming through. We know what to expect. We're prepared for assessment. We know what it involves. So this person, this care anchor, would help interpret the outcome and remain alongside the family until services are in place. Now, this is already happening, as you're probably aware, in the NDIS. I have a friend who works in the NDIS, and I was struck by how effectively her role works, walking alongside participants through a very similar complicated system, and it demonstrates that this can work, and I passionately believe we should be doing that. As I alluded to already, I do believe that the responsibility for connecting approved clients with available providers should rest with the system, not with distressed families. Once a person has been assessed and approved, their needs should enter a centralised matching process that identifies the providers with a genuine capacity and connects the services to the people. So as it is, I heard earlier, the evidence, we're leaving all of this onto the providers. We're all making calls. The providers, they have to expend their time to answer our calls and say, sorry, we don't have any room at the inn. So I also believe that this has have the extra advantage that it would allow the government to identify where those unmet needs are, to monitor the waiting times and understand where the additional workforce is required, plus whatever other amazing things that could do. Crucially, once the need has been approved, the responsibility for connecting the person with the service sits with the system, not with the providers, not with the families, because we're under such stress already. Secondly, throughout my career in education, one principle guided our work, and it's called a universal design. In schools, we don't expect students to adapt to a system that excludes them. We design the system so every student can access learning regardless of their starting point. Aged care should operate on the same principle. The system itself should be designed to be accessible, understandable, and supportive for all. I want to give you a good example of that. In preparation for this, I read the Principal Guide to Ongoing Support and Home Services online. Is everyone familiar with that? It's 44 pages long, contains 8,500 words. For many Australians, that represents close to an hour of online reading before even interpreting the unfamiliar terminology and considering decisions. The difficulty is not simply the length of the document, it's the combined burden of the acronyms, the financial tables, the eligibility rules, percentage ranges, the multiple pathways, and references to still more documents and links. So not until page 14 is there something simple, which is a flow diagram. But I want you to remember, you've probably already lost our audience by page 14, and let's remember that most of them don't have a device. So how are they? And I'm listening to your previous evidence. They were saying that they can't reach the clients. But I'll give you more information about that. Australian research shows that only 28% of people aged 65 to 74 have the literacy skills to understand that online document. And Australia has more than 2 million people aged over 75, which you're probably aware. And around 1.5 million of those don't have a computer or any skills. So they're the clients that are out there and we don't know where they are. We can't help them. So yes, reflect on that for a minute. These are the very people who are likely to need aged care support, and they're the most likely to struggle with the very information and the way it's currently presented. Finally, my final point concerns the extent to which the aged care system depends on us, families. I want to return to the older gentleman with dementia that we met in hospital. For 3 weeks, we watched him sit opposite my stepfather in a hospital gown with the same untouched bag of washing beside his bed. How could I not betake his washing home and look after him from that point? We later discovered he had already been in hospital for 3 months with no support from outside the hospital and very little from inside either. By the time we became his legal guardians, many of the important decisions had already been made. So he was actually finally, after a few more months, he was eventually granted a place in aged care. But he could have, I wonder, if someone had recognised him sooner, would he still have remained in his own home? So there's a whole sequence of events I could speak about there. So we need to ask ourselves, do we believe that there's a good Samaritan for every kinless person? His story reminds us that the system cannot assume someone will always be there to notice neglect, to recognise need, to ask questions and keep pushing until help arrives. In addition to that, a service can appear to be working simply because a daughter, a spouse or a friend is quietly filling every gap. And that unpaid work can hide weaknesses in this system. My situation also reminds us that families who do step in are often already caring for more than one older person. The system rarely sees this hidden workload, yet it relies on us very heavily every day. When I first began thinking about this issue, I believed that people living with dementia were those that most needed specialised support. Through preparing this submission, my thinking has changed. I now believe that this support should be available as a choice to every older Australian entering the aged system, so a partner right from the start, as they do in the NDIS. Families provide love and continuity, but they cannot replace a well-designed system. And not all families have the capacity to carry the load. It's very heavy. So no Australian and no family supporting them should ever have to navigate this system alone. And I would just also like to say that I speak today in honour of the loved one that I did lose, and that his experiences are the reason that I'm here today to help other families.
Thanks very much, Deb. I'm going to go to Peter.
Peter, polio at 4, 2 weeks ago, a pacemaker implant. Operations 3 hours, frozen shoulders, position to prevent movement. It's raw, it's fresh, lying in post-op, nurses managing my every move. At home, my bed has slide sheets. I can transfer to the bathroom.
Code yellow, overhead announcement system down. Please refer to mobile pages for code responses. Repeat, code yellow, overhead announcement system down. Please refer to mobile pages for code responses.
That's what happens when we're in hospitals. Back to you, Peter.
At home, my bed has slide sheets. I can transfer to the bathroom and pee independent. In hospital, I slump to the bottom of the bed, unable to reach buzzers and bed controls. I gasped, unable to reach my BiPAP mask. At home, I can open the front door remotely and exit for a bit of sun or a chat with a neighbour. I can turn on heaters and lights, shower seated, dry and dress myself, even put on pressure socks and do up my belt. I'm a lucky bugger and a home built for me. However, a life in narrow hallways of 3-point turns, reverse wheelchair opening doors, 1.5 by 1.8 metre bathrooms, 2.7 by 3 metre bedrooms, rattly ramps and microwave meals is a very different life to mine. More so, hospital or resi care would have me lay in bed, glaring and unreconcilable aged care statements. So support at home. Inflationary pricing, cuts to care hours, unaffordable gaps in co-payments, baffling governments, administrative overkill. Older people go without, opt out and die without. 4,812 older Australians approved support at home died before receiving a single service in 24-25. That is a person promised support, abandoned to hope, dying every 2 hours. In 2019, 58,936 people were unsuccessful with their application for a home care package. However, 96.3%, that is 56,777 people, were given approval to access CHSP. They had not been ignored or abandoned. Today, over 100,000 people wait to be assessed. Today, another 100,000 wait for services to begin. Reform, 20 billion spent on what? In 2019, the program known as Support at Home was designed in principle and costed. It is my proposition that little has changed the intrinsic 2019 model and that millions spent on outsourced consultations was a process to substantiate what had already been decided. There are hundreds of documents cited by government from 2019 that support this view. Of greatest concern is that the department proceeded with the 2019 model and timetable in spite of serious concerns raised by sector experts and older people receiving services. The lack of human input and the integrated assessment tool algorithm is just two examples. In 2022, Assessment Trial Advisory Group, the impact of algorithm was raised by ACAT assessors, health assessors and aged care professionals. We were told that the IAT was designed to recognise typical need. It was designed to recognise, if it had been designed to recognise high needs, the IAT would fail to recognise the needs for the majority of the 1.5 million older Australians. Assessors were told not to make changes. I pointed out that over 80,000 people receiving home care packages had high and complex needs, with many managing known and progressive pathways for their disability. Health acknowledged that disability could be flagged during triage and people undergo the more appropriate clinical ACAT assessment. The room sighed and we moved on thinking consensus would find its way into practice. We later learnt that a number of the successful tenders for the $1.5 billion single assessment program had been part of the IAT trials. There are significant documents available that raise concerns with who knew what, when, how and when. Senate hearing 9th of October 21. Department of Health submission number 13. For these reasons, to ensure the reform timetables could be met with appropriate enabling legislation in place, the Royal Commission Response Bill number 2 was not subject of an exposure draft process. Peak organisations including COTA, ACSA, OPAN, LASA, Estia Health were provided with an overview of the measures in the Royal Commission's Bill number 2 on the 1st of September and a detailed briefing on the 10th of September. The briefs were paid advocacy and industry groups except for Estia Health, recently sold by Bain Capital to Stone Peak for 2.5 billion. 16th of March 2020, to the Office of Prime Minister and Cabinet, the financial impact of home care providers as a result of changes. I also note that the regulatory burden to business, community organisations or individuals of changing payments from care subsidy to an approved providers to payment for services rendered has been self-assessed by the department, as they are less than $2 million per annum. 2021, Greg Hunt, the then Minister for Health and Aged Care, announced $17.7 billion to deliver once-in-a-generation change to aged care in Australia. Pillar 1, home care, $7.5 billion, residential, $7.8 billion. Pillar 3, residential aged care systemic improvements, $942 million. Workforce, $652 million. Governance, $698 million. 4th September 2024, certifications and impact analysis equivalent, Aged Care Bill 2024, page 129. Risk that higher co-contributions would lead to people choosing not to access services and to either enter residential care prematurely or go without services. Mitigation. The proposal is designed so that essential services people require are either free or set at an affordable level to allow people to continue living at home. Risk that IT is not accessible and or affordable for small providers. Mitigation. Smaller providers will continue to be consulted during development. 27th of May 25, Auditor General Administration of the Future Fit Program. Contracts totaling $14 million for what? To work out how much to increase the price of a frozen Meals on Wheels delivery? Auditor's findings. Health's administration of the Future Fit program was ineffective. Objectives were not achieved. Health did not establish sound government arrangements to support the delivery of the Future Fit program. Planning and conduct of the 21, 22 and 24 procurements were not effective and fell short of ethical standards. Health's management of the Future of Fit program contracts was not effective. 16th of October 25, just days before the 1 November start of Support at Home, a total of 72 million in grants to prevent or manage disorderly closures or financial failure. If the aged care system works, why would grants of this nature need to prop up failing business? Why would an administrator not be more suited to manage disorderly closures and financial failure? There is more than enough evidence for a referral to the Auditor General. Regardless of intent, the final amount paid by the Australian people is a price too high for this failed program that began under the Morrison government and became law under Labor. We need to build trust in our bureaucracy and our government. Sadly, there are well-intentioned people who are still in denial. Amazingly, senior public servants and their ministers still refuse to acknowledge that the current aged care system is doing massive harm. My written submission, number 25 on the Senate website, provides detail of why the aged care reform is a matter for the Auditor General. Same people, similar concerns, horrific outcomes. The government must hang their heads in shame that they signed off on a program designed to placate the largest number of people. By design, the numbers of failures escalate every 2 hours as a person dies, having waited for services for an average of 364 days. Let they, their families and friends rest in peace. I thank the Senate for this hearing, but was horrified when I learned the time devoted to reviewing Support at Home had been cut to half days, with no hearings in New South Wales or WA. I, unlike the government, am more than willing to answer questions. Thank you.
Thanks very much, Peter. Lynn.
Putting 2 photos of my dad, both taken by the Herald Sun, whilst investigating aged care. He wasn't just a number. He's a respected member of society, a taxpayer all his working life, a husband, a father, a great-grandfather, and a great-great-grandfather who was dearly loved. My darling dad, aged 91, was let down by the aged care system when he needed it the most. I convinced my parents to get an aged care number back in 2023 so that when they needed help, it would be a phone call away, or so I thought. I'd been incredibly lucky to have had parents that had maintained their independence and health to a certain extent until October 2025, when my dad was hospitalised with life-threatening sepsis. While he was in hospital, and only when I knew that he was going to pull through, I made a call to my aged care for help. I was told that an assessment would take place in 2 to 6 weeks' time. Fortunately, they gave me the phone number of the assessment organisation, as I had to chase up this assessment myself after 56 days, which is 8 weeks. And very surprisingly, I was told his assessment was going to be scheduled for that afternoon. Makes me wonder how long it would have been if I hadn't rung them, and maybe he had in fact slipped through the cracks. This assessment lasted for 5 minutes according to my phone records. It takes almost 5 minutes to do introductions, asking who is involved in the call, and introducing yourself as the assessor. If you've previously read my submission, you would know what my father's past history was, and how could a 5-minute phone call assess him adequately with all of his care needs. That afternoon, I received an email with a list of providers in their area who had capacity to be able to help us with what we needed. Most of them knocked us back. One never returned my call despite leaving a message, and I was on hold so long with one of them that after 45 minutes, the call dropped out. I then rang providers not listed after having just finished working in community nursing, and they couldn't or wouldn't help either, as I found out later after numerous calls that my dad was put on a package called a CHSP, which was as good as useless. Only one provider offered to escalate Dad's personal care needs to her superiors due to his age and never having had to use the system before, and despite them already being full with clients, they accepted him. 2 showers per week was what he was offered, but it cut the hygiene process for my dad to an hour twice a week from a 4-hour marathon, and then the rest of the day for recovering when he did the task himself. 36 days later, and after many lost days being on hold or told, sorry, we have no capacity to help you, resulting in lost sleep and grey hair from worry, he had another review. This time with a home visit, and he was classified as needing a stay-at-home package level 7. This, as you know, is the second highest available. You would have to agree that something was seriously wrong with the initial 5-minute assessment. I also wasted 3 days once waiting for the My Aged Care website to stop being under maintenance, only to find out that after an exasperated phone call that the site doesn't work on Safari. You have to use Google. Could something more meaningful be used, like please use another search engine if you were trying to use My Aged Care rather than just a blanket statement under maintenance? Just a heads up that many people use Macs and it is their default browser. It was much easier to talk to someone from My Aged Care anyway than to try to navigate a clunky, non-user friendly website. I thought our prayers had been answered when we got told about this improved package on January the 16th. I rang My Aged Care to see what I could get organised to help Dad before I went away in the February, only to be told it would be a minimum of 10 months waiting for his funding to come through. Someone who is deemed to be needing the second highest package available surely has to be shortlisted as a priority and not just added to the queue. That time frame is a lifetime for someone that age, and I wrote yet another email to the Minister for Aged Care to tell him this. I'd written previous emails on the 7th, 12th, 20th and 23rd of January highlighting the plight of my father and the elderly in general. I eventually received an email back from his office, but only after I'd contacted the Prime Minister's office, who passed it on to the Minister of Aged Care. It outlined what a magnificent job they'd done in assessing my parents, but that we just had to wait. I was proven right. My dad passed away on April 29th, 2 days short of turning 92, and his package arrived 3 weeks later in May. I wrote to the Inspectorate General of Aged Care about an interaction I had with an aged care provider and asked them to investigate. It wasn't something that they could do, but asked if I could be referred to the Health Department. Of course I said yes, as I wanted answers. This was my concern. Interestingly, on the day his letter was postmarked from Canberra, I received a phone call from an aged care provider who said how wonderful it was that my dad had his level 7 package. They could help me organise all my dad's needs. I wondered why no one could help us on the CHSP, but suddenly when there's $58,000 available, I had a care provider ringing me. Once I informed her of my dad's passing, she offered her condolences and said she would take him off the system. When Mum and I went to Centrelink 2 days later with certified copies of the will and the death certificate, although Dad's pension was stopped after the phone call I made 2 days after his passing, the lady there officially removed him from Centrelink and Medicare, and I said we should do aged care also, to find my dad was no longer on my MyGov account. The Health Department have since rung me to explain it was just a sheer coincidence that his name came up the same day as his package was released, as the care provider who called knew we were waiting an occupational therapist review. Amazingly, the government had also just found out about Dad's passing, and they had removed him themselves from my own MyGov account. She assured me it was all just such random coincidences that it all happened on the same day. So many so-called coincidences in the space of a day, it is hard for me to take any of it as gospel. The remnants of all this to my mum, who'll be 90 in October, is a profound sense of loss. both for Dad and for help they could have received. She feels let down as though she's been kicked in the guts by the Government of Australia. It is sad that she will now live the rest of her life with this anger and disappointment if she's convinced the government knew of Dad's passing and then gave him this package. I don't think she will ever want to use my aged care again when her needs increase, as the pain has been too great this time, and she knows that help won't be forthcoming. I guess it will be up to me to give up my life when the time comes to look after her. All this could have been avoided quite quickly and easily with the right assessment the first time, and we weren't asking for much. We needed a ramp from the back door into the garage so that he could enter and exit his unit safely, and a fall monitor so that he could have had contact with the outside world in an emergency, and would also allow my mum to have peace of mind when she left Dad alone at home if he needed help, as he was unable to use the telephone. He was being showered twice a week, which was a huge help, but we never would have spent $58,000 per year in our wildest dreams. They had simple needs, and it just needed a simple and a time-appropriate solution. It is laughable that when the first letter arrives from my aged care, it has a lovely glossy brochure in it about the rights of the elderly and to be aware of elder abuse when the people who are abusing the elderly the most is the Government of Australia. Thank you for your time today.
Thanks very much, Lynn. I'm now going to go to Linda, who's online.
Good afternoon. First of all, I'd like to acknowledge that I'm living on Darawal country, and I'd like to pay my respects to any Aboriginal or Torres Strait Islander people who are joining us online, if not in the room, and particularly to their elders. My submission is quite different. First of all, about me, I'm a Dementia Australia advocate, previously an educator, senior manager in New South Wales TAFE. I'm a weaver with the Illawarra Women's Health Centre, which means that I support other women who are supporting someone with dementia. I'm a founding and committee member of the Dementia Inclusive Kiama project, which was the first in Australia, and we began it in 2014. I'm a member of Elder Abuse Action Australia, and I'm a member of the Australian Association of Gerontology. Thank you for the opportunity to present my story, and I would welcome any questions for clarification. I'm a whistleblower, and I seek the committee's understanding of my position. My submission is brief, and I hope to the point. From 2021 to 2023 inclusive, I was the representative of the Older Persons Advocacy Network, that's OPAN, on the Assessment Working Group, which was established by the department and led by Health Consult, that's a consultancy business, to develop the integrated assessment tool. During this period of work, I was bound to confidentiality. However, since the IAT has been in the public domain, I have agreed to speak about the process of its development. I've spoken with a number of journalists, with the Commonwealth Ombudsman's Office at their request, and I've communicated on social media. The members of the Assessment Working Group were not informed that algorithms would be applied to the scoring of the IAT, nor to the process of classifying people for funding purposes. We developed the tool for use by clinicians, anticipating that it would be used to develop client support plans. I now feel personally cheated, as well as horrified by the numbers of incorrect assessment results produced by these algorithms and the consequences of those, as we've heard just now. To my knowledge, they were produced in-house, the algorithms, and have not been evaluated nor validated. Mr. Blair Conley, the Secretary of the Department, has already testified that aged care funding is rationed. And I believe that the purpose of the IAT was conceptualised several years earlier to do just that, but that it was not revealed. The Royal Commission envisaged a single assessment system that would be accessible to all. However, government waited until the eve of the enactment of the new Act on the 1st of November 2025 to remove the capacity of clinical assessors to override any incorrect results. The IAT, by the way, has an inbuilt override mechanism, which we deliberately designed. The IAT is iterative, that is, people only need to be assessed as far as is relevant to their situation at the time. The tool is flexible and it allows for further assessment when the person's circumstances change. It can be administered via hard copy where, for example, there's insufficient or no internet connectivity. However, results must be entered into a live portal where the results live so that there is no need to repeat the whole assessment at a later time where circumstances remain unchanged. The trial of the IAT through 20,000 assessments provided feedback from clinical assessors who requested the addition of more free text fields to add their comments. The assessment working group reconvened in 2023 to adjust the tool in line with assessor feedback. However, and this is the key point, algorithms cannot deal with qualitative data, which means that assessor qualified judgments are now not taken into account because the algorithm can't deal with comments. Personally, I have some reservations about the tool that we developed, and I believe it needs review. I think it needs to capture pre-existing trauma and also investigate complex conditions in more depth, including cognitive and psychosocial disabilities. I'm particularly concerned about the assessment of the impact of progressive conditions, for example, Parkinson's, the many forms of dementia, multiple sclerosis, cerebral palsy, motor neurone disease, and other conditions where symptoms change over time, often unpredictably. The effects of childhood polio, for example, often lead to debilitating changes in later life, as Peter well knows. As dementia is now the leading cause of death in Australia, and as prevalence increases with age, the need for funded rehabilitation and maintenance of function is acute. It may be possible for the restorative care pathway to provide episodes of multidisciplinary interventions by allied health practitioners. But get this, there are only 20,000 restorative care places nationally. And I contributed to a submission about the need for restorative rehabilitation care for people with dementia. About me, I'm a grandfathered client who self-manages a level 1 transitioned home care package. I am worse off under supported home because my provider now adds 9.8% to the cost of each invoice, and so my funding does not extend as far as it used to for the services I engage. My late partner's level 4 home care package, also self-managed with my help, used to buy 20 to 25 hours a week of paid support. On supported home now, people at the highest level of funding are receiving half that. Why is that? I was the sole unpaid carer of my late partner who battled a complex young onset dementia for 15 years. She entered the aged care system in early 2014 and died in 2024. So this is how long I've been dealing with the so-called reforms. I'm acutely aware of the inadequacy of ongoing government funding for necessary supports and of the absolute unsustainability of relying on informal family support to plug the gaps. We didn't have any family support, nor did we have any support from friends. Many of us have had to reduce or entirely give up our work, affecting our super, and that's my situation. Not only does it affect our financial security, but the workload affects our health. For example, I provided 60 hours a week of informal support over 8 years, which worked out at 50 cents an hour on the carer allowance. I went from a 6-figure salary as a senior public servant to subsistence now on the disability support pension as my only source of income when I've just turned 75. In addition to a permanent spinal disability, I now have a diagnosis of aortic stenosis, a result a number of people, clinicians believe is the result of intense and prolonged stress, and I also am trying to deal with PTSD. I'm barely able to walk, and I hope to soon have stents inserted into my legs. That's how bad my health condition is. I intend to apply for reassessment, hopefully, and I hope to eventually receive more funding. But in my region, the wait time for assessment is 1 year or more, and then there's a further wait before being granted just 60% of the agreed funding. And I should add, after what I've heard recently through these submissions, these hearings, that I'm actually reconsidering whether I will even risk reassessment. Because if I lose the support that I have now, life won't be worth living. I do not believe that CHSP should be amalgamated with support at home, which is an individualised transactional system, not relational. While I personally appreciate being able to engage workers of my choice, ensuring continuity, I think that CHSP, if it's properly funded, has the potential to provide primary levels of support to a large number of older people in line with the role of primary health. As the Inspector General of Aged Care said, prevention costs less than crisis intervention. I'm a member of the CHSP Alliance. Thank you very much.
Thanks very much, Linda. And now I'm going to go to Jen.
Good afternoon, and thank you for this opportunity. My husband has dementia. I'm his informal carer. We are somewhat supported by a supported home grandfathered, fully managed, transitional level 4 home care package with a dementia supplement, and we live regionally in Victoria. I come before you having worn several hats across my career, a retired registered nurse and hospital manager, and now I'm a volunteer advocate for Dementia Australia and a member of the CHISP Alliance and the Australian Self-Managed Supported Home Consumer Core Group. But my most vital role is being my husband's informal carer. I have not ever before felt this need to be so involved in advocacy, but our lived experience in my advocacy has shown me clearly how difficult it is for older Australians navigating supported home alone, who are less digitally able, who may not have a smartphone or computer, no background in health and policy, are more frail, living on the fixed income of an age pension. Supported home should provide timely, appropriate care to all Australians, and it simply doesn't achieve this. I'd like to start with the glaring inequality of health systems across a lifetime. If I live with a disability and receive NDIS funding, once I turn 65, I can remain on NDIS with a substantial larger budget. However, a person over 65 with a pre-existing disability who missed the NDIS rollout, now experiencing age-related frailty, is relegated to the supported home program on a much smaller budget, same needs, different budget, hugely unfair. Wait times within the supported home program, from assessment to being granted a package, to accessing restorative care, assistive tech and home modifications, are red flags to a person's safety and capacity and lead to unnecessary hospitalisations, premature entry into resi care and death. I wonder how many older Australians have found the process too hard, too stressful, and simply given up, only to present later in dire need or worse in our public health system at great personal cost and higher cost to the government and taxpayer. We need to actively partner to move from managing decline to proactively fostering wellness. With the new Aged Care Act, we finally have an aspirational rights-based framework, but this does not translate to the lived experience of many. When systems lack flexibility, we create real-world gaps and we enable the potential for harm. If the department and ministers would just hear our lived experience voices, we can collectively, in partnership, make a difference. Lived experience consumers and volunteer advocates need a seat and an equal voice at the policy table. We need to return to the table to strengthen the CHISP model as the first tier of support to actively prevent deconditioning and to promote functional capacity for those waiting on a support at home funding. There is little purpose in having a My Aged Care assessment receiving codes for care to be unable to find providers with capacity to provide services. There are older Australians waiting at the front door of the system, waiting for assessment, waiting for a package, hoping to find a supported home provider with capacity, hoping to be able to afford the care they so desperately need, hoping for guidance to prevent the frustration of navigating this terrible system alone without advocacy. We are over 3 years into living with aged care, firstly with CHISP, then with a home care package, and now supported home. But more and more, I feel the reality of system-imposed sadness as I read and see older, more frail people in their family trying to access care, trying to get in that digital front door. It's heartbreaking to know even one older Australian has died, let alone thousands, while the system beds down. Older people are at the pointy end of life. We don't have time to wait. We need appropriate care now. This should not be happening. It's a national shame. There is even a wait time for palliative care. Almost 5,000 people died 24-25 waiting for their package. They're huge figures, obviously showing there's huge need for urgent reform. Under supported home, we have noticed the impost of further hurdles in achieving support and choice. For example, previously in-scope dose administration aids are now funded by a siloed 8th community pharmacy agreement. Living regionally, our local pharmacy hasn't subscribed as yet to this agreement, and we've had no guidance on how to bridge this gap. Without a dose administration aid, if my husband lived alone, he would forget or confuse what medication to take when. He would decondition, end up in hospital, and perhaps face premature residential care. All that to save $20 a month on a Webster pack. Together, we can ensure siloed policy changes don't strip away tools for independence and capacity. With the introduction of support at home, our care partner, our provider, now has a policy of central procurement of our supplements at up to a 33% cost increase when compared to a discount chemist. The rationale given to us is our invoices may not be accepted by Services Australia. I ask the committee to support my right to agency to assure our funding delivers value for taxpayers and puts more care at the front line. Our ability to live well together is heavily reliant on respite. We receive 6.5 hours of respite weekly, spread over 2 days. To keep my husband engaged, prompt his functional capacity, and give me time to recharge, we rely on accompanied activities at a cost of $160 an hour to take him to the gym and to let him attend U3A. This is at a cost of $1,000 plus weekly, rapidly eating into our quarterly budget. Overnight respite is so prohibitively expensive and difficult to secure. It consumes our quarterly budget almost instantly. Recently, to visit family, I arranged just 2 consecutive overnight shifts and our usual daytime hours. The total cost to our package to allow me to visit my grandchildren was $3,300 plus. The care provided was by his usual carer, not a third-party provider. I have only done this twice in 3 years of caring. I kind of had a feeling of guilt when I do it, as it's so extremely expensive, but I sometimes just need to see my kids. When in-home respite is out of reach, we use residential respite as our backup. But recently we experienced a failed stay. The facility's resident cohort contributed to my husband's increased level of anxiety, sleep deprivation and fatigue. He came home early with marked cognitive deterioration. Terrified, this fog was his new normal. It took a week to claw back his functional and emotional capacity. I asked the committee to support the need for accessible small-scale cottage respite, similar to the NDIS semi-independent living home model of care. I asked the committee to support an urgent review of the exorbitant in-home respite costs. It's our oxygen. We need it. Care workers need the support of mandatory dementia training, covering cognitive impairment, complex communication, and clinical progression. Empowering our workforce with this knowledge promotes capacity for both the worker and for those of us living with dementia. Creating more sustainable funding models for respite is absolutely essential for carer longevity. I know, according to the World Health Organization research, I am at greater risk of cognitive impairment and dementia, experiencing stress, poor sleep, hearing loss, and social isolation. Our world is small and getting smaller. Please help me to care for both of us. Please recognise the care dyad. Informal carers underpin this system, saving billions of taxpayer dollars annually. The system needs to nurture the family. I don't feel nurtured. I feel the weight of being consumers in a program which limits our choice and agency. Increased hourly service rates have decreased our care hours. I also live with the heavy feeling knowing so many are still waiting at the front door. The Department and Health Ministers need to realise the pressures this system places on older Australians, their carers and their families. There is no nurturing humanity in people waiting 5 months for showering, wound care and continence to be included in clinical care. How many skin tears, infections and hospital administrations will occur before October because of this delay? I ask the committee to mandate the immediate inclusion of these clinical services without delay and to implement a supported home financial safety net protecting low-income Australians. We have been offered a reassessment because our budget is stretched by the vital and high cost of respite. I have delayed reassessment with the current governance of the IAT. I will not risk receiving 60% of funding, which may contribute to my husband's decline and my inability to keep caring. I will not risk being assessed by a computer algorithm, lacking flexibility and lacking modelling and insight into living with dementia. I would rather choose to forego other services, and I would take on those roles again of domestic assistance and the garden. I urge you to recommend the IAT be redesigned to support clinical judgment, not to replace it. Empower these professionals to use their clinical training and insight to add immense and irreplaceable value to the care ecosystem. In closing, I ask the committee to remember that behind every wait list is an older Australian and their carers and family struggling to hold the line. Older Australians are dying, waiting for a system that values their dignity and practically supports their carers. It's time to stop administrative delays, excessive governance, and remove algorithmic tools that are contributing to real harm. I implore the committee to champion these urgent reforms before more time and more lives are lost to a system that is failing its fundamental purpose. Older Australians with complex needs, like my husband, do not have the luxury of time for gradual systemic transitions or software updates. They are declining. They are dying while waiting for a system that affords them basic human dignity, agency, and affordable care. Thank you.
Thanks very much, Jen. Can I say thank you very much to Deb, to Peter, to Lynn, to Linda and Jen for coming and giving evidence today. I, along with my fellow members on the committee, recognise that it's not an easy thing to do, and that for many of you, you are telling these stories again and again and again to try and get change. And this committee is focused very much on making recommendations that will get that change. I also want to reassure you that because we are reporting in November, these are not the last hearings that this committee will be having, and there may well be more hearings before the year is out. But I just want to thank you again for the time that you've taken to write submissions, for the continued advocacy that I know all of you are continuing to engage in, whether that be with government, with departments and in your communities and other bodies. And thank you again for taking the time and the emotional labour to give us evidence today. Thank you. And the committee now stands adjourned. Good afternoon, everyone. I declare open this hearing of the Senate Community Affairs References Committee's inquiry into epilepsy in Australia. I begin by acknowledging the traditional custodians of the land on which we meet and pay my respects to elders past and present and extend that respect to any First Nations people that are with us today. The committee will be conducting today's hearing via video conference and in person. I'm Senator Penny Orman-Payne, the chair of the committee, and I have with me Senators Anand Raja and Askew, and we are joined online by Senators Antic and Ruston, and I believe potentially Senator Whittaker. These are public proceedings being video streamed live via the Parliament's website, and a Hansard transcript is being made. I remind all witnesses that in giving evidence to the committee, they are protected by parliamentary privilege. It is unlawful for anyone to threaten or disadvantage a witness on account of evidence given to a committee, and such action may be treated by the Senate as a contempt. It is also a contempt to give false or misleading evidence, and witnesses also have a right to request to be heard in camera. If a witness objects to answering a question, they should state the ground on which the objection is made, and the committee will determine whether it will insist on an answer, having regard to the ground which is claimed. If the committee determines to insist on an answer, a witness may request that the answer be given in camera. I remind senators of their obligations under the Behaviour Code for Australian parliamentarians to treat witnesses with dignity, courtesy, fairness and respect. And I remind committee members and witnesses who are appearing via teleconference and who aren't speaking to please mute your microphones. I now welcome representatives from the Epilepsy Foundation. Thank you very much for appearing before the committee today. I understand that information on parliamentary privilege and the protection and obligation of witnesses giving evidence to Senate committees has been provided to you. For the Hansard record, if you could please state your full name and the capacity in which you're appearing today, and I'll start on my left.
Bernadette Zappa, General Manager of Services, Projects and Research at the Epilepsy Foundation.
Rihanna Nation, Epilepsy Advisor for the Epilepsy Foundation. I also have a lived experience in that my son passed away due to sudden unexpected death in epilepsy on the 12th of January 2024.
Nicole Coulthard, CEO of the Epilepsy Foundation.
I'm going to invite you now to make a short opening statement on behalf of the Foundation, and then we'll go to Senators' questions.
Thank you. I do appreciate this opportunity to present to the committee today. From the Epilepsy Foundation's experience and the evidence that you've heard so far through the inquiry, it's clear that Australia's current systems are insufficient and fragmented, and too many people are falling through the cracks. Epilepsy is not just seizures, and it's not just a medical condition. It affects education, employment, family life, independence, safety and mental health. Too often people are left to navigate disconnected systems on their own and need to carry the practical and emotional burden of coordination at a time of fear and uncertainty. Insufficient knowledge and understanding continues to place people with epilepsy at unnecessary risk, and the lack of mandated training for staff in childcare, schools, disability services and workplaces means people experience unfair discrimination and stigma. The healthcare workforce, including first contact with GPs and first responders, requires greater knowledge of epilepsy so that people receive safe and respectful support wherever they present. Access to services should not depend on postcode, culture or ability to pay. To have a real and sustained impact, epilepsy support must go beyond the clinic door and into the settings where people learn, live and work. Every day, our client services team help people navigate the realities of living with epilepsy by providing reliable information, education and tools. We know that with the right education and support provided at the right time, it can be the difference between a child being able to attend school alongside their friends or being excluded and not being able to go on camp and maybe not even being able to attend at all because the school doesn't know how to support them. It's the difference between a person with epilepsy being able to work, supporting themselves and their family financially, or being told they can't return to work because witnessing a seizure is too distressing for other staff. It's the difference between a parent being told about SUDEP and ways to reduce risk, or waking one morning to find that epilepsy has taken their child's life during the night and no one ever having told them this was possible. At the centre of every one of these examples is a person and a family carrying the burden of a system that is not prepared to support them. There are examples of initiatives across epilepsy and other health conditions that provide some optimism that these systemic gaps can be addressed. In 2020, the federal government funded the development of Epilepsy Smart Australia, a program providing a national intake point, central knowledge base and referral for further support. This program was delivered in partnership with epilepsy support organisations across Australia, and over a 4-year period, approximately 10,000 people accessed information and support, almost 2,000 were referred on to other services, and thousands more accessed education, training and connection with peers. Loss of government funding has meant service volumes have fallen, skilled staff have been lost and waiting lists have grown. The unmet need is widening again. Community-based support, such as that provided by the Epilepsy Foundation, is only one part of the solution. Australia needs a national epilepsy plan to connect health, disability, education, employment and community systems. Through this inquiry, the committee can provide the leadership Australia needs: a clear path to national reform, stronger coordination across federal and state governments, and funded support that genuinely improves the lives of people with epilepsy.
Thank you. I'm going to go to Senator Askew to start us off with questions.
Thank you, and thank you very much for your time and for being here today. You've touched on some of the things I was going to go through anyway, so we'll start there for the National Action Plan. So what do you see the National Action Plan bringing that existing policies and the situation doesn't actually, isn't addressing now? What are the key barriers to that we need to address with that?
I think it's largely a coordination piece. I see the National Epilepsy Plan as an architecture or a roadmap that gives us a really clear plan of where we're headed. I think at the moment we have lots of organisations across community, health, all aspects of the sector who've got great ideas and have separate pieces of work that are currently adding value, but we're not understanding all of those pieces of work as part of a whole. We're not measuring the outcomes effectively of that work. So I think the National Epilepsy Plan can provide that the architecture that it hangs together, and importantly the reporting that means that we are, instead of doing things that we think is making a difference, or we know that it's improving people's lives but perhaps not in the way that has the greatest impact, and the accountability that comes with the plan as well is what will make the difference, I think.
We have heard evidence already of the fractured nature of epilepsy service across the country, that it's not sort of connected properly, so that makes sense. But is there how would you see it being administered then, the action plan? Would it be one organisation running it? Would it be run by the government? How would you see that taken?
I do think government need to be a partner in this work. I think you've heard that it's a very complex space and lots of different elements, different organisations who are very passionate. I think through Epilepsy Smart Australia we made a great start. It's not the full solution, and some of the challenges were really about the state and federal jurisdictional differences around policy. So I do think that being able to progress with a plan in a way that is more coordinated, and I would like to see the Commonwealth support in partnership so that it's not left to one particular entity or organisation. I'd also just like to say lived experience, it's critical that we have lived experience embedded within that process. And I think, Bern, you might like to speak to some of the other examples across cancer or dementia where I think we have some models that we've seen it, seen it work.
I've had some involvement in the cancer space, an advisory group at the start, pretty broad reaching, so there's current state, mapping analysis, and I think that would benefit us in this space.
Very good. Ms. Nation, I noticed you mentioned that you have had lived experience, so would you like to share your experience with us, and also how you would see the benefit have been to you in regard to a National Action Plan?
Yes, certainly, Senator. So my son was diagnosed with a syndrome called juvenile myoclonic epilepsy when he was 12 years old. not uncommon in a young child of that age and male. So he had 3 different types of seizures. We're a military family, so we were posted in Darwin at the time, and very luckily were able to get into a really amazing paediatrician in the Northern Territory, which is surprising, I know, because they're so remote. And then our journey continued like every other family's journey around trying to find the right medications, breakthrough seizures, what did that look like? And I didn't have the knowledge I obviously have now. My son, lost his life. He wasn't able to get his licence, so we went through primary, high school, memory issues. And then on the 12th of January 2024, my son had moved out to live independently. We were very excited. He was working as a public service servant for Victorian Police in that role. He hadn't disclosed that he had epilepsy because he wasn't comfortable to do so, so there is that stigma around that again. And had decided that he wanted to go back to university to study environmental science. And then he was going away for the weekend with his friends. They couldn't contact him. We couldn't contact him. I was away and my husband had to break into his apartment and found him deceased. And obviously you have everything on top of that. So the police arriving, the ambulance, fire were called as well. So that whole process, the coroner's report, the choice to whether you go and look at your child, because you are asked that, would you like to come and say goodbye? And then all the emotional, mental health stresses that come with that. So from my perspective now, because I've been an epilepsy advisor for a significant period of time, it's my role now to ensure that my clients are informed about SUDEP, and I'm not afraid to speak about it. I'm fully aware that there are practitioners in the neurological setting that are very fearful of speaking about death in relation to epilepsy. Unfortunately, it's a reality, and it needs to be spoken about, and it's not an easy topic. I think from a national perspective, because we'll bring it back to what it was about. So from a national perspective, I was actually part of the ESAP process, and with anything that's, there's teething, but I think, all the organisations, the aim is to put the client first. Well, that's my aim. It's bigger than any individual organisation in my perspective. It's very much about supporting the client, their families who have to live it every single day, no matter whether their seizures are well controlled or they have significant genetic type epilepsies. Or deaths like I went through. It's about us supporting the carers, the families, and that person long term through things as well. And I think if all the organisations are on the same page in relation to client focus first, then we'll have a really good national plan. If we don't have that, we'll never have a national plan. That's my opinion, not the Foundation's opinion. That's my opinion as an advisor, having worked nearly 7 years with people with epilepsy and their families, and going through what I went through myself. I hope that's answered your question, Senator.
Thank you. I just wanted to sort of understand where you had come from and to. So you'd mentioned education, Mrs. Coulthart, when you did your introduction, and that would be something that your son you said was 12 when he started, so when he was diagnosed. So the education system, as well as educating people about epilepsy, needs to provide quality support as well, and that's obviously something that has been lacking in lots of different areas, not just epilepsy, in regard to health situations. So is there any things that we can do to try and improve that as well, or is that just something that you think will just get fixed under the plan?
Yeah, I think when we talk about the education, it is broad, but if we're talking about in sectors like schools, it's about, if we could be mandating some training, I guess, for example, because what happens now is really inconsistent. So we have some excellent schools who are, really quick. They find out they've got a student living with epilepsy. They contact an organisation and we deliver, effective training. They train their whole school, perhaps. We might have another, organisation who will train only a small number of staff because of costs. And then in a childcare setting, for example, when that staff member's not working, we no longer have someone caring for that person. But it's even broader than that. We try to talk about be prepared, don't wait until you've got someone who has epilepsy in your childcare centre, in your primary school, in your secondary school. So the education needs to be sector-wide, it needs to be broad-based at a community level, but then really targeted in those areas really around safety and risk for people living with epilepsy, so people can go to school and be safe. Can be in childcare, you know, you're trusting your young child to be left so that you can be employed, contribute to society that way. So we need that systemic change where there is mandated and mandate about the quality of the training that is delivered as well, so that we know that there's some controls around what has been delivered and that there are some measures as to whether someone is competent, for example, in administering an emergency medication.
Can I just say something there, if that's okay? I think the interesting thing is that, and I've heard it previously from other states, that most people only believe, who don't understand, there's only one type of seizure, and that's the tonic-clonic seizure. And in first aid, that's the only seizure that you... And even that seizure appears differently. You could have 5 people lined up here with the same diagnosis, and every seizure, they might have the same seizures but may present very differently. So I think when we talk about mandating, it's really important so that these people who are caring for children or even adults understand that there's 30 or 40 different types of seizures, not the one you see in the movies with the person foaming at the mouth. You know, that it's much broader than that.
The training's not just about the seizures or the medication as well, that it's the broader impacts of the epilepsy. So again, in a school setting, you know, impacts on concentration, and participation, all of those kind of things, so that the broader impact of it is recognised, and that's what is missed in generic first aid training. Yes, we hear many stories that they're the things that are missed. Yeah.
So, do you want time? No. Okay. Well, I just want to touch on one other area. There's so many areas I could touch on, but this is something else that was in your submission, as regarding increased targeted Commonwealth investment in epilepsy research. I just wanted to see if you could expand on that and see where it should be best invested, I suppose.
So at the Epilepsy Foundation, we have supported psychosocial research over an extended period of time through the Australian Epilepsy Longitudinal Study. You've actually got a speaker later on this morning who has been pivotal to that work, so I won't go into too much detail. We're very supportive of scientific research, but we'll have that conversation about what's the research that improves the experiences for people in the future versus right here and now. And I think there hasn't been enough focus on the here and now experiences. It's not just about having that information to advocate for change, although that is really important. It's about giving us information to look at our own services now and what do we need to change? What are the biggest challenges and issues that people with epilepsy are facing, and what can we do in the here and now to make that experience better for them?
And we're pretty passionate about it being consumer-led, the research as well. And again, you'll hear in, I think, the next session about research for rare and genetic epilepsy, for example. So again, making sure that the research that's being done is actually meaningful and purposeful to the people who are living with or supporting someone living with epilepsy.
I think that's a key message, making sure that we're actually getting value for money in whatever research that is invested. And that's a key message. I'll leave it there for now.
Okay. Senator Nandaraka.
Thanks, Chair. You mentioned earlier the Australian Cancer Plan. What elements of that plan do you like? What elements do you think should be modified or perhaps not considered for something similar for epilepsy? I actually think it's quite a good plan.
Yeah, so do I. The things that I think are good are around the measurement and the mandatory reporting. Also, the optimal care pathway piece that fell out of the cancer plan, I think, has been really significant. I worked in an integrated cancer service, so they were set up to ensure action against the plan and to support health services and organisations to take action against the plan. So it was around having strategies in place that mean it doesn't just sit as a plan, but it is actually a living and breathing and regular reporting against that plan. So lots of aspects of it, I think, would apply.
If it were helpful, that is something that we could provide as further information afterwards.
I think that would be
some
really
mapping
good,
against.
because I think what we need is a bit of a roadmap for the roadmap.
Yeah.
You know.
And there are lots of great examples, and we don't need to reinvent
No.
the wheel. There's lots of complexity in other conditions out there. So I think that would be a valuable piece of pre-work
Workforce
to do.
pieces sat in underneath the cancer plan as well. So again, things I think everyone's been speaking about.
Yeah, on workforce, I'm glad you brought that up. I mean, it's a universe, right? In epilepsy, the challenge is it's such a spectrum. It's children to adults, and it's that bimodal, peak, young and old, and it's lifetime, right? So workforce, if we just focus for the minute on the medical side, you mentioned you went to a pediatrician. Now, was that pediatrician a general pediatrician or was it a neurologist in pediatrics, or was it
It was just
a general?
Really amazing.
Yeah.
We were lucky he was the head of pediatrics. We just very lucky he wasn't visiting. But that just shows we were lucky on that day. Regionally,
it's potluck, right?
Yeah, if the guy from Adelaide wasn't there, we'd have to wait for him.
So, I mean, I find this really difficult because I think it's a scaling issue here, right? So we have specialists, medical specialists, neurologists, but they've got to be epilepsy specialists. And then even within that cohort, there are some who will further specialise into the different types of epilepsy, which is, so you're taking a group and you're just whittling them down even further. And how do we take that very, very niche, scarce resource and scale it? And I'll give you one example. I know that there are doctors who have gone from Adelaide to the Alfred in Melbourne to learn skills from there, to then take it back. And I wonder how we can better, use these centres of kind of excellence to train up more specialists in these fields. But how do we scale and how do we train?
I mean, I don't have all the answers, but I like what you said about sharing training, but also telehealth has been used in lots of other, isn't it? I think, example, the Children's would have a telehealth service for regional areas. So I wonder if there's some opportunity in the telehealth space.
I would defer to the Epilepsy Society of Australia around medical workforce, but I know this has come up to GPs. So the first point of contact for the vast majority of people is going to be their local GP, and we have heard so many stories from people about that. Not being a positive experience for them, it perhaps being missed or not recognised because of the diversity of seizure presentations. So I know you've raised it before, Senator, about how do we build capability at the GP level, and that's something that we've spoken about, but have not really come up with an effective way of engaging at this point.
I think education is key at the lowest level of medical connection to someone who has a child or adult or someone. So GP is generally your first point of call. If the GP doesn't understand epilepsy, there's no hope on the referral to get to a neurologist or even a paediatrician. So a lot of paediatricians do look after young children who have a diagnosis and actually work with a neurologist, where I have clients who have a paediatrician as their main contact, but the paediatrician can speak to an RCH epileptologist here and they have a good relationship. But, parents struggle that, and I talk about young children at the moment, but it's across the board. If you don't have consistency with a GP, I mean, how many families now have a GP for 10, 15, 20 years like we generationally did? Now they're just going to 24-hour GP. So I think it starts at this level even.
No, I think your point is well taken. I think there are things GPs can handle, there are things that they can't handle.
Yeah, exactly.
And I think that there are, in medicine, this condition is probably in the probably a bit too hard basket, and it does require really intense specialist input. But again, we need a model to scale, and I will ask the Children's how they intend to sort of look at that with SUDEP and things like DRE, drug resistant epilepsy. We've had testimony from people who had never heard of SUDEP until it happened, had never heard of drug resistant epilepsy until many, many years into their child's illness, and I'm just, I'm gobsmacked. So how do we fix that so that without overloading families also? There's a lot for them to deal with, and then when you sort of mention SUDEP as well, there's a chance of really escalating their fear to another level, such to the point where they may not be able to function properly, being so worried about their child dying suddenly. How do we find the balance? Where should that kind of information be introduced?
I think that's a very complex question based on the fact that I'm actually a social worker by qualification. So unless I'm sitting in the room with the family as they go through their first initial appointment with their neurologist or paediatrician, then it's very hard to say when it should be introduced, because you have to make an assessment based on the capacity of the family at the time to be able to handle that information. So I even do that now when I'm talking to families. I base my assessment on how I feel the family's going, generally the mother, because it's generally the mother that we speak to, and then I may not mention it in my first contact, but in my second contact I'll make another brief assessment and then I will mention it in my second contact.
So early?
Very early, very early, especially if we're talking about adolescence. And it's not to negate that it doesn't happen at younger levels, but when I'm talking about young people with my clients, especially adolescents, 15 and above, they're starting to look at alcohol and drugs, and now they've got this other thing and they become rebellious. So I will throw it in a lot earlier, and sometimes families raise it. Yeah. And so it's really easy if, will my child die? Well, I can't answer that, but however, these are the things. There is a thing called SUDEP. So I'm an early introducer because I'm not afraid to talk about it, but I assess my client very closely during that conversation. Am I going to do it on that first contact we have? But I definitely will do it on the second if I think it's appropriate.
Do we have any longitudinal data as to whether that kind of knowledge, and then presumably some families, some patients will take measures to maybe reduce their risk? What are the protective factors? Has that had any appreciable impact on the rates of SUDEP, or is no one actually monitoring this?
I believe there's some research happening at the moment, and Christine might be able to talk to that around SUDEP and understanding. Yes, I know with when we do some outcome measurements and talk to people about their experience of living with epilepsy after our contact, we certainly talk about things like, do you better understand safety? Do you have greater confidence to manage seizures? So I would like to think that that there is a correlation there, but I can't recall.
I think, again, if you're happy to receive some information following today, that is, we can find out what is available.
I think the information needs to be at multiple points and repeated, I think, about SUDEP, and that's one thing we know from having the community epilepsy organisations, more of that longitudinal contact when people are not in that acute outpatient clinic setting, highly anxious. Message can be received a bit differently. So I think it needs to be messaged at many points in it, but a community epilepsy organisation is well positioned.
Let's just come back. Sorry, there's a principle in this which is about the empowering families to make decisions about their own lives, and I think that's an underlying principle, certainly for our service. We do need to make assessments in the very early stages, but ultimately we need to give people the information that they can then make decisions about their, and if that's sticking your head in the sand, well, that's okay, because they've made a decision about that. It's not our place to do that.
Do you think with the prevalence now of AI that it could be potentially a positive here, or are you worried that it could spread misinformation? I mean, people could punch in epilepsy, ask all kinds of questions. It could conceivably automatically tell them about SUDEP or whatever, right?
Yeah.
What has been your sense on the introduction of AI so rapidly? What are families?
I think the issue has been there a long time. I think with the emergence of Google, Dr. Google, don't go down that sort of rabbit hole. So I think perhaps it's at people's fingertips more so than ever now, but I think that has always been a concern.
Needs to be endorsed by the foundation.
Well, that was one of the pieces of the Epilepsy Smart Australia, to invest time and money on reputable resources that could be then passed to people with a level of confidence, but you've obviously got in a ever-changing world, keeping information contemporary.
My last question is around evaluation. So say we land on a plan a national plan and it starts rolling out, what would an evaluation framework look like? And you can take this on notice if you like. And what would we measure in order to gauge success? You talked about measurement, and your first point was measurement.
So we will provide something afterwards as part of the Epilepsy Smart Australia development. An outcome measurement framework was developed, and that was at individual system, service and community levels, and a range of measures and indicators were created so that we can provide, and it may become a useful input.
That would be great. And was that co-designed with families?
Yes.
Okay,
yes,
great.
Yeah.
Thank you, Chair.
That concludes our time that we have for this panel, but can I thank you very much for your submission and your evidence today. It's been really helpful for the committee, and we really look forward to getting that additional information on notice. The committee will report to the Senate on the 10th of September 2026, and we've agreed that responses to questions on notice should be provided by close of business on Monday the 17th of August. So thank you very much again for your time today.
Thank you very much for having us.
And I'm now going to welcome representatives from SCN2A Australia and the DEE Roundtable 2026 Steering Committee. Afternoon, everybody. Thank you very much for appearing before the committee today. I understand that information on parliamentary privilege, the protection and obligations of witnesses giving evidence to Senate committees has been provided to you. For the Hansard record, if you could each state your full name and the capacity in which you appear today, and I'll start at this end.
My name's Leah Duffy. I'm attending as part of the DE Roundtable Steering Committee, which I was part of due to my membership of Genetic Epilepsy Team Australia. And I also have lived experience as a mother of a 6-year-old girl with Dravet syndrome, which is a DE. Thank you.
My name is Neil Deacon. I'm representing as a member of the DE Roundtable Steering Committee also. I'm also a father of a child with DE.
Christine, I was going to say my middle name, Christine Pearce. I'm here representing SCN2A Australia, but I am also a parent of a young adult with a genetic epilepsy.
Thank you. And can I just check, do we have Mrs. Milne online? No, I don't think we do. All right, if she does join us later, we can always come back. I'm going to ask each of your organisations now to make some short opening remarks, and then we'll go to questions. So I'll start with Ms. Pearce.
Thank you. Senators, thanks for having us. We're really pleased to be here and speak on behalf of DEEs, or developmental and epileptic encephalopathies. As I mentioned, I'm here for SCN2A Australia because that's the gene that my son has, but there are over 900 different genes that affect largely children, but also adults. And as you've heard, epilepsy is not just, epilepsy is not just the seizures. You've heard that a lot across the inquiry, but for DEEs it's a very complex multi-morbidity condition that affects pretty much every part. So, most of these children and adults have intellectual disability, mental health challenges, behaviour, gut and movement disorders, as well as ASD. And some of our families with SCN2A, they don't have seizures, but the autism that presents through the gene change is quite challenging. So I've come with a problem-solving approach. So I'm going to read out 5 facts and then 5 fixes. So the 5 facts: 7 to 14 years for a genetic diagnosis. The medicine that helps one child can make another one worse. So, for example, it can make seizures worse. Children lose a lot of time and years on the wrong drug, and Leah can speak to that later. 13 to 15% of children with SCN2A die, and that's the same mortality as childhood cancer. For other DEs, as it's been mentioned, nobody has counted. 26 million a year in hospital beds, and that's the cheap part. 86% of our families lost income or a career, including myself. 4 to 10 people with a DE in our survey are adults, and to our knowledge, there is no specific adult DE service in our country. 2/3 of our families were denied NDIS support or have been given a plan that doesn't fit what the child needs. So now I've got some fixes, and everyone is within the control of the Senate. So the first one is funding genetic testing through Medicare at first presentation. There's enough research and evidence to support this. The problem is there's disagreement about who should pay. But the decision to make this accessible so families don't have to go years without treatment is one that can be reached. Build a national DE register to support finding families, and we currently don't know how many there are and where they are because we don't have this register. We'd like to see DEs as a distinct group. It is now recognised as a medical term for a specific group of conditions. And we want to build a national action plan, but within that we're looking for distinct attention to DEs because pretty much everything in our care is quite different. We would like adult DE cares, so adult DE clinics in every state, and some transition planning, that start early on. And the last one is to fix the NDIS. Genetic mutation does not resolve, and so every year we are still asked to prove why we need the supports. Our kids need 24-hour support, and at the moment the parents are carrying that load. Everything I've asked for already exists somewhere in this country, just not for us. And we're looking to you for a decision that can start supporting our families.
Thank you.
Thank you.
I'll now go to the DE Roundtable Steering Committee.
Thank you. Thank you, Chair and members of the committee, for holding this inquiry and shedding much needed light on the issues that we face in the DE community. I am Dr. Neil Deacon, and I'm appearing on behalf of the DE Roundtable Steering Committee, of which I'm a member. I'm also the father of a 3-year-old with a developmental and epileptic encephalopathy. I won't say that again because it's hard. Our recent DE Roundtable held on the 1st of May brought together diverse stakeholders across the DE landscape to identify priorities for people living with DEs. At the last session of the inquiry, you heard from Associate Professor Catherine Howell, also a member of our steering committee, who provided an overview of what DEs are. I just wish to reiterate that they are much more than epilepsy. They are severe, lifelong genetic conditions, combining epilepsy with complex developmental disability and multi-system health needs. For example, my son sees 6 different specialists and has a therapy team of 5 allied health professionals. Evidence from 134 families like ours shows that the system is falling at their interfaces. Families describe delayed diagnosis, fragmented care, gaps in NDIS support, limited access to trials and treatments, and a cliff at transition to adult services. The financial and psychological impacts are also felt keenly on carers and siblings, and they are also profound. Too often, families must coordinate systems that are no longer working as they should. There's no single fix to this. It requires a multifaceted series of solutions. Key pieces of the puzzle are, as you've already heard, national recognition of DEs as distinct lifelong conditions, better access to genomic testing and support through the diagnostic journey, health technology assessment that enables access to the world's best treatments, better understanding of DEs within the NDIS, including recognition of fluctuating functional capacity and specialised pathways for people with DEs, We also need better multidisciplinary care, including through investment in DE navigation and care coordination supports. The Federal Australian Cancer Nursing and Navigation Programme provides a promising model for this. There are also changes that will be required at the state and territory level to see that health, education and disability services are consistently meeting the needs of people with DEs and their families. As such, there is urgent need for collaboration and coordination across sectors, including public, not-for-profit and industry, government departments and the states and territories, to guide the changes required to improve the lives of people with DEs and their families. Therefore, we need a national plan dedicated to DEs and a national DE peak body to coordinate it, working alongside our partner organisations and allies across the DE landscape, many of whom you've met through this inquiry. A distinct peak is needed because DEs sit at the intersection of rare disease, epilepsy, disability, complex health needs and advancing gene-specific science. It would complement, not duplicate, existing epilepsy organisations, connecting DE communities, embedding lived experience and collaborating with the broader epilepsy sector and governments. The action plan and peak organisation would coordinate action across diagnosis, treatment and care, the NDIS, education, research and access to therapies and adult services. Thank you.
Thank you very much. And before we go to questions, I note that we have Miss Milne online. Oh, yep. Miss Milne, if you could just state your full name and the capacity which you're appearing today for the benefit of the Hansard record.
My full name is Catherine Joy Milne and I am attending on behalf of the DE Roundtable Steering Committee also.
Thank you and welcome. I'm going to go to Senator Askew to kick us off for questions.
Thank you, and thank you very much for your time and for your submissions, which we've read with great interest. Thank you. It's been interesting to see the genetic side of things is something that really interests me. I've been involved in that from a cancer perspective and a few others along the course of my career. So just would like to see if I could get a bit more understanding on, obviously your Mrs. Pearce, your first comment was that at earliest or at first diagnosis that it should happen. My question, I suppose, is who should be doing it? So it should be, is that at a specialist level or is it from, like, who would actually be organising that and what sort of cost is involved in it?
So most of these presentations would come when children have an acute presentation. So of seizures, they end up in casualty in the ED ward. And so that's where it would happen most of the time.
Is that before diagnosis or is that at the initial?
That's at diagnosis.
Okay,
yeah. Generally, there needs to be a presentation of some kind of symptoms, generally seizures, that would trigger that investigation. The challenge is that when it's genetic, you need to test parents as well, and so that's a barrier in terms of being within a hospital system, in a state hospital system. So at the minute, there's a number of barriers between federal and state, and who should pay. But at the end of the day, it's these kids that are paying in delayed diagnosis. So I understand that there have been some attempts by, Associate Professor Catherine Howe and others to take this to MSAC, and it feels like that's not the right place, but then there's also not where to go to next. So I think there needs to be, a process where we work out where that happens. And it won't be the only thing. There'll be other tests coming along with this sort of explosion of genomics. So a sort of a pathway for those kinds of things would be useful.
So with the genetic testing when it's being done, so I just want to understand how it works and how involved it is, and then also if the parents need to do it, that becomes obviously, as you say, an additional cost, but who would actually manage that process? So who would be in control of making this happen is, I suppose, my question. How would we make it happen if we were to put a recommendation in?
I guess for early diagnosis, it's really coming from the hospital presentation most of the time. I mean, again, I think Catherine Howe will be able to speak more to this through MCRI for sure, and particularly the Gene Steps program that she'll be covering a lot more later. But I think in small hospitals, when you might have a presentation in a regional hospital with a young baby, they might present with a seizure, they might have a tonic-clonic, which is obvious, but then they might have other seizure types which are going unnoticed by people. So we're having long delays in that diagnosis process because regional hospitals don't know to order those genetic tests at the first signs of seizures, for example. I suppose funding-wise, I would say with most young children's presentations, it should be coming from the hospital system.
Yeah.
But again, I would probably defer to Catherine how to cover that more.
Save some of those questions for later in the day.
Lucky her.
You also mentioned, Dr. Deakin, about the cliff from when it's sort of turning into adulthood. So can you talk us through that a little bit and just give us an understanding of what services they would lose access to, when someone moves across into adulthood?
If you don't mind, I'd pass this over to
Oh,
Chris,
yeah, okay,
because
yeah,
Chris has an adult
Either-
child.
Oh, of course.
And
Good point.
I have a very young child, so I'm not,
Not there yet.
there yet.
Yeah, so because the condition is complex, there's no, specialties stepping forward to take ownership of these families. So it could be epilepsy, it could be general medicine, it could be other specialists, depending on what their primary presentation or concern is. So like we're in the latter years and seizures have been controlled for some time, and so our main providers are neurologist, psychiatrist, behavioural therapy, we're dealing with really complex behavioural challenges. But we actually happened to move interstate around when Will transferred. When we were here in Victoria, I was given a letter. It went to the GP. I went to the GP. The GP said, you're going to have to tell me what I need to know and what to do and when. And then when we tried to link into Queensland Health, the GP wrote a referral so we could get Will on, our son, on the books, and they refused. And even with some sort of going back and forth, they just said, we're not the right home. So nobody wanted it at home. And an example of where that comes unstuck is that my husband and I, on one of the very few occasions we got away, we were on a train in Spain and the hospital's ringing us. It wasn't actually related to this, but they're, what is he normally like? How do we know he's not, where he is from baseline? So that's why we want to have someone within the health system, because these children and adults live far more regularly in the health system and they need to be understood.
So you mentioned an adult DE clinic. Would that be something that would be a state-based organisation that you would be envisaging? Is that how you would look at that?
Well, I think to some of your earlier points is at the minute, the understanding of adult DE, so my son's 24, and so he would be one of the oldest with a diagnosis, and that's because, genetic testing wasn't around. So there'll be a whole lot of adults that don't have that diagnosis and the families don't understand that there's some genetic component of that, which I think is important because there are medications that can help. We know that at least. I would say there needs to be some capacity building in adult neurologists, because for the same reason, they haven't sort of trained understanding that as well. So I know some of our partners mentioned that there's a very, the understanding of DEs and the cross multimorbidities are not really understood, and they just still see it as epilepsy. Yeah.
There's definitely a workforce shortage in the whole area of everything that we've heard, to be honest.
Yeah.
Okay. I think that we talked about that one. I had lots of different things highlighted. Done that. The NDIS, that was the other bit. So just on that cliff thing. So the NDIS, you're obviously coming up against barriers within the NDIS. If someone was as a child was accepted into the NDIS, that would then continue through and would resolve that issue going into adulthood. Wouldn't? Or do they drop off at adulthood?
I think there's a drop-off earlier. Like my daughter's just turned 6, so that triggers a reassessment for whether she's eligible for NDIS. and I had this phone call and I was trying to explain she's got a genetic disorder. She's not going to be miraculously cured. And just he's like, yep, we'll be in touch again next year to see if she's still eligible. And I'm thinking, why am I going to have to go through that again in a year? And her condition is not going to change. She's got a genetic disorder. Yeah. She's got ongoing needs. And there's no pathway. Like, I communicate with people from the NDIS. They have never heard of a DEE. They don't understand. Her diagnosis is often just labelled as developmental delay. It's a lot more complex than that. And that's not recognised. There should be, I suppose, a more clear pathway. I think for epilepsy in general, there's very little understanding in the NDIS of the really highly specialised support that our kids require, and our adults as well. And it's frustrating as a parent to have to advocate for that when it should be understood at that level of government, I feel.
I feel like frustrating is a little, but just to add to what Leah said, there are pathways that have been created for other conditions like this. So MND recently was talked about, childhood dementia. A lot of the childhood dementias would fit under DEEs and vice versa. So it's the pathway is there. It's just trying to talk to the right people and get that put in place for our families.
There's also a difficulty sometimes in getting access early when we know that children have a genetic diagnosis. We know the path. I suppose there's a lot more natural history studies being done now. We can see that children, for example, my daughter has Dravet. It's pretty commonly known now that there'll be a decline after their first birthday. And so our families shouldn't have to wait until those delays start being more evident, I think, until they're gaining intervention. Like, we should be getting in early with that early intervention as quickly as we can. And I think that we're finding that's not happening. People are being told that they're not eligible still. And you really feel like you're falling behind in that medical versus disability gap. I know you talked with the last presentation from Epilepsy Foundation about SUDEP. So with Dravet syndrome, 1 in 5 children won't reach adulthood. And SUDEP is the absolute biggest fear you have as a parent. And one thing that can alleviate that for us is that, getting an oximeter, which should be funded, I guess, through NDIS. A lot of families get knocked back for that. And having an oximeter, I suppose, monitoring and other monitoring equipment for your child overnight means that hopefully you're not going to wake up in the morning to find that your child has passed away. And you can imagine as a parent, can you ever sleep having that fear? Whereas this piece of equipment that really should be pretty standard, it's not super expensive, should just be coming along with the diagnosis that would alleviate a lot of that fear for parents. And, if you get a night's sleep, you can cope with a lot more, and you're coping with a lot.
You are, that's right. And okay, so maybe this outcomes of this inquiry is definitely trying to shine a light on all these situations. So hopefully there will be some outcome from that. I'll hand back to the Chair because I'm conscious of time. Thank you.
Senator Nandaraja.
Thank you, Chair. With regards to genetic testing, we did hear from Professor Powell the other day, but just keen to unpack this further. So this proposal went to MSAC and it was knocked back. Do you know how much the test cost?
I do. It's around $1,200. I think Catherine can...
But the cost is coming down?
It is coming down.
Yeah.
I'm going to defer that to Catherine because I know she put a slide up about this very recently at a presentation I was at, so she would definitely be able to answer
Maybe
that
on
today.
notice.
Yeah, she's coming next.
Okay.
Catherine is coming
Oh,
in
wonderful.
today.
Yeah,
yes,
great.
So it would be
Chair's
good to
telling
get
me
that on
we'll
record.
be able to get to the bottom of this. And is this whole genome testing? Is that what it is? Do they sequence the whole genome?
Again, I'm going to defer to Catherine because I don't want to get something wrong.
I don't think it is.
It's probably not whole genome. It's usually targeted, but it's a panel. But then
all right.
whole genome.
And have you had any contact with Genomics Australia, with the Commissioner, about this?
I actually sit on the Genomics Australia Advisory Council.
Oh yeah.
With which was appointed late last year, and so we're just getting off the ground. And I know that researchers in this area are really trying to find a way to get around some of those barriers by doing research and, cost analysis. And but if the barrier is the system, I think they have, to my understanding, the research has already proven that this well, one is a benefit for the person or child, but also, you know, if you can get in early and you get treatment started, if you have delays in treatment, then largely, you know, it can impact brain development and also, you know, the impact on families, like we're talking about getting diagnosed and what that implication it has on the families. If we can give a diagnosis and a bit of a plan, then...
And you said earlier, but I just wanted to dive into this, we can ask Professor Powell about this as well, is this a link between the genetic marker and treatment? And so if you can actually then tailor the treatment to the genetic anomaly that's been found.
Absolutely. So just to illustrate the point, Leah and my child both have a mutation in the same gene, but the mutation in my child's gene is a gain of function mutation, and Leah's is a loss of function mutation. And we need exactly the opposite treatment strategies, right? Yeah. And so if we didn't have that precision diagnosis, then, you know, we're just going through a trial and error, and, you know, likely my son would have been given medication that would exacerbate the condition, not improve it. So that's the criticality of having that precise diagnosis. So when I hear $1,200 and, you know, can we fund that or not? It's like, I would give you $1,200 for that information in hindsight.
But I think
it's trivial in
this. Yeah, it's a false economy, totally.
Yeah, and that you think of the hospital, you know, visits that child would likely have with uncontrolled seizures, because we visit frequently. And we've got a same example in SCN2A, same gain of function or loss of function. If you give sodium channel blockers to a loss of function child, it makes the seizures worse.
Yeah, right.
So that, you know, that genetic component.
So you do need to know the genetics. Yeah. It can be quite consequential.
Yeah.
Yeah, go on.
Just to say that the right medication just makes all the difference.
Yeah.
Like my child used to have 100 seizures a day. She was in hospital every 3 weeks for multiple days. We've got access finally through compassionate access to a different medication that was available internationally but not in Australia. She's had about 12 seizures in the 4 years since then total. And the hospital actually, it was through the Austin Hospital in Melbourne, Professor Ingrid Sheffer. They looked at the actual data of her hospital admission cost versus the cost that they paid for her medication. And they were paying so much more for her to attend hospital and attend all the services.
So, yeah, okay. I mean, I think, look, this is very problematic. I don't quite understand this logic here of not offering this. When it sounds like we need to speak to MSAC, actually. I'm guessing MSAC take into account this sort of cost-effectiveness type data, but I don't actually know. It's all a little opaque to me. Do you have any sense of what sort of data they look at?
I don't personally. I really think that would be great to get a health economist to give you some advice on this, because I think that that's a really key factor in this. I think if you look at that early intervention and the correct intervention that people with epilepsy could be saving a lot of money for the Commonwealth.
Yeah, I'll just jump in and say I think that information is available. When Catherine comes, she can correct me if that's not right. But I also sit on MSAC-ESC, which is the evaluation committee. So the types of information is like the impact of the condition, the consumer impact, and also, the economic. And then, you know, the committee I'm on then passes it to MSAC for a decision. But it does take into account that balance between quality of life and things like that. Yeah. But I think the barrier is state versus federal, and also getting the parents tested, because you need to make some of these have an inherited aspect. So we need to find out if it's inherited or it's a de novo that's just shown up.
Sure.
Yeah.
With regards to just respite care, I mean, we've heard that there's a huge burden on families. What kind of respite care is available for children and families with children who have these conditions?
Sometimes you can get funded for support work through NDIS. It's often pushed back as parental responsibility, which, to be honest, just feels like a slap in the face, because it makes you feel like you're not living up to your parental responsibility, and that's, you know, I think, you know, we have a lot to deal with as parents of kids with epilepsy and complex needs. Otherwise, there's not really much, to be honest.
Hospices, some states have hospices, some are being built.
In Victoria.
Yeah, but traditionally, you know, DEs are not really seen as like a palliative care, which is something that also, you know, does need to change. I've been doing some work as a CRE being run out of Brisbane and trying to get that on the radar. But I know, like, we got my son into palliative care when he was little because he was sent home to, like, take him home, and that was probably wouldn't live till 12. So we got in on that basis, but there are a lot of other families that I know will go with a DE diagnosis and they get knocked back.
So what would you see as best practice then, if we were to consider some type of respite for families? What would that look like?
It needs, question, Chair. I mean, for me, it needs to look like VSK, very special kids, because without that nurse and that complementary care, like Leah said, you know, parents would really struggle to sleep or feel like they could have a rest if that sort of medical support wasn't there.
Lots of kids with DE have quite severe seizures, and you know, I know of one family, their child goes into cardiac arrest with every seizure, for example. So you can imagine the high level of care that they need. So you need really highly qualified carers. They're hard to find. And when you have a child with a DE, you've got, you know, every parenting takes a village. Your village is very small. You can't drop your kid off to a friend to care for them for half an hour while you run an errand. Your grandparents might be perfectly capable of caring for another 6-year-old who doesn't have these complex needs. That's not happening. So I think support work from NDIS, I feel like it shouldn't be pushed back as often as it is, because we do need that little bit of respite every so often, and we need people who are qualified to care for our kids. You can't hire a teenage babysitter from around the corner to look after your kid for you to have a break and go out for dinner.
Yeah, thank you, Chair.
I'm very conscious of the fact that it's very hard to get involved when you're online. So, Ms Milne, you've been sitting there listening to the questions. I'd like to give you the opportunity to make any contribution that you would like to before we move on from this panel.
Thank you. I think the three representatives have covered everything really well. Probably the only thing that I would add is that I have more of a policy background rather than a lived experience background, and you know, each of the issues that have come up today during the discussions are you know, how do I say it? You know, well known or you know, established policy problems in the rare disease space, and you know, really systemic issues that yes, are really felt in the DE space, but are also felt more broadly, which you know, I see as an opportunity to improve lots of different pathways, including obviously for DE families. I was going to give a specific example, but every one that has come up, you know, for example, the respite, for example, the transition to adult care, these are all, you know, written about, known about, so you know, I think there's a real strong opportunity there to make improvements and recommendations that align with, you know, align with known needs. I also want to apologise while I've got the floor. I am in South Australia and I made a mistake with the time. I'm so sorry. So thank you for your understanding.
That's totally fine. We have all been there, believe me. That ends our time for this panel. Can I just say thanks very much for both for your submissions and your advocacy, and for taking the time to come before us today. It's been very much appreciated. And just in terms of the formalities, the committee will report to the Senate on the 10th of September 2026. And we've agreed that responses to questions on notice should be provided by close of business on Monday the 17th of August 2026. Thank you.
Thank you.
We're now going to move to our lived lived experience panel. So if Anne, Scarlett and Christine would like to come forward to the table.
It's cooling down, thank God. It's too hot or too cold.
Afternoon everyone, and thank you so much for joining us here this afternoon. This session is an opportunity for the committee to hear from members of the community about their lived experiences, and I remind the committee that this is a listening exercise for us. I also have to say this, but I'm sure it won't be necessary, but I would like to remind everyone that this is a public hearing and these are formal proceedings of the Senate, and the hearing must be conducted in an orderly and respectful manner. I would also like to remind witnesses not to disclose any personal or private information, so things like your full name or your date of birth or your address during the statement, as this is being broadcast live, and once it's out there it can't be taken back. I now welcome Anne, Scarlett and Christine to the table, and this also feels a bit weird, but I'm now going to go down the line and ask you to state your first name only, please. So I'll start at this end of the table.
I'm Anne. Scarlett. And Christine.
Thank you very much. I'm now going to invite each of you to make a statement about 10 minutes in length, and to make sure that we hear from everyone, and the committee will sit here and listening to your evidence. So I'm going to start with you, Anne.
Good afternoon, Senators. Thank you so much for the opportunity to present today. My name is Anne and I'm here to share my daughter Lucia's story. This is how epilepsy has impacted us. When my daughter Lucia was aged 11, we noticed when she was in direct sunlight, her eyes and head would shake uncontrollably. Although she was conscious, it looked like she was having a seizure. Over several years, I took Lucia to see our GP about it, but he wasn't concerned. So Lucia always had to wear sunglasses when she was outside. After raising my concerns several times, I insisted that the GP investigate further, and Lucia was sent to see an ophthalmologist. But he didn't see or find anything wrong, and he thought that she might just have dry eyes. So he advised her to use eye drops, although it really made no difference. No other recommendations were made, so we just had to manage Lucia's hypersensitivity to light ourselves. Lucia was 13 years old. She was in Year 8 and had been suffering terrible stress after being bullied at secondary school. It was March 2020 and the start of many of the Melbourne COVID lockdowns when one Saturday morning we saw Lucia have a tonic-clonic seizure in her sleep. She was taken to the emergency department at a major hospital in Clayton via ambulance. I told the doctors in the emergency department that I was worried that she had epilepsy. After monitoring her vital signs, the doctors said that Lucia was not likely to have epilepsy, as only one tonic-clonic seizure had been witnessed, and we were told it wasn't likely to happen again. So not one single test was done on my daughter, no blood test, no ECG, EEG, MRI or CT. And that night, unfortunately, Lucia was absolutely terrified to go to sleep and fearful of having another seizure. However, I reminded her that the doctors said it wasn't likely to happen again. 3 days later, Lucia and I had a telehealth appointment with a paediatric emergency doctor from the same hospital. And he said that Lucia's seizure may be due to spending too much time on her iPad, which was what every single student at the time was doing because we were all on our iPads and working from home, and that maybe she hadn't had enough sleep. So 3 times during this appointment, I expressed my concerns that Lucia may have epilepsy. However, he downplayed them and we were told to see a GP if she did happen to have another seizure. 3 days later, on a Saturday morning, I went into Lucia's room
to find her in bed lying face down in the pillow. She was non-responsive, and I did CPR for what felt like eternity until the paramedics arrived in their full COVID PPE. Lucia was unable to be revived and had died hours earlier in her sleep. As you can imagine, this was the most horrific, traumatic experience that any parent could ever have. She was my only child and the most precious person in my life. And my heart was totally shattered into a million pieces. Lucia died just 2 weeks shy of turning 14. She had everything to live for, and she had a really bright future ahead of her. I have to say she was a really bright girl. She was fun-loving, she loved dancing to music, she loved her friends. She'd won a scholarship to secondary school, she was naturally gifted in painting, maths and English, and she was a member of her local swimming squad. She had a real spark for life and she just made everyone feel really special. Lucia's cause of death was deemed unascertained by the coroner. Although Lucia had not been formally diagnosed with epilepsy, her autopsy showed she did have mild congenital heart disease, but not enough to make her pass away, and a hippocampal dysplasia in her brain that did indicate epilepsy. Now, I know my child, and I know she died from SUDEP, which is sudden unexpected death in epilepsy. I know you would have heard about this a lot. So this is when a person with epilepsy dies suddenly and prematurely. Regardless of Lucia's epilepsy being diagnosed before or after her death, it does not in any way change the biology of what happened to her. And I believe she died from SUDEP. I asked a world-renowned professor in neurology who specialises in epilepsy to review Lucia's autopsy and her medical history, and his opinion was that Lucia's death should be classified as definite SUDEP plus. However, unfortunately, I could not get her cause of death changed, so her death still remains unascertained. As we know, epilepsy impacts 1% of Australians, or if not more. A third of these people do not respond to medications that prevent seizures, and these people are more at risk than others of dying from SUDEP. And 1 in 1,000 people who have epilepsy will pass away from SUDEP, although it's suspected the numbers are much higher because it's not properly recorded in autopsies. Now, I just Googled this, so please accept my apology if the stats are wrong, but the Bureau of Statistics records that 28 million people currently live in Australia and 280,000 of these people will have epilepsy. So that actually means that 280 Australians will pass away from SUDEP each year, and that's a very high number. As Lucia's mum, I will forever wonder if she'd been diagnosed with epilepsy and medicated, could she still be alive? I feel Lucia, her family and friends were totally let down by the medical system. How is it that a healthy 13-year-old can have one clonic-tonic seizure and die exactly a week later? Why were we advised by 2 doctors from an emergency department that she was fine and that she wasn't likely to have another seizure, and then she died a week later? Look, I have so many questions that will never be answered and it'll never bring her back, but I have to live with this pain of not knowing every single day of my life. So I'm here today to please beg you for a case for change. I'm part of a SUDEP online Facebook group, and there's many of us SUDEP parents who have recommendations for change. There are real inconsistencies in how children with seizures who attend hospital are managed, and this is in itself a cause for alarm. If you go to hospital to emergency and you see a neurologist, and you're automatically then sent for a brain scan and the tests, even if you've only had one seizure. But if you present to emergency and see an ED doctor, then you'll be sent home with no tests and no referral to see a neurologist, which is just not right. Lucia was 13 when she died. If she'd been 16, she would have been referred to the Alfred Hospital Seizure Clinic. Many major hospitals in Australia don't have a first seizure clinic run by trained paediatric neurologists with access to EEGs and other more involved evaluation modalities. So I believe that the following actions could be taken in order to save lives. Please make it easier for doctors to diagnose epilepsy and educate them on the 40 different types of epilepsy. As seen in Lucia's case, the risks are just too high and the diagnosis really needs to be quicker. Please investigate all seizures regardless of the age of the patient or the number of seizures that they've had, and listen to families and don't dismiss their concerns, because we know our kids. All patients and parents need to be advised of the risk of SUDEP. Greater awareness will save lives. We need to raise awareness about SUDEP and help reduce the risks, because it's empowering for people to know. Epilepsy Action Australia has a SUDEP prevention list, and this should be shared with all patients and GPs across Australia. There's also SUDEP prevention tools and seizure alerts that people should be advised about. And I think a full education and training program must be delivered to medical professionals, including GPs, paramedics, nurses, ophthalmologists, school staff and maternal health nurses. Please, can we help raise awareness and funding for SUDEP? There's no education or focus for SUDEP like there is currently for SIDS or heart disease or cancer or MMD. And I suggest that the following actions could be taken. So research and advocacy around SUDEP to help reduce those risks, because if people are told about it, then they can take steps themselves. And yes, talking about SUDEP is really scary, especially for people with epilepsy, and it's confronting. But it's more confronting to find your child deceased in bed. So every patient and their family members have a right to know about SUDEPs, and they can do everything to help avoid what we've been through. I believe that Australia needs to have an advocacy and support group established like they do in the UK. It's a group called SUDEP Action UK. They do absolutely incredible work to support families who've lost loved ones to SUDEP. They support them through counselling, education and even advice when they're going through the coronial process. So in conclusion, no family should ever have to go through the pain and suffering we have, like we have with losing Lucia. If Lucia's legacy is to save one other person from dying from SUDEP, then her death will not have been in vain. So it's really imperative that we shine a light on SUDEP and avoid other families going through the heartbreak. I really hope Lucia's story has provided some insight into the challenges of diagnosing epilepsy. Please, Senators, help me and my many friends who have lost their children to SUDEP to advocate and raise awareness about this incredible risk, because lives depend on it. Thank you.
Thank you very much, Anne. Scarlett.
I just want to say thank you, and I'm also a person living with epilepsy, and hearing that from a mother's point of view, I live with the epilepsy, and I know that my parents, must have that same fear every day, and for them to, hope and be thankful that I do wake up every day, is a blessing for them. I had my first 3 seizures when I was 9 months old, and I was living in Sydney at the time, and was taken to the Royal Children's in Sydney. I didn't have any tests, nothing sent home. I continued to have seizures throughout my childhood and into my adulthood. Very rare seizures known as palinopsias. Was told by the GPs that I was making this up. It was stop it, go away. My parents were following the instructions from the GP. Oh, she's making it up. Get her to write down every time it happens. And then when I was 18, I had 3 generalised convulsions again. I was in Tasmania at the time, was taken to the Royal Hobart Hospital, was told, no, she doesn't have epilepsy, she's stressed, send her home. The next night it happened again, went to the Royal Hobart, no. And it took 6 months of that, which is very quick in the space, but very long as well. The worst 6 months we've been through. And then I was really lucky. It just so happened that, same as Rihanna, it was a top neurologist here, epileptologist, was also in Tasmania at the time. So I was diagnosed really quickly, really smooth transition. And I want to talk about peer support today. That's my main focus. Across Australia, the Epilepsy Smart Australia program has 12 peer support groups, focusing on many different categories. I support the young adults, so 13 to 17-year-olds. I've got a statement written by a mother of the youth group that was written to my co-facilitator. I would like to thank Scarlett for her involvement with my daughter Jane, name changed. I remember the first time Jane linked in on the call with Scarlett and was asked, "How are you today, Jane?" This question is a very common one, and one that Jane is frequently asked at school. Jane's standard reply is tired, to which most people reply with a version of, "Oh, Jane, you're always tired," or "Oh, Jane, it's the start of the day." It was Scarlett's reply that brought me to tears. In her immediate natural response, Scarlett asked Jane, "Why is that, Jane? Medication? School? Seizures?" It was in that moment that I felt my daughter was really being seen by Scarlett. Scarlett's empathy and understanding was such a welcoming relief. I am grateful for the connections that the online groups have for Jane and other people living with epilepsy. Now that statement, yes, it refers to me, but that is also something positive that is happening through Epilepsy Smart Australia. Peer, one belonging to the same social group that is equal standing with another. That's a verb. Support group, a group of people with common experiences and concerns to provide emotional and moral support for one another, from the Webster Dictionary. I'd like to read some of the quotes that I have put to the young youth, asking them why they attend the meetings. It reduces isolation. It felt so lonely and I wasn't in the world. It's given me confidence. Emotional support. Family really can't understand what it's like living with epilepsy. They try, but it's not the same. Building confidence. Safe, able to join without judgment for the first time. It encourages self-advocacy. Seeing other members start work gives me hope I didn't have. Supporting mental well-being. Joy, really understanding true friends that I feel safe with. And lastly, one of the 17-year-olds gets me to catch up on the goss I may have missed. No matter the epilepsy group that Epilepsy Smart Australia runs, they all run with the same intent: inclusive, respectful and confidential, age appropriate and focused on the needs of the unique group. I'm proud to be a trained co-support facilitator for the youth living with epilepsy. Epilepsy's peer support groups help foster connections, resilience, knowledge, confidence, and enable people to better manage their epilepsy with personal development. Funding for such groups ends in December this year. Imagine what life would be like for people without peer support. Close your eyes, darkness, and that's all you see. Reopen them, the light, along with this comes a lifeline.
Christine.
My lived experience was that I had my first seizure, tonic-clonic seizure, when I was around about 13, and I was diagnosed with epilepsy, and the seizures occurred every few weeks, and they left me with aching joints and feeling absolutely exhausted for days. And I only saw a neurologist once, and after that all my prescriptions were done by a GP. Every time I had a seizure, I just got more drugs thrown at me. I have to say that although I wouldn't have had the words at the time, I felt like I was devalued as a person. But I managed to, even though I didn't go to school very often, and I think the school was quite happy for me not to go to school very often, I ended up completing school at the age of 18 and was offered a place at Monash University, and I then left home and studied part-time and worked part-time and put myself through a bachelor's degree and then a master's degree and then a PhD. And I was always very interested in chronic diseases and looking at the chronic disease framework, and I noted that epilepsy was never seen as a chronic disease, which it is in many ways. And that is when, at point, having an association with the Epilepsy Foundation, that I decided that I would like to actually research the social impact of epilepsy. So I'm a sociologist by training, and I was really interested in the social aspects of living with epilepsy, the cultural aspects of it, the Australian cultural aspects, also the political economy issues and health policy issues around epilepsy. And I think one of the first things that I did was to actually examine stigma and the effects of stigma, and that would have been around about 2001, and then later in 2006 I got a small grant where I was able to actually talk to people with epilepsy and ask them what they wanted researched. And most people didn't know, apart from a randomised controlled trial, what research was. So we ended up talking about what was important to them and what would improve their lives. And that is the whole focus of my research. It is improving quality of life for people with epilepsy, and all of the research operates on people with lived experience, whether they're family members or they are people with epilepsy themselves. So we're getting an evidence base right from the horse's mouth, put it that way. And the interesting thing that I've been working on recently is once again around stigma, and it is unfortunate to have to say that it hasn't improved since the early 2000s. People are reporting and writing about it in the most recent survey that we've done of the discrimination that they've faced. And most of that discrimination comes in the workplace, and it is very often mostly coming from workplace colleagues. But management, management is not actually, good management, put it that way, is not actually very evident, I have to say. And people are called things like disgusting. They're told that they're disgusting. If they have a seizure, people will refuse to actually work with them or even volunteer with them. And they aren't given a lot of help from the HR departments. There's a whole range of things. There was in educational facilities, particularly tertiary, there's an example where one young man was called by his professor a spaz, which I think is just absolutely disgusting. But the other issues that come up a lot is that there are always at least 10% of people in the survey that we do, which we've been doing since 2010 up until this year, 2026. So we've got 16 years of longitudinal work where we can compare. Income, the issue of income, people who are on lower incomes with epilepsy, they live in poverty, particularly if they're in rural and regional areas. They actually quite often, at least 10% report that they do not see a GP, they do not see a neurologist, and they don't get their prescription medicines. And the other thing that they would really like to have would be the access to a psychologist, and they just don't get any of those services. And that has been reported all of the time. One of the good things that we have found out is that education, there were people in the first cohort of the longitudinal survey who hadn't even completed sometimes primary school, very small number, or hadn't completed secondary school. Now we are finding that more and more people are doing tertiary education, and we don't quite know why, but I would say it is the work of associations like the Epilepsy Foundation and all the other state-based organisations, that they have actually, with the work that they do with schools and informing teachers and training them, and the epilepsy management plans that have been developed, that this has actually helped children engage better in education. It's quite the difference to but I'm ancient, so so that issue of income and the costs of medication and the costs of seeing a neurologist is a huge issue, and it's already been mentioned. So they're the most. The other issue that I really want to talk about is peer support. I had the advantage of actually evaluating the training that Scarlett would have done, and which trained coordinators and then facilitators, and the facilitators being people with lived experience of epilepsy who are running these groups. And the evaluation showed that the training was really strong. It was valued, and it was actually working extremely well. And I'd like to support Scarlett in her point that she made about when the funding runs out, that's going to be really difficult. It will be a huge loss. So I'll stop now.
Thanks. It will be a huge loss.
Yeah.
One question, even though this isn't a question session. Can you tell us which organisation is funded to do the peer support work?
So as far as I'm aware, it comes through the Epilepsy Smart Australia program.
Okay.
Yeah, so that's, and also to let you know, we've just, bereavement group has just been created under that.
Yes,
Yeah.
thank you.
Yeah.
All right, thank you. Anne, thank you very much for coming along today and sharing your story and Lucia's story. I know that you speak not only for her, but on behalf of so many families that have gone through the same experience as you. So thank you for doing that. Scarlett, thank you for telling us your story, but also for sharing the value of that peer support group, because I know that means that you are speaking on behalf of so many people who access that service and really need that to keep going. So thank you for that. And Christine, thank you for coming and sharing your story and the qualitative research that you've done over such a long period of time. That's really an aspect of research that we haven't heard about for this inquiry, so that's been really, really valuable. And thank you to all of you, because I know that it takes emotional labour to come before a committee and tell your story, and we very much appreciate it. I'm supposed to say something formal. I better check what that is. The committee will report to the Senate on the 10th of September 2026. We've agreed that responses to questions on notice should be provided by close of business on Monday the 17th of August 2026, but that doesn't apply to this panel because we didn't take any questions on notice. But thank you very much again. We really do appreciate the time that you take to make submissions and to appear before us. Yes, and we are going to suspend briefly. Committee will now resume. Good afternoon, everyone. Before we get underway, I just want to check. There's been a request to take photos of the panel, and I just want to check if there's anyone in the room that's not comfortable with that. No? Okay. All right. So that's fine. If anyone wants to take photos, go ahead. I'm now going to welcome representatives from the Murdoch Children's Research Institute, who are joined by Saxon and Melanie. And Epilepsy and Other Neurological Disorders Alliance. Thank you so much for appearing before the committee this afternoon. I understand that information on parliamentary privilege and the protection and obligations of witnesses giving evidence to Senate committees has been provided to you. For the Hansard record, if you could each state your names and the capacity in which you're appearing today, and I'm going to start at the end of the table.
I'm Saxon and I'm Stella's father.
Mm-hmm.
I'm Melanie and I'm Stella's mother.
Catherine Howe from MCRI.
Piero Peruca, representing Epilepsy and Other Neurological Disorders Alliance.
Great, thank you. I'm going to invite each organisation if you'd like to make some opening remarks, and then we'll go to questions from senators. So, Professor Howe, are you going to
I'll say something very brief. Thank you very much to the committee for the opportunity to appear again. Thank you for asking us to talk a little bit more broadly about our research. I'm going to be very brief because I'm very fortunate to be able to be joined by Melanie and Saxon and Stella today. Our epilepsy research at MCRI, you've heard about some of our genomic testing. It's actually, we have research that's a lot broader than that as well. Some really great brain imaging work, some stem cells and diagnostic advances, as well as new treatments such as gene therapies. And really, I think that our research is really made possible and really amplified by our co-location with the Children's Hospital, which means we can embed the research in clinical care. And it absolutely would not be possible without the really generous participation of children and their families. And Melanie and Saxon's daughter Stella was a participant in our Gene Steps research study, and I think they might be able to speak to some of the benefits of research participation.
Thanks for having us on. With Stella, she has a condition called CYFIP2 or CYFIP2, and it causes a range of issues. So that includes drug-resistant epilepsy, intellectual disability, a global developmental delay, severe hypertonia, which is the best way to describe it to people who aren't familiar with hypertonia is it's as though she presents with cerebral palsy. So she is in a wheelchair, doesn't walk, and is nonverbal. She does have feeding difficulties as well, so she's nil by mouth and is 100% fed through the PEG, and we blend all of her feeds. She has microcephaly, meaning that her head circumference is on the smaller side. Gastrointestinal issues as well, so that includes chronic constipation, a lot of management around her bowels, sleep disturbances as well, and neutropenia and leukopenia. So she's just a bit more medically fragile, and we found that she seems to be unsuitable for, or too fragile to be in typical childcare settings. So we've got her in childcare in the home, and we have an educator come out to our home as well. And she's just a little bit more fragile, but she's very sweet in nature. She also does have as well a vision impairment, and a lot of the strategies that we learned from her vision specialist is something that we use in all of her therapies as well. And with Stella, she, I guess the symptoms or the signs of having a genetic condition started in utero. So she was fetal growth restricted, so I advocated for more monitoring. And she came out and she seemed healthy and typical, but between, I guess, birth up until 4.5 months of age, it was a bit of a decline, in that the medical professionals seeing her, including the maternal child health nurse, paediatrician, they were both quite weary about her head circumference, the lack of eye tracking, her not being able to swallow her milk and formula, And then at around 4 months old is when she started having infantile spasms. I was able to pick up that it was a medical emergency because I just kept Googling these symptoms over and over again, and I guess YouTube picked that up, and the algorithm suggested a video on infantile spasms. So I saw a video about infantile spasms, and then 2 weeks later Stella started having infantile spasms. So we presented to ED, and between presenting to ED up until her genetic diagnosis, it was about 4.5 weeks, which was incredibly rapid. At the time, I didn't really understand it. I just thought, okay, that's great. But now, knowing the other families who have children with genetic conditions, it could take decades to get a genetic diagnosis. And what that's really helped us out with is taking a bunch of shortcuts. So what I mean by that is it's not a complete shot in the dark when it comes to figuring out the right types of medications that Stella can be on so that it controls her seizures. And even just learning about her vision impairment, because we thought she was blind, and being able to talk to other families who have children with this condition, they're able to point out that their children had a vision impairment, and that meant that we could start vision therapy at 7 months old. And so it's just been so vital in terms of helping with Stella's development and giving or empowering her to be as independent as possible. I know that she doesn't walk and is a little bit more limited in her mobility, but she's showing signs that she wants to do certain things. She's got her own interests. She doesn't have a walker yet, but we're walking her around the house, and she wants to go outside, or she wants to do certain things and watch TV. And
it's allowed us to get the correct early interventions to get the most out of her life, I guess.
Yeah. And so, I guess with being able to get that genetic testing as well rapidly, it meant that we could get early interventions. And I suppose as well, it was just incredibly helpful for our family, especially as well because Stella's the only one with this condition in Australia. So SIFIP2 globally, I think there's about 40 to 60 cases so far. And so we would never have been able to figure out by ourselves how to approach or how to advocate for Stella appropriately as well. So,
or how she would even get diagnosed without this testing.
Yeah. Gene Steps has given us so much and given so much to Stella as well.
Thank you.
Thank you.
Professor Peruka.
Chair and members of the committee, thank you for the opportunity to appear today. I'm chair of the Epilepsy and Other Neurological Disorders Alliance, simply known as ENDA. I'm also president of the Epilepsy Society of Australia and the director of the Comprehensive Epilepsy Program at the Austin Hospital in Melbourne. ENDA welcomes this inquiry and the attention it is bringing to the experiences of Australians living with epilepsy. The need for coordinated national action is clear. The key message I would like the committee to take away today is that the international framework for action already exists through the WHO's Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders, known as IGAP. Recognizing the need for a coordinated national response, ENDA was established in 2025 to advance implementation of IGAP in Australia by providing a national collaborative mechanism for epilepsy reform. ENDA was deliberately designed to bring together the diverse leadership, expertise, and lived experience needed to drive national progress and improve outcomes for Australians living with epilepsy. ENDA is unique because it is the only fully inclusive national epilepsy alliance in Australia. We bring together clinical experts, researchers, professional bodies, epilepsy service organizations, and critically, people with lived experience of epilepsy. Consumer representatives are not simply consulted, they are embedded within our governance structure and help shape our priorities and decisions. The evidence before this inquiry reflects what clinicians, researchers, consumers, and support organizations have long observed. Too many Australians experience fragmented care, delays in diagnosis and treatment, unequal access to specialist services, workforce shortages, and persistent stigma. These challenges are felt most acutely by people living in regional, rural, and remote communities. Importantly, these problems are not the result of a lack of commitment by individuals or organizations. Rather, they reflect the absence of a coordinated national approach. This is why ENDA's primary recommendation is that the Australian government adopt the WHO IGAP framework as the foundation for a national epilepsy strategy and formally recognize and support ENDA as the collaborative national coordinated mechanism to assist with its implementation. As an example of the practical work that could support this national approach, Epilepsy Action Australia has submitted a funding application on behalf of ENDA to support the development of Australia's first nationally endorsed epilepsy optimal care pathway and a national epilepsy workforce planning framework. In short, the opportunity before us is clear. The international framework already exists through IGAP. In Australia, ENDA provides an established and inclusive mechanism for national coordination. We encourage the committee to use this inquiry to recommend a coordinated national response that improves outcomes for all Australians living with epilepsy. Thank you. I look forward to your response.
Thank you. Senator Askew.
Thank you, and thank you very much for all of you for being here today, especially little Stella. How old is Stella?
She's almost 3.
Almost 3. Yeah. I've got one of those. It's obviously been beneficial for Stella's diagnosis to have the genetic testing. Can you go through with us how that actually came about? Was it an automatic process within the hospital system, or was it something, were you in part of a trial? I just wanted to get an understanding of that.
So we were transferred from another hospital to RCH, and I suppose they were able to see on the ward which child was having infantile spasms. And so the genetic counsellor, Sarah Mulhern, she came up and saw us and asked if we would be interested in enrolling Stella into the study, which absolutely, we jumped at that. And yeah, it was a bit of a blur in that I didn't really completely understand what was happening, but now, in hindsight, we can see how vital it was for Stella and for our family as well.
Professor, how would you like to explain to us how that then processed from there, just to give us that bigger picture?
Yeah, sure. So the Gene Steps study, which is how Stella got her genetic testing, is just run out of the MCRI in the hospital in Australia. There are 3 international sites as well. So you need to be a baby with seizures who's presenting here. So at the moment, other hospitals and other states in Australia don't have the same routine access that we do through the research. So a child presents here and then is identified by the neurology team usually as being potentially eligible, and then families are seen by a genetic counsellor to talk through whether they would like to proceed with testing. The testing is run through the Victorian Clinical Genetics Service as a clinical test, but research funded. So in 3 weeks' time, the families get a clinical report and the results returned to them by their treating neurologist with the genetic counsellor who's met them before. And then, whichever, I guess, treatment or management changes that might be informed by the genetic diagnosis, we can then start to implement them. Some of those are things that we can implement straight away. Some are things that are sort of a bit iterative over time. As you can imagine, there's a lot in hearing the diagnosis. Yep.
Okay, so the cost to that would have all been covered as part of the trial, or the...
Yep, so currently it's research funded. When it hopefully becomes clinically funded, it would need to be funded by the government in some form, but there currently isn't a pathway that fits. I think, as you know, we had an MSAC submission that was knocked back, so we would like to see there be an avenue for this, because right now we've got inequity around the country in terms of what people can access, and the pathway to get a genetic diagnosis, and sometimes even any genetic testing, is very slow.
Very good.
Senator Askew, can I
Yeah, go for it.
When is the study due to wrap up?
So we have about another 12 months worth of funding, and so beyond that time we don't have a way to fund genetic testing, and unfortunately, as you probably know, an MSAC application, if it were to go through that pathway, sort of takes in excess of 18 months. So we are looking at having, even in the sort of best circumstances, there is looking like there will be a gap. So it's really very important that we do get access to another pathway.
And what are the key outcomes that you're looking at in this study?
Yep, so we're looking at, initially we were looking at feasibility because this is the first time we've taken rapid testing outside of the ICU. We were looking at the diagnostic yield. We know genome sequencing makes a diagnosis in a significantly higher proportion. So we've shown that. We've shown short-term clinical utility, so just about everyone who gets a diagnosis, it's impactful in some way. For over half of those, it changes your treatment. And we're now have a large enough cohort, we've got over 600 people across the 4 sites, that we're able to look on a bigger scale at what that means over time for both clinical outcomes and also economic outcomes in terms of health system use. But we already know that purely at the test level, it's approximately cost equivalent to do rapid genome sequencing when you do economic modelling, comparing it against the current standard of care. And so we, I think we have a lot of evidence that it's clinically beneficial and cost beneficial. And so I don't think we need that longer term evidence to actually say we should be doing this, and families universally tell us they are, it was very useful to them.
Thank you. I just also noticed in your recommendations that you're wanting the government to expedite approval of a Medicare item number. So can you explain a bit more on that one for us and what the benefits would be if that was done?
Yep. So essentially what we would like is for all Australians, infants with epilepsy and people of any age with a DEE to be able to access rapid testing, because having a diagnosis is so impactful, frequently changes outcomes, and increasingly we're looking at things like access to genetic therapies was going to become an increasing reality. And in order to do that, we need a government-funded pathway. And the ideal approach would be a national approach, so that we don't have to approach all of the different states and territories, which is what's happened with the intensive care acute genomic testing. The MSAC Medicare approach is currently the best option. It's not 100% fit for purpose, but it is the only option and actually the best option. About half of children in our study were seen in the outpatient setting. About half were inpatients and half were outpatients when they had the test ordered. And the majority of those that were inpatients their initial hospital stay wasn't particularly long, so they could have been seen in a Medicare-funded clinic in a reasonably prompt time frame. It's a bit clunky and it would be ideal not to do that. But currently, from a point of view of equitably providing a test for everyone around the country, that would actually work for most people.
So it would be a good solution if we could recommend that. Okay, I just have one quick question, because I'm going to get into trouble with time soon for Enda. Just on the IGAP, can you explain a little bit more to us what that looks like, how long it's been in existence, and why Enda, you believe Enda is the correct group to actually administer that or to monitor that?
Oh, thank you. I'll just frame a little bit of history here. So the 73rd World Assembly in 2020 resolved that a plan had to be implemented to tackle the challenges, the gaps which people with epilepsy and other neurological disorders are facing, and ensuring that there is a coordinated, comprehensive response across sectors. Ultimately, this plan was developed and approved by the WHO Executive Committee in 2022. And in May 2022, then all the WHO member states, including Australia, and I'm very proud of this, endorsed the plan. That was in 2022, and the window for the successful implementation and really witnessing those outcomes spans to 2031. So ENDA was formed with the goal of bringing together the sector. And this means the Epilepsy Society of Australia, which is the Australian body of healthcare professionals and researchers, epilepsy service organizations and consumers are at the very center of this, bringing them together to facilitate the implementation of IGAP in our country. And so I think we're making very important strides across many of the gaps that I think we have really witnessed from the beginning of the Senate inquiry into epilepsy.
And what countries globally have actually adopted it, and how's it going internationally?
Yeah, it's look, I've the privilege to serve also for the International League Against Epilepsy, ILA, and I'm pleased actually to share that many countries have really adopted the IGAP, especially in the Asian Oceania region, as a benchmark to implement a national epilepsy strategy. And we had a town hall meeting just 2 weeks ago, and my dear colleague Bernadette Zappa was on it as well. And ENDA was actually consistently brought up as a beautiful example of how this sector can collaborate, because it's about a collaboration. We recognize the strengths across the sector. There are some outstanding individuals, outstanding organizations in our country. And so it's a matter of coming together and really working towards a shared common goal, which hopefully will be successful.
All right, thanks, Chair. I'll hand back for time.
Just one question from me. Are there any countries that have fully rolled out IGAP?
They are in the process. I mean, we're talking about the global stage, and there are ongoing initiatives. We had a meeting in September of last year as part of the International Epilepsy Congress. Different countries share their experience. It's a pathway to implementing this. And there were some very, very powerful examples in Europe. In Spain, they've implemented a plan with a roadmap to actually implement IGAP. Australia has shared their experience. And after we actually presented the ENDA framework, we have received inquiries from different countries, I name a few, many in South America, such as Argentina, to share our experience, to share our framework, and how actually we can work together in achieving this goal. Because one of the challenges in most countries is actually working together. And again, I think there is a common denominator in that many countries have outstanding individuals and organizations, but it's sitting at the same table and putting those heads together so this can be implemented.
What do you see are the barriers to being able to roll this out here in Australia right now?
I think if I be fully blunt, it's important that the Australian government puts into action its verbal support of IGAP. As I mentioned earlier, it is fantastic that the Australian government has endorsed this WHO plan, but how we translate that into tangible actions and plans, it's obviously the next step. And this is why we want to work together, and we want to really work together with government to facilitate that mission.
So is it the case at the moment that the community orgs and the medical professionals who are working in this space are all collaborating, but the government needs to come to the table? Is that essentially what
that's correct? And so in a way, IGAP provides the benchmark for making that change, and ENDA is that mechanism to make the change. But obviously, we can't do it together without the support of government. And again, ENDA is specifically formed to facilitate the implementation of IGAP, recognizing the strengths of the various individuals.
Yep, thank you. Senator Nandaraja.
Thanks, Chair. Dr. Powell, with regards to your MSAC proposal, are you able to share that with the committee?
Yes, I can. Yes, I can provide that on notice.
That would be great, because I suspect it will have a lot more detail than me just asking lots of questions. So
sure.
That would be terrific. I just want to talk to you a little bit about specialist training again. I was in Adelaide recently for conference, and was approached by some epilepsy stakeholders there who informed me that there are neurologists from Adelaide who are visiting the Alfred to be trained up, which made me ask all kinds of other questions as to why this is happening. So I'm interested to know what your thoughts are, again, on, and feel free to just talk about this issue of workforce capability. It's very niche. This is a niche field, even within the profession. How do we scale up and then deploy?
I wonder, Piera, do you want to share your thoughts first? Because the adult side of things is quite a bit bigger than paediatrics.
I think, thank you for this question. Obviously, I also have a hat as president of the Epilepsy Society of Australia. I'm really passionate about equitable access to care. South Australia is an example of some of the issues that we're facing. It takes 3 years from a new referral to see an epilepsy specialist. This is frankly unacceptable.
Yep.
The Royal Adelaide Hospital actually had a video EEG monitoring unit with 1 bed. This was closed at the time of COVID and is yet to be reopened. And those are tremendous barriers, I think, for providing what is really minimum standards of care for people living with epilepsy. And so I think, going back to your question, the fact that some of the next generation of clinicians are moving from South Australia to Victoria and train in some of the Victorian hospital is with the goal, is with the hope of getting the training and bringing it back to South Australia, and giving and fueling that push towards actually addressing those very gaps in medical care.
Is it conceivable that right now there is not enough capability, specialist capability in some states, and we can't wait, given the clinical need in the community, for specialists to be made? It takes years, right? We all know that. So is there a role for the committee to consider recommendations that can actually use a more national coordinated approach, where capability from one states that have more capability, we fund that capability to be put towards training and upskilling registrars or specialist neurologists in other states, because frankly we can't wait for specialists to just rise organically through the ranks.
Yes, I think there's a multi-layered answer to that. It's obviously a complicated question. I mean, I would say, simply put, the answer would be yes, that would be a doable thing, whether temporarily or ongoing. I mean, we now have far greater access to telehealth services, for example, so that absolutely would be doable. I think the question is going to be about sustainability and what's the ongoing best practice and best care, because, for example, things like having access to video EEG monitoring, that kind of thing has to be done in person, so you need the facilities there. And then, and once you've trained people up, there need to be jobs. We do have people trained up here in Victoria for whom there is then no work in the public health system. For children with epilepsy, the main source of care, particularly if you've got a more severe epilepsy, is within the public hospital system. But we train people and then we can't employ them, which is really problematic. I think the other thing that we need to consider is who is capable of seeing people with epilepsy, and that will differ across paediatric and adult sectors. But if we think about what we do versus what some other countries do in terms of looking after children, the majority of children with epilepsy, people want to or try to get in to see a neurologist, and I think there is an increasing trend to de-skilling of paediatricians and also reducing confidence by paediatricians, but also confidence of families in paediatricians. And that's not necessarily the case around the world. And there are mechanisms that other countries have used, including some really good training strategies and links with between neurologists and paediatricians to try and bridge that. And that kind of thing where we've got a greater workforce might actually help there. I don't know.
Could we have on notice some information about that kind of capability strengthening?
Mm-hmm. Yep, absolutely.
Thank you, Catherine. May I just add also, we want to see South Australia, for example, flourish. And so additional funding, I think, for the public health system would create perhaps job openings for some of that new talent being trained now in Victoria and see it go back to South Australia. There are also outstanding colleagues, such as the president of ANZAN, of the Australian and New Zealand Association of Neurologists, who work in private, and private practices only captures one side of epilepsy. Unfortunately, people with epilepsy are often face social challenges which prevent them from accessing private care. Yeah. And so I think funding of the public healthcare system, including that in South Australia, would I think facilitate seeing some of that new generation of clinicians actually move to what is a beautiful state.
So we don't. Commonwealth doesn't control outpatients, but it sounds like there needs to be some outpatient reform in the public sector across the country, to be honest.
Yeah.
In this space. Yeah?
100%.
100%.
Okay. Okay. I think that covers most of what I was going to ask, actually. My final question was really around the value of patient registries. Can you? Oh, no. Actually, let's cancel that. Can you just talk to us about SUDEP, please?
Yes. SUDEP is, probably the most devastating thing that, people with epilepsy and their families fear, and is the reality for some. There are so many massive challenges, but this is just a really devastating one. It's common. There are things that we can do to reduce the risk. We don't have the capacity to take the risk away, but there are a lot of things we can do to reduce the risk. And the key one is to get the best seizure control that we can. And then there are various other things around awareness, monitoring, safe sleeping, things like that. But really, there's an enormous gap if we are actually not able to get people on the right on any treatment, let alone the right treatment. You had an example of that just so starkly described before. When we've got waiting lists of years, that is a whole lot of people who are at higher risk than they should be.
So SUDEP is, what is the driver here? Is it why are people dying? Explain the pathophysiology? Yeah.
Yeah, so the biology is incompletely understood, although there is quite a lot of research going on, including in Australia. And a question about whether the driver is the brain, the respiratory system, or the heart, and in which order. And there will be a brain driver, and then different people are at different risk. And that may depend on what the underlying cause of their epilepsy is, what type of seizures they're having. If you're having tonic-clonic convulsive seizures, you're at higher risk. If you're having seizures where you stop breathing, you're at higher risk. So the biology isn't completely known, but what is known are the things that increase or decrease your risk.
Could you sorry, Chair, I think this is important because we don't understand it. Could you just go through those risk factors?
Yeah. So there are a number of them. Having uncontrolled seizures, and particularly uncontrolled tonic-clonic seizures, is probably the greatest risk factor. So getting better seizure control is the best thing that we can do. Things like sleeping alone or sleeping without monitoring. Things like sleeping prone. There are a number of different risk factors that we can mitigate, and it doesn't take away the risk completely, but certainly from the point of view of getting people on treatment, and then awareness and facilitating people's knowledge of how else they can reduce their risk. And a really important thing that is very increasingly sort of understood and known across the epilepsy world and community is that we as neurologists and epileptologists don't always discuss SUDEP with patients, and we should, and patients and families tell us that we should. And where you've got something that's devastating, I think people are reluctant to talk about it for worrying people. But you can, if there's something you can do something about, then we need to be able to empower people and to do that for themselves and their family members.
Okay, so perhaps on notice then, that then brings me to my next question, which was going to be on patient registries, but if we could just get an answer from you on the value of patient registries, that would be great. Thank you. Just on notice.
Yeah.
Thank you.
Oh, that one on notice? Or?
Yeah, I think we're out at time.
Sure.
Yeah.
If you both want to answer,
Why don't
you
you
can answer within 5
You,
minutes.
yeah,
then
you go for it.
Indulgence.
Go for it.
Catherine is a friend, so I'm happy to. But I think registries are very powerful ways to actually study different aspects related to epilepsy. And there are different types of registries. I can share the answer with Catherine, but or Professor Atwell, I should say. But we have some very powerful examples. One is the Australian Pregnancy Register of Anti-Epileptic Drugs. This is a register that was funded in 1999 and captures all pregnant women with epilepsy, or aims to capture pregnant women, Australian women with epilepsy who are pregnant and are taking anti-seizure medications in pregnancy, with the goal of studying the outcomes of pregnant women who are taking medications and the risks associated with taking different medications during pregnancy. This is a register, as I said, that was funded almost 3 decades ago and has never really received dedicated funding from government and has survived somehow the last 3 decades, generating data which have changed practices in the prescribing different medications for epilepsy to women of childbearing age. For example, it has demonstrated that taking valproate in pregnancy is associated with an increased risk of birth defects. And this has led to a reduction in the prescription of valproate in Australian women with epilepsy, and an increase in the prescription of other safer medications. This is a register that, as I said, has been not really funded by government, and we don't know how long it will survive this way. It has survived 3 decades, but we shouldn't assume that it will continue to survive. So this is an example, powerful example of how registers can make a difference, change practice, inform the way we counsel our patients, and yet we try to find alternative sources of funding to keep it going. But I think the only way for it to continue, for them to continue and generate really high quality data, is to get the support from government.
Yep, I would strongly agree with that, and especially because practice continues to evolve, new treatments come through, the kind of effects and impacts of treatments of medium to long term and intergenerational, it's going to take time to know, so that would be a really important investment. And I think the same thing goes for other types of registries. A DE registry was mentioned before by the DE Roundtable group, and that would be hugely impactful in that context. And I think for epilepsy more broadly, there are so many unknowns, so many unanswered questions, whether we're talking about understanding a condition itself, measuring its outcomes, looking at how our health system is set up and what, whether we're meeting goals or not, and what would be the best, most efficient and best bang for buck ways to approach that. Having those data would be critical.
Thank you. Thanks, Chair.
Can I say thank you very much for appearing before the committee this afternoon and for your submissions, and thank you Melanie and Saxon and Stella for coming and advocating on behalf of other families so that they can have access to the same treatments that you've had the luck to be the benefits of. The committee will report to the Senate on the 10th of September 2026. We've agreed that responses to questions on notice should be provided by close of business on Monday the 17th of August 2026. After we adjourn, I note that the committee is going to go straight from here to a site visit to the Murdoch Children's Research Institute, which we're very much looking forward to. So that concludes today's hearing. Thank you to all witnesses who appeared and to Hansard and Broadcasting for their assistance, and thank you to the Secretariat. The committee will report to the Senate on the 10th of September 2026 and has agreed that responses to questions on notice should be provided by close of business on Monday 17 August 2026, and the committee stands adjourned. Thank you.